அனைவருக்கும் இனிய காலை வணக்கங்கள். கட்டிடக் கலைச்சான்று ராஜராஜேஸ்வரம், கங்கை வெற்றியின் சின்னம் சோழபுரம், சிற்பிகளின் கனவு தாராசுரம், அழியா சோழப் பெருங்கோயில்கள், அகிலம் போற்றும் நம் மரபு சின்னங்கள். டிபிஹெச் மரபில் மற்றுமொரு அழியா சின்னமாய் தஞ்சையில் டிபிஹெச் ஐகான் 2024. பருதி புலரும் புதிய காலையில் டிபிஹெச் ஐகான் 2024 மூன்றாவது வருடாந்திர சர்வதேச பொது சுகாதார மாநாட்டின் முதல் நாள் அமர்வுகளுக்கு தங்களை அன்புடன் வரவேற்கின்றோம். முதலாவதாக மாநாட்டு தொடக்க கருத்துக்களை வழங்க அன்பிற்கினிய பொது சுகாதாரம் மற்றும் நோய் தடுப்பு மருந்து துறையின் இயக்குனர் மருத்துவர் TS செல்வ விநாயகம் அவர்களை அன்புடன் அழைக்கின்றோம்.
So good morning, respected additional directors, joint directors, DHOs and all the officials from all the districts and our ADME and experts from NHRC, UNICEF, Government of India and all the officials and also the officials from the municipal corporation. உங்கள் எல்லாருக்கும் முதற்கண் நன்றி கலந்த வணக்கம். இன்றைக்கி நம்ம எதிர்பார்த்த மாதிரியே நீங்கள் எல்லாமே ஆஸ் யூஷுவல் டீமாக இருக்கீங்க. ஐ குட் சி சம் ஆஃப் அவர் VHN, சம் ஆஃப் அவர் ஹெல்த் இன்ஸ்பெக்டர்ஸ், மெடிக்கல் ஆஃபீஸர்ஸ், DHOs எல்லாமே வந்திருக்கீங்க. நம்மளோட மீண்டும் நம்ம வரும்போது இப்போ நான் அந்த கவர்மெண்ட் ஆஃப் இந்தியா அஃபிஷியல் ரீஜனல் டைரக்டர் வந்து அவரோட பேசிகிட்டு இருந்தேன். பப்ளிக் ஹெல்த்தை பொறுத்த வரைக்கும் இட் இஸ் த டீம். ஹவு யூ ஆர் கொகேசிவ்லி ஒர்க்கிங் வித் ஈச் அதர் தான் நம்மளோட சக்ஸஸ். இந்த எஜுகேஷன், மெடிக்கல் எஜுகேஷன் பார்த்தீங்கன்னா நம்மளை பொறுத்த வரைக்கும் இந்த ஒரு பர்டிகுலர் டீச்சர், இந்த ஒரு பர்டிகுலர் எக்ஸ்பர்ட் அப்படின்னு இருப்பாங்க. பட் பப்ளிக் ஹெல்த்தில் பொறுத்த வரைக்கும் நம்ம எவ்வளோ பெரிய டீமாக இருந்தாலும் ஹவு வி ஆர் ஒர்க்கிங் டுகெதர், தட் இஸ் மோஸ்ட் இம்பார்ட்டன்ட். இன்ஃபேக்ட் தட் இஸ் த ரீசன் ஃபார் அவர் சக்ஸஸ். இது நம்ம பில்டப் பண்ணுறது தான் நம்மளோட கோல். இந்த செஷனில் வந்து தோ இட் வாஸ் கிவன் ஃபார் half an hour, I will not take half an hour. I'm just trying to share my experience in working this department for 30 years and also as a director for more than 5 years now. How we can take our department to the next level. We call it way forward or vision, whatever way you want. நமக்கு நிறைய விஷயங்கள் இருக்குது பண்ணுறதுக்கு, but we cannot do everything at one time. So we need to focus on certain areas where we'll have a better results or we can get the results which are more critical. இந்த மாதிரி கொஞ்சம் ஃபோக்கஸ்டாக போனால் மட்டும்தான் we can do many things. அதர்வைஸ் நான் எல்லாத்தையும் பண்ணிகிட்டே இருந்தோம்னா even after working for 24 hours, at the end of it you will not see the results. Now you need to have a focus where you will have a better impact which we can create. அது எதில் பண்ணலாம் அப்படின்றது ஒரு 2-3 areas I just thought I can do it. ஒன்று வந்து now we need to think the difference between the primary care and the public health. பிரைமரி கேரும் பப்ளிக் ஹெல்த்தும் வித்தியாசப்பட்டதா, ரெண்டும் ஒன்றும் கிடையாது. நவ் வி ஆர் திங்கிங் தட் வாட் அண்ட் ஆல் சர்வீஸ் விச் வி ப்ரொவைட் இன் எ PHC இஸ் அவர் என்டையர் பப்ளிக் ஹெல்த். நோ. வி நீட் டு கோ பியாண்ட் த இன்ஸ்டிடியூஷன். வி நீட் டு ரீச் த சிட்டிசன்ஸ். யாராவது ரொம்ப கதை பேசுகிற மாதிரி இருந்தால் வெளியே போய் பேசலாம். வி நீட் டு கோ பியாண்ட் த இன்ஸ்டிடியூஷன். வி நீட் டு கோ டு த சிட்டிசன். நம்மளோட ஸ்ட்ரென்த்தே என்னன்னு பார்த்தீங்கன்னா நம்ம எவ்வளோ க்ளோஸாக கம்யூனிட்டியில் இருக்கோம் அப்படிங்கிறது தான் நம்மளோட ஸ்ட்ரென்த்து. அதுக்காக தான் அந்த காலத்தில் ஃபீல்டு ஸ்டாப் பண்ணும்போது உங்களோட VHNோ உங்களோட ஹெல்த் இன்ஸ்பெக்டரும் இந்த ரூட்டில் இருந்தாங்க. ஒரு விஷயம் போனோம், ஒரு ஹெல்த் எஜுகேஷன் போனோம், ஒரு விஷயம் நடக்கணும்னா we have a people at the top root most village or a ward, அந்த லெவல் இருந்தது. அந்த ஸ்ட்ரக்சரை நம்ம உடைச்சோம்னா which will not survive. the PHC care is a institutional care. இது மட்டும் கொடுத்தோம்னா ஒரு பீரியடில் வில் பி திங்கிங் தட் வி ஆர் ஏ ஸ்மாலர் யூனிட் ஆஃப் ஏ மெடிக்கல் காலேஜ். இதுதான் நடக்கும். மெடிக்கல் காலேஜில் எல்லா ஸ்பெஷலிஸ்டும் எல்லா கேரும் கொடுக்குறாங்க, அதை PHல கம்ப்ரைஸ் பண்ணி ஒரு டாக்டர் ஒரு நர்ஸை வச்சு சின்னதாக கொடுப்பாங்க அப்படின்வாங்க. தட் இஸ் நாட் த பப்ளிக் ஹெல்த். பப்ளிக் ஹெல்த் இஸ் பியாண்ட் த இன்ஸ்டிடியூஷன். வி நீட் டு கோ டு த கம்யூனிட்டி, live with the community. In fact, our role is how to prevent the emergence of health risk factors. How to control it. இதுதான் நம்மளோட கோலாக இருக்கணும். அதை ஃபோக்கஸ் பண்ணோம்னா there will be no competition. We are the only person who reach in the community. அதுக்கப்புறம் நீ எவ்வளோ பெரிய இன்ஸ்டியூஷன் tertiary care institution பண்ணாலும் you can reach only through us. You can reach the citizen only through us. So இந்த மைண்ட் செட்டை வச்சுக்கோங்க. The small service delivered the PHC care is nothing. We need to go bigger. The Public Health Act is the one biggest tool which you have. No other department has got that legal capacity to enforce what they want. So நம்மகிட்ட மட்டும்தான் இருக்கு, which we need to use it. This is one. Second concept which I want to know is that most of the time it is donor driven. See, donor driven, don't assume that it is only the funder who are going to do it. ஒரு period, see, this is a scientific forum, we should take it in the right sense. See, the NHM will decide what the public health should do. So just because they are funding, we should not be dictated on what is needed. In fact, we should plan that this is the demand, this is the requirement of the community person, and this should translate, that should get funded. See, இதுக்கு பண்றதுக்கு ஒரே வழி என்னன்னா, we should know what is the real demand of the public. See, unless and otherwise we create a demand, it's a demand generation. See, unless otherwise we create this demand generation, people may not understand what is exactly needed. See, avanga they'll become biased, the funders they'll become biased, and they will always have a limited resources. And the limited resources la, whatever their understanding about their medical care or public health, they'll start investing. But it may not be the real need of the community. If you want to give the real need of the community a focus, you should start generating the demand for the right services. இது நம்மளால தான் பண்ண முடியும். See, if it's going, non-communicability is going to be a big problem. We should know what are the factors which will determine the reduction in it. See, otherwise it will become tertiary care, it will be drug-driven company or a market-driven company. That is not the goal. This is one which should do it. And the same demand generation now, thanks Rahul, same demand generation now, we have one more way. As I said, the finance is shrinking. In fact, Rahul has come exactly in time with the World Bank team who represents. The finance is shrinking. Over a period of time, you will not have a money for your expectation. Even after demand generation, the fund is limited. We should know where to focus. And in fact, this is the time we should start talking about self-sustaining models in delivering the care. See, இது வந்து இப்போதைக்கு உங்களுக்கு ஒண்ணா it should be beyond your imagination நினைக்கலாம். But unless and otherwise you do this, we will have a limited fund and support. See, particularly இப்போ நிறைய பேருக்கு தெரியும், the first நமக்கு வர resources கை வைக்கிறது வந்து training. But training, everyone feels it's the smallest need, no need to invest on it. But in the training, capacity building, if it is not given again and again, your system will collapse. See, there is no knowledge in the system. Fresha varavanga, they come in a different knowledge, but field practice is something different which they need to learn on day-to-day basis. So, analada, you need to have, see, definitely public financing, the number wise may increase, but if you call it as a percentage wise, it's going to decrease. So, with the limited finance, let us know where we are going to focus our attention. So, this is our second goal. Third, the bigger area which we need to focus is your surveillance. The surveillance is going to be the big game changer in the days to come. When the global has become a small village, where the travel has become just like that, we can reach any part of the globe within 2-3 hours, unless and otherwise you do a surveillance, not only COVID, many infections are going to come just like that. So, இதுக்கு ஒரே வழி சர்விலன்ஸ்னா, இன்ஃபேக்ட் திஸ் த அனதர் பிக்கஸ்ட் டூல் விச் யூ ஹேவ். நம்ம இப்போ நினைக்கிறோம், ஏதோ ஹெல்த் இன்ஸ்பெக்டர் போனார்னா ஒரு ஃபீவர் கேஸை நோட்டிஃபை பண்ணிட்டு வர்றார், இதான் சர்விலன்ஸ் நினைக்கிறோம். ஸோ வி கேன் டூ சர்விலன்ஸ் ஃபார் எனிதிங், இன்க்ளூடிங் ஆஸ்டியோபோரோசிஸ், கேன்சர், எதுக்கு ஒன்றா பண்ணலாம். பட் நம்மளோட இமேஜினேஷன் ஸ்டில் ஸ்டாப்ஸ் வித் யுவர் இன்ஃபெக்ஷியஸ் டிசீசஸ். மிஞ்சி போனால் ஏதாவது ஒரு இன்ஸ்ட்ரக்ஷன் கொடுத்தாங்கன்னா எம்பாக்ஸுக்கு பார்ப்போம், நிப்பாக்கு பார்ப்போம்னு சொல்லிட்டு வி ஆர் ஸ்டாப்பிங் இட். சி, த சர்விலன்ஸ் இஸ் பிக். In fact, if you see the IHIP portal itself, it's so vast, it covers anything. See, நம்மளோடது என்னன்னா, any event தான் சொல்கிறோம், any infectious disease definition கிடையாது. Any event which of public importance, we should start monitoring. It could be anything. Tobacco utilization நீங்கள் மானிட்டர் பண்ணலாம், வாட்டர் குவாலிட்டியும் மானிட்டர் பண்ணலாம், environmental air pollution மானிட்டர் பண்ணலாம். See, ultimately, whatever you feel affects your public health, you have a role. இது பண்ணோம்னா என்ன ஆகும்னா, our capacity, நான் ஏதோ பிஹெச்சியோட பாஸ் நினச்சிக்காம, you will start thinking beyond your limitations and start focusing on the community. இது நீ பண்ணிட்ட பிறகு நீங்கள் ப்ரைவேட்டையும் கண்ட்ரோல் கொண்டு வரலாம், மெடிக்கல் எஜுகேஷன், ஜிஹெச் எல்லாரையும் கொண்டு வரலாம். இப்போ நம்ம ரிப்போர்ட்டிங்காகவே நம்ம போய் ரிக்வஸ்ட் பண்ணிட்டு இருக்கோம். பட் ஒன்ஸ் யூ மேக் பீப்புள் டு அண்டர்ஸ்டாண்ட் த இம்பார்ட்டன்ஸ் ஆஃப் சர்வீலன்ஸ், திங்ஸ் வில் ஹேப்பன். அகெயின் இதெல்லாம் பண்ணணும்னா, I will talk about two things. What is public health and primary care difference? How the policy can be decided by financing and donors and surveillance. இது மூணு தான் core area. If we want to do it, there are few things which we should have. See, one is your infrastructure. See, unless and otherwise you have a place to sit, it will be very difficult. See, நான் நேத்திக்கே அமைச்சர் இருக்கும்போது I was focusing on it. Though I have around 11,000 more institutions, more than 2,000 institutions are still in a rented and rent-free building. Another 2,000 institution, I already obtained a condemned certificate. I don't have money to replace. Another 2,000 institution badly in need of a monitoring into your minor repairs and maintenance. இந்த மாதிரி இருக்கும்போது, see, the people who are working in those institutions will not have that capacity or urge to work further. So இந்த infrastructure create பண்ணோம். See, the infrastructure, yes, இது எல்லாத்துக்கும் ஒரு 1,000 crore வேணும்னா, the 1,000 crore we are ready to invest in a showpiece, a bigger piece, which will have a public attention. But dispersing these throws across the PHC, across the state, will not have an impact. பெருசா வெளியே தெரியாது. See, அந்த மார்க்கெட் விசிபிலிட்டிலாம் may not be there if you are investing in a primary care. But இது பண்ணா மட்டும்தான் the real health of the public will be taken care. See, we should not blame some officials or politicians for this. See, it is our failure to make those people understand the value of it. சார், இது பண்ணா மட்டும்தான் உங்களுக்கு ரீச் இருக்கும், இது பண்ணா மட்டும்தான் பப்ளிக்கு தேவையான சர்வீஸ் போகும் அப்படின்னு சொல்லாதும் போது, as I said earlier, from their understanding, their vision, they will try to build a bigger institution and they'll go away. But this is the role which we need to take forward instead of blaming some X or Y for this responsibility. It is our duty. We fail to create this demand, which we'll do it. Second is your HR. As I said earlier, public health is the team. நமக்கு இன்றைக்கி வேக்கன்சி தான் ஒரு பெரிய விஷயம். நேற்றுக்கு மினிஸ்டர் இருக்கும்போதும் பேசிகிட்டு இருந்தோம் அதை பற்றி. சரி, இன்றைக்கி நம்மளோட வெல்கம் சார், வெல்கம் பஸ், மோர் தென் 2253 விஹெச்என் போஸ்ட்டு இன்றைக்கி வேக்கண்ட்டாக இருக்குது. நம்மளோட கிரவுண்ட் ஸ்டாஃப், சரி, நம்மளோட சகோதரிகள் தான் ஒரு ஏரியாவை பார்க்குறவங்க 2 ஏரியா 3 ஏரியா சேர்த்து பார்த்துட்ருக்காங்க. பட் இந்த பாப்புலேஷனில் இருந்தால் மட்டும்தான் நம்ம எல்லா ரிப்போர்ட்டும் கடைசியாக எங்கே போய் கேட்போம், இந்த இடத்துல தான் வேணும்னு கேட்போம். அப்படி இருக்கும்போது அந்த போதுமான அளவுக்கு அவங்களுக்கு பாப்புலேஷன் கொடுத்து கவர் பண்ண சொன்னால் தான் அந்த உண்மையிலே எஃபெக்டிவ்னஸ் இருக்கும். இல்லைன்னா ரொம்ப ப்ரெஷர் பண்ணோம்னா நம்பர் எழுதி கொடுத்துருவாங்க. See, that is not our goal. So this one vacancy. The similar way, either likingly or unlikingly, health inspector cadre வந்து அப்படியே கொஞ்சம் கொஞ்சமாக குறைஞ்சி போயிடுச்சு. See, when I entered the service, it was more than 7,000 plus. Now the sanctioned post itself has become 3,000 and odd. See, பாதிக்கு பாதியாக என் கண்ணெதிர்க்கே குறைஞ்சி போச்சு. See, என்னென்னா, we fail to utilize them properly and we fail to give them a suitable job. இப்போ இது பண்ணல என்ன ஆகும், the cadre நம்பரும் குறையும், வேல்யூவும் குறையும். ஒரு ஸ்டேஜுக்கு அப்புறம் everyone feels that இது என் வேலை இல்லை, இது தேவையே இல்லைங்க அப்படின்னு வந்துடுவாங்க. ஸோ இதுக்கு தான் நான் again and again I used to tell everyone, please work hard, please make your work visible. இது பண்ணலன்னா the same thing may happen even to your district health officers. நான் விளையாட்டாக கூட உங்களை எல்லாரும் திட்டிகிட்டு இருப்பேன். பிகாஸ் ஆஃப் மை ஏஜ் ஐ கேன் ஈவன் ஷவுட் ரைட் நவ். சி, நீ வெறும் 2 மீட்டிங் நடத்திட்டு போஸ்டர் போடுறதா இருந்தால் people will think that DHO is only for doing this and organizing a meeting and fixing a poster that can be done by anyone அப்படிங்கிற மைண்ட் வந்துடும். ஸோ அது வரக்கூடாதுன்னா we need to talk about science, we need to talk about documentation, we need to talk in a scientific way, a professional way. If that is not there, we will be replaceable, easily replaceable. ஸோ அது வரக்கூடாது. See, that is what has unfortunately happened to health inspectors. ஸோ ஒரு ஸ்டேஜில் இது வேண்டாங்க, பரவாயில்லைங்க, அது இல்லைன்னா கூட ஓடும் அப்படிங்கிற டைம் உருவாக்கிட்டாங்க. பட் that should not happen to anyone, including this will revive it over a period of time. So this is your vacancy இருக்குது, maybe because of the court cases. In fact, I told minister also, ஹெல்த் இன்ஸ்பெக்டரில் இன்றைக்கி வந்து ஒரு 34 கேஸ் இருக்குது, விஹெச்எல் அதே மாதிரி ஒரு 20-25 கேஸ் இருக்குது, இன்க்ளூடிங் அட் த கேஸ் ஆஃப் த சுப்ரீம் கோர்ட், விச் வில் ட்ரை டு சால்வ் இட். பட் இதுக்கு மெயின் காரணம் என்னென்னா a misguidance by some of our officials also. See, நம்ம அவங்கள மட்டும் blame பண்ணக்கூடாது. யங்ஸ்டர்ஸ் வந்து they always want some way to get into the government service. பட் நமக்கு ப்ராப்பராக கைட் பண்ணி this is the way to get in, this is the not the way to do it தெரிஞ்சிருந்தால் கரெக்டாக இருந்திருக்கும். That we fail anyway, we'll see how we can take it forward. After infrastructure and your HR, the third area is your logistic management. See, இதெல்லாம் நமக்கு லாங்குவேஜ் ஒன்றா புதுசாக இருக்கலாம். பட் இந்த லாஜிஸ்டிக் மேனேஜ்மெண்ட்டுங்கிறது இட்ஸ் மேஸ்ட்லி அபவுட் யுவர் ட்ரக் மேனேஜ்மெண்ட் அண்ட் யுவர் diagnostic management. These are the two bigger expenditure for the common public. The outer packet expenditure சொல்லுவோம், this is around 60%. The 80% of this outer packet expenditure is because of your drugs and diagnostics. இதை நம்ம டச் பண்ணோம். இதை டச் பண்ணாமல் நம்ம மற்ற வேலையை மட்டும் பண்ணிட்டு இருந்தோம்னா things will not happen. So the fortunate thing which you have done is your drug managementல தான் நம்ம DDMS portal கொண்டு வந்திருக்கோம். In fact, I can give an assurance that it is only in a PHC I can tell you what is the stock of a particular drug at any point of time. No other institution has got that capacity to do it. நம்மளால பண்ண முடியும். ஆனால் இது பண்ணுறதுக்கு இன்னொரு காரணம் என்னென்னா it needs our strong commitment. இந்த நம்பர் தெரியணும்னா you need to update it on a day-to-day basis, on daily basis. In fact, our pharmacists are doing this job exceptionally well. ஒரு ஷார்ட் ட்ரைனிங் தான் கொடுத்தோம், they could able to do it. The similar thing we should do it for the diagnostics. See, diagnostics வந்து நம்மளோடதுல அந்த மிஸ்யூஸ் ஆகிறதும் கொஞ்சம் அதிகமாக தான் இருக்குது. That we need to do it. இதை கொண்டு வந்தோம்னா you will have a proper diagnosis. In fact, now you have your ILS done at a PHC by simply moving the sample. சாம்பிள் மூவ் பண்ணும்போது எல்லாமே பண்ணலாம். இன்ஃபேக்ட் JDCDயோட நான் பேசிகிட்டு இருக்கும்போது I used to tell him, சார் முன்னாடி டிபி எங்கேயோ இருந்தது, நவ் வி ஆர் ஒன் ஸ்டாப்னு உள்ளே கொண்டு வரும்போது யூ நீட் நாட் worry about the availability of a NAT test in a PHC. You need not worry about availability of a digital X-ray in your PHC. We can simply move things. We can take a sample, move it for a NAT. We can mobilize your mobile diagnostic center and bring them for a X-ray. இது எல்லாமே பண்ண முடியும். This is another area which you do. And third and fourth is your monitoring and evaluation. See, நாங்கள் உள்ளே வரும்போது டிடி என்றைக்கா ஒரு நாளைக்கு தான் ஆஃபீஸ் வருவாருன்னு கிண்டலாக சொல்லுவாங்க. ஆனால் அப்போ என்னென்னா அவர் ஃபீல்டில் இருந்தார். காலையில் மத்தியானம் அவுட் பிரேக் எப்போ இருந்தாலும் ஃபீல்டில் இருப்பார். எப்போயாவது முறை வந்து ஆஃபீஸில் ஃபைல் கிளியர் பண்ணிட்டு போவார். இப்போ நம்ம ஆஃபீஸுக்கும் வரமாட்டேங்கிறோம், அப்பப்போ ஃபீல்டுக்கும் போக மாட்டேங்கிறோம். See, in fact, this is your core. நான் நிறைய நாள் உங்கள் ரிக்வஸ்டே என்ன சொல்லுவேன்னா, don't come to office in the morning. ஏதாவது ஒரு 2 ஏரியாவுக்கு போங்க, 2 PHCக்கு போங்க. then only you will understand the ground reality. And PHCங்கிறது என்னோட ஐடியா என்னென்னா, not to the PHC as a institution where you go and check up only by attendance. See, you go to the field. உன்னோட MCS கேர் கிடச்சிதா, உன்னோட NCD கேர் கிடச்சிதா, உன்னோட காம்ப்ளிகேஷன் ஸ்க்ரீன் பண்ணாங்களா, this should be your goal. Not going and checking only the attendance. See, இதை நீங்கள் தொடர்ந்து பண்ண ஆரம்பிச்சிங்கன்னா ஆட்டோமேட்டிக்காக every service will fall in line. See, please understand, most of our workers are willing to work. It's only a failure on our part to make them work. See, over 10 to 20% may be a deviance. Let us not worry about the deviance right now. See, 80% of the people are ready to give their service. It's only our effort to make them happen. அதுக்கு ஒரே வழி, just go to them, live with them, work with them, things will happen. This is my monitoring and evaluation aspect. And finally, it's your research and innovation. See, this is the one area which we neglected so far. See, இதுதான் அந்த visibility, இதுதான் அந்த documentation. If you fail to do it, ஒரு 10 வருஷம் கழிச்சு நீங்கள் ஒன்றா பெருமையாக சொல்லிக்கலாம், நான் அங்கே இதுவாக இருந்தபோது இதெல்லாம் பண்ணினேன் அப்படின்னு சொல்லிட்டு. There will not be any evidence. After you go, nothing will be there to show what you have done. The only thing is your science and innovations done. In fact, உங்களோட இதில் நல்ல retrospective பண்ணி பார்த்தீங்கன்னா, what and all you have done as a small intervention has become a policy. உங்களுக்கு சானிட்டரி நாப்கின் கொடுத்ததா இருந்தாலும், நியூட்ரிஷனல் கிட் கொடுத்ததா இருந்தாலும், மதர் அண்ட் பேபி கொடுத்ததாலும், இட்ஸ் ஆல் ஸ்டார்டட் as a small intervention in some place. Once people know the value of it, it has become a policy. See, நமக்கு மட்டும்தான் அந்த கெப்பாசிட்டி இருக்குது. See, other people, it's only a theoretical knowledge. But since we live with the community, we know what is the requirement. அழகாக இதை நீங்கள் இனோவேஷனாக கன்வெர்ட் பண்ணுங்கள், ரிசர்ச்சாக டாக்குமெண்ட் பண்ணுங்கள், அண்ட் ஆட்டோமேட்டிக்லி இட் பிகம் பாலிசி. அட்லீஸ்ட் யூ வில் ஹேவ் a satisfaction that what you visualize has become a reality. இது பண்ணலாம். So these are the few things which you do it. In fact, now we created an environment for it, make it happen. நீங்கள் ரிசர்ச் பண்ணனா உனக்கு எத்திக்கல் கமிட்டி இருக்குது, ஜேர்னல் இருக்குது, எவ்ரிதிங் அட் அவர் டிஸ்போசல் ரைட் நவ். அட்லீஸ்ட் இந்த ஆப்பர்ச்சுனிட்டியை I don't want, see this may be a little bit of selfish interest also. See, document your efforts. That is more than enough. நீ பெருசாலாம் செய்யலைன்னா கூட இதை பண்ண ஆரம்பிச்சிங்கனாவே other things will follow in line. So this is the area which I said now. Now I will go to few more programs which are very critical. Time இருக்குல்ல? Few more programs which are very critical which you need to focus. இது நான் சொல்றது என்னன்னா, we have done a maximum in this. But these are the few things which we need to do in further. So one is your MCH. Very good. MMR has come down. We are far better. We are in the top 3. Now it is 44. We expect to go further. Nalla irukku. But this is the time our high risk is become different. See, முன்னாடி HOB-யும் teenage mothers தான் உங்களோட பெரிய high risk. See, இப்போ வர high risk, it's going to be your obese, elderly, a precious mother who has underwent an IVF and coming to you for a delivery. See, and the high risk and the high risk are totally different. You need to have a totally a different mindset, different way of working on it. So how we are going to adapt for it? This is one area which you need to focus. Second is your preconception care. Or I even call it last meeting and சொல்லும்போது it's a passport to your pregnancy. See, unless இப்போ நம்ம குழந்தைங்களுக்கு என்ன சொல்கிறோம், அடல்ட்ஸுக்கு you should prepare them mentally, physically, socially to get into adult into your social life. அதே தான் for your maternal care. See, unless and otherwise you prepare this child properly, unless otherwise, see for example, anemia control-ஆ இருக்கா, obesity control-ஆ இருக்கா, risk control இருக்கா, இதெல்லாம் பார்த்துட்டு if that child has become, or that mother has become a pregnant woman, managing them is comparatively easier. But if you are not prepared this child for the pregnancy and delivery, it's going to be a risk. So how we are going to do a preconception care? So this is where we are moving. Veru antenatal care lab, we are moving little beyond for your preconception care. Third is the area which we commonly called as what is known as your usually அது பெரிய நேம்ல வரும் 3Bன்னு சொல்லுவோம், birth, before and beyond. So இதில் we'll try to bring everything together, birth, before and beyond. This is a concept going on in most of the world. Another area which we can immediately start is that, in fact Nirmal has already started, is that how we can decide the place of birth. See, இது வந்து ஒரு சின்ன விஷயமா தான் இருக்கலாம். இப்போ நம்ம என்ன பண்ணுறோம், place of birthனா மொனாட்டனஸாக அந்த ஆன்டினேட்டல் பீரியடில் PHCன்னு போட்டு விட்டுறோம். 90% people want to deliver in PHC. In reality, it is not so. See, it is only 8 to 10% of the deliveries are happening in the PHC. Then, why 90% of the women prepares to do it in a PHC? ஒன்று அந்த உமனுக்கு என்னன்னு தெரியாமல் இருக்கலாம், இல்லை நாம் சரியாக சொல்லி கொடுக்காமல் இருக்கலாம். See, the place of delivery is much critical in every woman's period. See, அந்த ஒரு நார்மலைசேஷன் வரணும், அந்த ஹாஸ்பிட்டல் அட்மாஸ்பியருக்கு அவங்க அடாப்ட் ஆகணும், பழகணும். இதெல்லாம் பண்ணுறதுக்கு ஒரே வழி என்னென்னா, அந்த ஆன்டினேட்டல் பீரியட்லேயே அவங்களுக்கு நம்ம முழுசாக சொல்லி கொடுக்கணும். அது பண்ணுறதுக்கு என்னென்னா, இந்த ஆன்டினேட்டல் ஐரிஸ் பண்ணும்போது see there is a little bit of challenge here also. அவர் ரோல் வந்து பிளேஸ் ஆஃப் டெலிவரி பண்ணுறதுக்கான காரணமே என்னென்னா, we need to understand what is the risk factors in a mother, whether this will match the facility available in a PHC. PHCல இருக்க வசதிகளையும் அந்த மதரோட ரிக்குவயர்மெண்ட்டும் we need to match. See, please understand that what and all our experts in a regional institute with the director of OG with the 20 Fiji surrounding it, the same care, people unnecessarily expect the same care in a PHC where there is only one staff nurse or a VHN or A&M sitting. அவங்க படித்த காலத்தில் என்னென்னலாம் கொடுத்தாங்களோ அதெல்லாம் இந்த ஏஎன்எம் கொடுக்கணும்னு எதிர்பார்க்குறது இட்ஸ் நாட் எ ரியாலிட்டி. பட் அதுக்கு என்ன நினைக்கிறோன்னா, அவங்க சொல்கிறாங்க நீங்கள் தானே இங்கே பிஹெச்சில் டெலிவரி பண்ணுறாங்கன்னு சொல்லிட்டீங்க, அப்புறம் காம்ப்ளிகேஷன் சொல்லிட்டு எனக்கு லேட்டாக ரெஃபர் பண்ணுறீங்க, தட் இஸ் வை த மதர் இஸ் டைங் சொல்லிட்டு இது சிம்பிளி ட்ரை டு ஷிஃப்ட் த பிளேம். பட் அவர் ஐடியா இஸ் தட் லெட் அஸ் கிவ் ஏ proper antenatal care. That is enough. See, நம்மளோட performance comes second. The safety of the mother is first. நம்மளோட ரோல் என்னன்னா ஐடென்டிஃபை ஆல் த high risk possible. மிஞ்சி போனால் ஒரு 40-45 கண்டிஷன்ஸ் தான் ரெஸ்பான்சிபிள் ஃபார் மோர் தென் 90% ஆஃப் யுவர் ப்ராப்ளம்ஸ். இந்த 40-45 இப்போ ஆர் ஏபிள் டு பிக்அப் early and place them in a appropriate place. It need not be PHC. It can be an upgraded PHC or a medical college, CMANG, எங்கன்னா இருக்கட்டும். நம்ம ரோல் வந்து we should guide them properly where it is advisable to get delivered. See, the last minute complication is happening in anything, but at least over 80% you can push it to the center. இதில் என்ன சேலஞ்சுன்னா you will save your mother, definitely. But unfortunately, the PHC performance may come down. Let us not worry. See, நீ PHC பர்ஃபார்மன்ஸும் வேணும், மெட்டர்னல் டெத்தும் வரக்கூடாது அப்படின்னா இட்ஸ் a little tricky. ஏன்னா our facility at a PHC is not to the level of a tertiary care institution. ரியாலிட்டியாக இருக்கணும். See, in this reality, with this facility, this is what can be done. See, MCH கேருங்கிறது டெலிவரி மட்டும் கிடையாது. Let us not monitor your performance only with the delivery. See, if you are able to give a proper care for 9 months, that is also equally valuable. And if you are able to pick up all the high-risk mother and give it, that's also equally valuable. இதை பண்ணம்னாவே போகும். This is one area which we need to focus. Second area which we need to think about is your NCD. Non-communicable disease பொறுத்த வரைக்கும் we have done a wonderful job. No other state has got a list of 1.94 crore diabetic and hypertensive patients in their hand. எங்கேயுமே கிடையாது. இன்ஃபேக்ட் குளோபல் ஆல்சோ திஸ் மெனி நம்பர்ஸ் வில் நாட் பி தேர். ரைட்லி வி ஹவ் கான் டு த லெவல் ஆஃப் காம்ப்ளிகேஷன் ஸ்க்ரீனிங். என்ன காம்ப்ளிகேஷன் ஸ்க்ரீன் பண்ணலாம்? எதர் இட் இஸ் ரெட்டினோபதி ஆர் யுவர் நெஃப்ரோபதி ஆர் CKD, வாட் எவர் இட் இஸ், வி ஸ்டார்டட் டெவலப்பிங் இட். வி ஆர் ஆன் த ரைட் ட்ராக். பட் இதில் இன்னும் 2 சேலஞ்சு விச் ஐ ஆன்டிசிபேட் வி நீட் டு ஃபோக்கஸ் இஸ் தட் we all know we have done 2-3 round of screening entire population பண்ணிட்டோம். But still the gap between the expected number and our program data is little more high. For example, இப்போ recent step surveyல பார்த்தோம்னா your hypertension is 29.6%. நம்மளோட program dataல பார்த்தோம்னா it is around 20. See, in the 10% which is equivalent to 10 lakh, still we are missing. See, 10% தான் இருக்கும். See, this is the numbers which we keep coming down. Step survey 1, step survey 2 and program data போகுது. Whatever the 10-20% gap still which we need to reach, we should do it. நீங்கள் நினைக்கலாம் இது வெறும் 10 லட்சம் தானே, இது private sector தானே, let us not worry. Please understand, those who are missing are the one who are going to land in complication. In fact, this is the poorest of poor who don't have a reach to the system. These are the people left out of the system. It is our duty to reach them. Let us not assume that they are from the high income family who have not come to a PHC. We have reached the community. This 10-20% is critical. The another result which our NIE has done recently highlighted another 2-3 points. Almost 75% of the beneficiaries are taking treatment under MTM, மக்களை தேடி மருத்துவம். இது இட்ஸ் a very big statement. 75% மக்கள் ஹைப்பர் டென்ஷன் டயபெட்டிஸ் வந்து அரசால் முன்னெடுக்கக்கூடிய மக்களை தேடி மருத்துவர்கள் தான் ட்ரீட்மெண்ட் எடுத்துக்கிறாங்க அப்படிங்கிறது இட்ஸ் a big thing. No one could do it. But when you go little beyond, இன்னொரு பாசிட்டிவ் ஃபைண்டிங் வருது. ஆல்மோஸ்ட் 80-85% of these patients visit our institutions. 100 பேரை லைன் லிஸ்ட் வச்சுருக்கோம், 75% ரீச் பண்ணிட்டோம். அவங்களும் நம்ம ஒன்ஸ் இன் 3 monthsக்கு ட்ரீட்மெண்ட் வரும்போது அதுலேயே ஒரு 80-85% ட்ரீட்மெண்ட்டுக்கு வந்துட்டாங்க. ஸோ இன்ஃபேக்ட் த பேஷண்ட், த பெனிஃபிஷரி ஹஸ் டன் இஸ் ஜாப் வெல். பட் வென் இட் கம் டு த நெக்ஸ்ட் லெவல் கண்ட்ரோல்னு வரும்போது தான் இட் இஸ் ஒன்லி த 56% ஆஃப் த பீப்புள் ஆர் அண்டர் கண்ட்ரோல். ஸோ த ரிமைனிங் 44% இஸ் அவுட் ஆஃப் கண்ட்ரோல். ஸோ இப்போ எங்களோட ரோல் நல்லா யோசிச்சு பார்த்தீங்கன்னா, ஸ்க்ரீன் பண்ணுறதுக்கு உங்களோட கோஆப்ரேட் பண்ணாங்க, லைன் லிஸ்ட்டு கொடுத்துட்டாங்க, அட்ரஸ்ஸு பேர் கொடுத்துட்டாங்க, அரசும் வந்து உங்களுக்கு மருந்து மாத்திரை வீட்டுக்கு போய் கொடுக்கறதுக்கான எல்லா வசதிகளும் கொடுத்துட்டாங்க. பேஷண்ட்டும் ஒன்ஸ் இன் 3 months 85% உங்கள்கிட்ட வந்துட்டாங்க. Still you are not brought in the control. Still 44% of the people are outside your control. Where is the problem? This is where I used to shout about அவங்க DD NCD, JD NCD. None of us are following the protocol. See, unless otherwise you manage this hypertension and diabetes as per the protocol, this will not come down. If this is not coming down, ungaloda reduction in the mortality or prevention of complication is not going to happen. See, 30, in the 44, almost 50% of them were still in the high risk, the grade 3, whatever you call it, high risk. Either control பண்றதுக்கு ஒரே வழி, make them follow protocol. See, இனிமேல் நீங்க இன்ஸ்பெக்ஷன் போகும்போது வெறும் மாத்திரை கொடுத்துட்டாங்களா, ஸ்கிரீனிங் முடிச்சிட்டாங்களான்னு போகாம புரோட்டோகால் பிரகாரம் ஃபாலோ பண்ணாங்களா. See, in a PHC we have only 4 to 5 drugs. இது பிரகாரம் பண்ணோம்னா மட்டும்தான் things should happen. See, for example, இப்போ உங்களுக்கு டயபெட்டிஸ்னா let them start with metformin 500, increase to another 1000 வரைக்கும் போங்க. Then you have a second line drug, all glibenclamide 1 or 5 grams போங்க. Then you go for a vidagliptin. See, இந்த லைன்ல போனீங்கன்னா தான் it is economical to treat and easy to follow up. பட் இதை விட்டுட்டு நான் விடாகல்டின் போவேன், டைரக்டா இன்சுலின் போவேன்றதுலாம் there is only a limited scope for that. You are not expert. As a PHC MO, as a PHC team, if you follow protocol, that is more than enough. See, அதே மாதிரி உங்களுக்கு ஹைப்பர்டென்ஷன் வரும்போது we already design a protocol, அந்த protocol ஃபாலோ பண்ணுங்க. Let us not start with fancy combinations. நம்மளோட இன்ஃபேக்ட் நம்மளோட protocol பிரகாரம் tell me start on is coming only as a second line. நம்ம விளையாட்டா எல்லாத்தையும் ஸ்டார்ட் பண்றோம், we don't know how to titrate it. So in the following the protocol is the second area which we need to consider. இது பண்ணோம்னா மட்டும்தான் the complication prevention we can able to do it. And NCD ஓட இன்னொரு bigger area which we need to focus is your mental health. See, the mental health, as you know, everyone is burnt out, everyone is stressed out, everyone is having all depressions. But இதுல என்ன current challenge is that the medical college institution உள்ள psychiatrist care is up limited. அவர் ஒரு நாளைக்கு 2000 பேரை பார்த்தா கூட அவரால் பார்க்க முடியாது. See, it is the time how we can decentralize it. See, in a primary care setup, we should know how to pick up those suspects. இதை எடுத்துட்டு if you are able to integrate into your mental health care program, whatever it is, it will be easier. சொல்லப்போனா I used to say we need to do it in a little more level. Integrating mental health into primary care is the ultimate solution. See, your psychiatrist can manage only in a certain proportion of cases, maybe 10 to 20%, which really need a titration. Otherwise, routine management, a little bit of counseling and a little bit of pharmaceutical therapy very well can be done in the primary care, provided you follow the SOP. நீ SOP பார்க்காம பண்ணோம்னா it's a challenge. This is one area. And final area which I want to touch upon is your geriatric care. Our population is becoming older. See, what was around 7.2% few years back, now it is almost 22%. நம்மளும் நம்ம பக்கத்தில் இருக்க கேரளாவுன்னா we are growing in a geriatric population. என்ன சேலஞ்சுனா the current statistics shows that almost 48% of the families have one elderly to support. And அவங்களோட நிலைமையும் it is becoming pathetic. So the strategies are almost 25% of them elderly living alone. See, they need a financial support, they need a social support, they need a medical care. See, நம்ம போனா அந்த palliative careனு ஒரு சின்ன portion தான் நம்ம டச் பண்றோம். But beyond this, there are so many requirements. அவங்களோட லெவல் எப்படின்னா இருக்குன்னா, there is one more data which shows that almost 25% of them had not visited anyone in the past 1 or 2 months, or not visited by anyone in the last few months. In the loneliness. So this is responsible for most of your problem. நம்ம பார்க்கறதுக்கு ஆள் இல்லை, நாமளும் போய் யாரும் பார்க்கல. And there is a still worse condition. When you are 80 plus, only 2% of them move out of their home in a month. Imagine, தனியாக ஒரு வீட்டில் வயசான பிறகு எந்த உதவியும் இல்லாமல் இருக்கும்போது it's really pathetic. And if it happens to be without financial support, it's still more sad. So how we are going to do it? நம்ம நினைக்கிற மாதிரி old age home is not a solution. It is too costlier. It will not, see, none of us in the room will have a capacity to pay our parents or whoever it is for a old age home. 50,000 1 லட்சம் நீங்கள் தாராளமாக இருந்தால் மட்டும்தான் ஒரு பர்சனை கேர் பண்ண முடியும். So now how we can push them based on home-based geriatric care. See, there is a evidence for it. There is a data available. This is our next area. Home-based area, it will become sustainable. I think, boss, I am becoming saturated. Sir, now I highlighted few things. Basically, in a primary care, to do this, where and all you need to focus, how to develop a infrastructure. Infrastructure, terminology include infrastructure. Infrastructure, it's a part of our infrastructure. You need a computer, internet, desktop, so the infrastructure will become part of it. Then where to focus? MCH, immunization and other things will remain, as a head will remain same. But within this major area, where exactly to focus the area, idallam pannala, and our PHC will be our fulcrum. But our area operation undu perusaganum. Idu pannamna, we can bring any fold into it. I am going back again, health team da. See, one or two have their vision to contribute. Na ennoda part naan solli tharen, implementation neenga ellam panna vendirukom. Idu ellam சேர்ந்து பண்ணோம்னா definitely we can do it. In fact, the future of the public health department is in your hands. I hope you will take it to the next level. Thank you very much for the opportunity. Thank you.
Public health is Pandora box with a lot of lids to be opened. You open one lid, another lid comes. It is not opened completely. So, sir has highlighted and enlightened us with elaborate instructions which we need to, we'll keep on trying to open the lids. So, thank you, sir. We will follow up your instructions in the right spirit, sir. Thank you, sir.
Thank you. Thank you.
The next session. We are doing a better job, but that is to be mentioned by others. So we can make a better decision making, better policy decisions. We can better improve and increase the program efficiency and also bring out better health outcomes. So what will make us achieve this? That is one word called operational research. There is one term called public health and another is operational research. Do we have anything to connect or what is the connection between this? That is the session which we are anticipating.
DPHICON2024 renders warm welcome to Dr. Himanshu Bhushan, a public health specialist, former head of Public Health Administration Division, National Health Systems Resource Center, supporting the Ministry of Health and Family Welfare, Government of India. He has led the Maternal Health Division as Deputy Commissioner. His significant contribution to health initiatives, particularly in remote areas, focusing on emergency obstetric care, maternal and child health, and training doctors in life-saving skills are noteworthy. Dr. Bhushan has led the development of key healthcare policies, including guidelines for district hospitals, national ambulance services, and the National Urban Health Mission. He has collaborated with organizations such as WHO, UNICEF, and ICMR, aiming to ensure high-quality healthcare for underprivileged populations. We welcome Dr. Himanshu Bhushan, sir, to enlighten us on embedding operational research in ongoing public health program, strategies and impact. Thank you.
So, good morning to all of you. It is always a great pleasure coming to Tamil Nadu and talking with all the public health experts. I know the Director of Public Health of the Tamil Nadu since last 30-40 years, and every person whom I have met, they are the icons and the present lead of the public health, Dr. Selva Vinayakamji, when you hear him, it's a music for a person who is working in the public health. And certainly, it is because of the team, the vast team of public health, the big team of the public health, which Tamil Nadu has not only inculcated, but mentored very efficiently and effectively. And as a result, certainly you are the national leader. During my next 20 or 25 minutes, I will try to take you to the areas where you have to lead more, you have to do more, so that why you should only become a national leader, you should come at par with the global leadership. And with that aim, what all you have to do, and is it more vibration? It is fine? Okay. So that is what I will try to, deliberate in the next 20 or 25 minutes. So, as has rightly been said, that, and also Dr. Selva said during his deliberations, that research is very important. There are 2 points. One, reaching to the community. Unless you reach the community, till now, 16 CRM has taken place, and I have led all the CRMs. Whenever I visit the health facilities, it is all green. But when I go to community, it suddenly turns red. And that red has to become green. And that is the word he also said. And what we say, that researches can be of various types. The clinical research, very important aspect of the research. And clinical research is particularly seeing the health and illness in the people to understand disease and mechanism and evaluate the treatment. It examines the implementation process of the health interventions and focus how the programs are delivered, what are the evidence, how you can best do it. And in public health, it focuses on assessing the impact of clinical interventions. So clinical research focus on the clinical interventions, whereas the process research examples the implementation process, and it involves midday evaluation to assess program fidelity, reach, implementation, and challenge. So it has just been conveyed that reach to the community, whether it is there or not. Then comes implementation research and operational research. These are very 2 important aspects of the research from the public health angle, because you are involved in many implementation programs, and this research studies methods to promote the systematic uptake of the research findings and evidence-based interventions into regular practice, ensuring that health services are delivered effectively, efficiently, and equitable. These are the key words that you have to remember. Any program that you are delivering, whether it's efficiency, effectiveness, and equitability is there. It focuses on how and why of the implementation and addressing issues of scalability, sustainability, and adaptation in diverse settings. So you have to put your lens to see this type, and operational research is the application of systemic research method to identify and solve operational problems. It focuses on improving the health system interventions by analyzing factors like, again, Dr. Selva told you, logistics, infrastructures, resource allocation, process optimization, and both the aspects you are dealing in your day-to-day work and life. WHO has, summarized it beautifully. And this is a very key slide for you to understand what it says, that any research producing practically usable knowledge like evidence, findings, informations, which can improve the implementation of a plan or program, that is the access to the health services, equity, effectiveness, efficiency, and quality, regardless of the type of research, falls within the boundaries of the operational research. So these are the 4 or 5 very key words that you have to remember. What I am trying to convey is that equity, effectiveness, efficiency, and quality. TB program, RNTCP program is one of the examples countrywide which has utilized the operational research very effectively at almost throughout its till the journey of the program, and introducing, shortening the regime, shortening the duration, introducing new drugs, introducing, testing and diagnostic equipments and variety. So this is one of the examples which has widely used this operational research, in our program. So, what are this research, the operational research guides your policy. Again, Dr. Selva told you that, like SNCU, first initiated in one of the very small area in one health facility, and then it became the viral. So, this type of things needs to be done. So, suppose your problem is health services if you want to see, then what will be the outcome? What will be your strategies and intervention? What will be its impact? It is very important because we are not measuring the impact of our program. We are running so many programs in the country, so many programs in the states, but impact of the program is not getting evaluated properly, and it says that impact in terms of coverage, quality, performance, and it aims for a long-term planning, resource optimization, and cost effectiveness. These are all keywords. Are we measuring the cost effectiveness of the program? Are we seeing the impact of our program? So operational research will guide you to cover all these things, if you do in your program. So what is the cycle? It is very, very simple. You have to think of a problem, and problem you can list more. I have given some examples of the problem: implementation program problem, or program uptake in the community, or adherence to the national guideline, or SOP, or standard treatment guidelines, or training needs, or quality, or any other health indicators. You can always identify more problems. Whatever problem you identify, you have to assess the evidence, develop solutions, validate it, implement it, evaluate it, and there your health services improves. So this is the cycle that you have to maintain while doing this operational research. And if you do that, what is the importance of operational research in the public health? The importance are immense. The program effectiveness improves, efficiency improves, your operational challenges are resolved, quality of care improves, timely interventions are there, health system strengthening is there, cost effectiveness is there, and it has a policy influence also. So the operational research gives you variety of the outcomes and the variety of the benefits for each of your program, your problem, and your interventions. But what is important is that you, the public health people, you have to start doing it. Don't depend on the others. Why not you can do, and again, Dr. Selva Binayakamji told you that start documenting your things. Now, for example, such, methodology in the past has helped in many policy decisions of the government of India. TBA to SBA. Some of you might be remembering in RCH phase, it was the traditional birth attendants, and more than 8 lakhs or 800,000 TBAs were there in the country, where at that time globally it was SBA. So India also shifted to TBA, from TBA to SBA. It was a great challenge. It was a big political force. I vividly remember that how difficult it was to change it. But then we conducted a research involving our PRCs in the country, and it very clearly said that TBH we are not able to identify the complications, and then finally it was accepted that let us transit it from TBA to SBA. And MCH service, ASA, JSY, primary health care, COVID is an example, IPHS revision, emergency services and public health management cadre. So I have already told you about the TBH and how the SBH were trained countrywide, and as a result, India could achieve the Millennium Development Goals. Not only this, when we initiated the program, people were not coming to our institutions. You know, the home delivery was very high, institutional delivery were very low. So a demand promotion scheme was initiated in the form of the JSY. Initially started in the high focus state, but seeing the benefits of this expanded to the whole, this was expanded to whole country. ASA, if some of you might be remembering that it started long back as a village medics program in some of the states. Then, you know, methionine in Chhattisgarh, and then ASA in the country. So these are all examples. Whatever small things that you are doing is going to be a big thing one day, and it helps the program. Ambulance services, you know, I remember that panchayats were given rupees 5,000 for arranging transport for managing complications, but the vehicles were not available. So how they can give the transport? And National Ambulance Service was then brought, and today, you know, already more than 30,000 ambulance services are running in the country. Then JSSK and the Suman, because even if the people were coming to our health facility, still they were incurring the expenditures on drugs, diagnostic, and JSSK as a commitment came. So there are several examples where policy influence has come, you know, because of the operational research. Then we also have IPHS revised, because when we visited the health facilities, there were so many problems that we saw. You know, there were no layout plans. Doctors were not knowing that what should be the flow of service, what type of infrastructure we should have, what should be the size of a delivery room, what should be the technical infrastructural needs of the. They were not knowing that in the operation theaters, air conditions are not required, because air exchanges are important, humidity and temperatures are important. So how many air exchange you need in the operation theater, how many air exchange you need in ICU or HDU, these facts were not known. They were not knowing that what 3 colors should not be used in any health facility. So there are so many small things which IPHS took. It took 4 years in revision of the IPHS, but all such small things through various research and evidence was brought in the IPHS, and first time the performance monitoring parameters were introduced. None of us measure the performance of our health personnel, including doctors, specialists, nurses, because parameters were not let down. So even IPHS, you know, brought down this parameter. IPHS brought down that in a district of 20 lakh population, how many surgeries are required, how many emergency care is required. So what I am trying to convey is that operational research helps in various ways and has helped in the various policy decisions. The emergency, Tamil Nadu is one of the states. I vividly remember during the PIP discussion, and we gave the funds, and your emergency care is very good. But even at national level, it was not good. So, and a study was conducted by the Niti Aayog involving AIIMS Delhi, and it clearly said that if we go to the health facility, drugs are not there, equipments are not there, doctors are not trained, and then we came out with the primary and secondary care guidelines for the emergency care and also the ICUs and CCUs. Public health management cadre, you already have a 100-year-old public health cadre, but it is the time for you to think whether the managerial role of the health system, procurement of drug, tendering, when I was given the responsibility of finance, when I was asked to collect utilization certificates and SOEs from the states, I tell you my experience that till I was handling finance in the ministry, 90% of the time I was busy in the states collecting the SOEs and UCs and audit reports. I was not able to focus on my program. So thanks to NHM, when the finance monitoring group came, FMG came, and we handed over the finance to them, and I could now, after that, contributed in so many policies. So do you need a procurement specialist? Do you need a management specialist? Do you need a HR specialist? If you need so, then you should guide them and they should, work under you. So this is the time you may think about the public health management cadre also. And now some of the specific contexts for the Tamil Nadu where you can think that how progress you can do, but you already know and you have several areas you can expand it further. So you have national health policy, you have SDG goals, you have universal health coverage and resilient health system and the climate and environmental change. These are the 4 big areas that you have to cover and you have to meet these goals. But not only meeting the goals, beyond the goals, because our goals at present is not equal to the goals of the developed country. It is still for the countries like India. So you have to think beyond that, how do you achieve and what all you need to do. You have good achievements. Nobody can beat you, nobody will ask you questions, NMR, MMR, under 5 and TFR, everything is all right. But then for exemplary study which was conducted globally in several countries, it is a global study, was conducted in India also, and 4 states were included, that including Tamil Nadu was one of the states, and a national state dissemination has already taken place here, where your positives are there. There is no doubt of all the positives, your intervention coverage, your 80% of the deliveries coming to the public health institution. It is a big thing. 80% deliveries coming to the public health institution is not a joke. So these are all positive things highlighted by the exemplary study. But they also have highlighted that you have to increase this from 80 to 90%. You have to work on infection control, intrapartum causes. You have to ensure quality of care for the poorest groups and continued improvements in the social determinants of the health if you want to improve your MNH services further. So this is one of the examples that area, and this has been widely deliberated by Dr. Selva Binayakam ji while addressing about the MCH. There are many other problems, anemia, stunting, wasting, obesity. So all these problems, high sugar level, elevated BP. So are we doing the district-wise analysis? Are we doing the block-wise analysis? Are we taking actions, at the local level? So we have to deep dive into all the micro details and then see. All this slide is familiar to all of you. You know the change in the disease pattern. You know the coverage where accidents, non-communicable disease and other things. What all you can do so that it comes and reduces, because your burdens vary. It is not only in Tamil Nadu, pan India, the burden varies from one district to another district, one block to another block. Are we doing this block-wise plan or district-wise plan to tackle these burdens? Then you have done very good in many of the areas like strokes and other things. But if you see, you have to work on ischemic heart disease, diabetes, depression, mental health, stroke, COPD, chronic kidney disease. All these are the further area where you need to work more, and operation research will help you. So first target should be achieving and sustaining. Are we achieving any goal that you choose? I am not saying that you choose IPHS or you choose this. But IPHS is one minimum standard that you should choose. Are our health facilities compliant of the IPHS? Should we work on it? And if compliant, how should we sustain the quality assurance? We have achieved so many health facilities which are quality certified, but experience says after 3 days you go to the same health facility and the quality deteriorates. So how to sustain those quality, how to sustain the standards, these are the area of the operational research that you need to do. And again, I will repeat the word which Dr. Selva Binayakamji told you, that capacity building is very important, monitoring is very important, mentoring is very important, then only you will be able to achieve it, and that is what you have to do. So, if you remember that Tamil Nadu was the first state which started PHC as the CMOC center, and that helped the country to prepare the policy on the CMAC centers. Tamil Nadu was the first state which initiated 24/7 PHC by 3 nurses. That became a national policy. So, taking the cue from the PHC as a CMOC center, what I am suggesting is that every state, district is still the hub, should be bring down this hub to the block level. It is the high time that we should bring this hub to the block level, so that our block level health facilities, our people working at the PHC and the sub-center are able to analyze these programs. I am just saying one example, say take RBSK. Numbers you have. If I ask the people here, they will be able to tell me how many screens. But I am not interested in number. What is the percentage you are getting? In this block, you are getting this percentage. In that block, you are getting that percentage. And then go to the population. See whether there is the impact of this surveillance or not. If there is no impact, then why we are investing? It is a huge investment, RBSK. Every block, 2 vehicles, along with, 3-4 doctors and staff. So are we, using this type of analysis? So this is the high time that we should think whether we should bring our district hub down below to the block hubs, and then, district health action plans. Still we do not have even in Tamil Nadu, as I understand. Every district and every city should have a health plan. And the city health plan should be part of the district health plan. If we talk of the urban health, none of the urban cities have a city health plan, proper city health plan, which addresses all the aspects of the health. And those city health plans should be part of the district health action plan, which is still missing, and should be a start, doing this and getting the standards delivered accordingly. If you see, our medical education directorate people are here. I am not wanting to offend them, but if you see, your own data says that investment in tertiary care is more, investment in secondary care is increasing, and investment in primary care is reducing. This is not the time. Your investment in primary care is the most important, and that is the time. Unless you invest in primary care, how many cath labs you will create, how many center of excellences for bites you will create. Preventive and promotive is the answer, and 2/3 of the expenditure should go to the primary health care, and unless your preventive promotive approach will be there. But then to convince the finance, you need operational research. You need to give them the evidence. That is what I am trying to convey here through this slide. And finally, I will also convey, without, sir, you offending you, sir, that every district is being converted into medical college, and secondary care is going. Secondary care is the hub. It monitors the program. You have to understand, medical colleges are for teaching and training. It is not there for the monitoring of the program. I have seen in one of the state, I will not know, in one of the state, a big district, the district hospital was given to the medical college. So teachers come, faculty come, they teach it, and for them it becomes a case. The patient is a case for them. Whereas in secondary care facilities or primary care, a patient is a patient for you. I remember my final year exam. Now I relent for it that there was a case of prostate. So 6, 7, 8 groups were there. Every group people said, on that bed there is a case of prostate. Everybody started examining him. You see that old man one day, next day round, he asked surgeon, are you telling me that doing PR is the treatment? So if it is there, I have dozens of grandsons at my home. I will discharge me from here. So, for medical college, it is a case. For secondary and primary care, it is a patient. So, have we done the cost-benefit analysis of opening so many medical colleges? I am not saying you don't do it. I am not saying yes or no. I am just trying to, give you some areas of the research. And there are some gray areas which I have already discussed: health management cadre, city health action plan, district health action plan, promoting normal deliveries because you have a high C-section rate, achieving standards, financing, how to reduce out-of-pocket expenditure. It is very, very important. We have everything, but still if people are incurring, you just see your data of the out-of-pocket expenditure, it is very high even in Tamil Nadu. Universal health coverage and a multidisciplinary team at the block, district and state level for performing robust public health actions. And critical care beds availability as per the disease burden, management of ambulance fleet. Do we have the trained EMTs who can actually resuscitate on the site? No, we don't have. Our ambulances have become like a transport vehicle. So, any of the district official, I am sure, is not entering in the ambulance and trying to see their infection control mechanism, trying to see that, how many drugs are there, if the equipments are functional or not. Tamil Nadu, maybe it will be good. Bihar, it may be very poor, or Chhattisgarh. But here also I have gone inside the ambulance and I have found the gaps. So what I am saying that please see all those, urban area. Urban area is a gray area. All of us know, but what all we are doing for the urban health? We have 2 verticals. So how these verticals can be? Because plans should be, that's why I said that city plan should be the part of the urban health plan. So that the same program officer may have a different process for the urban and rural. That's fine. But then the plan should be one for addressing it. And management training in hospital and program management, upgrading district hospitals, disease burden, digitalization of health records and e-hospital. It's very important. It is the high time. Mr. Rahul will talk about this also, I hope. And then we have the opportunity if we have the district health act plan. NHM gives you the flexibility. NHM is one, you want research, please do it. NHM will fund for it. So you have to, machine learning, so many softwares have come, health equity, health impact assessment, all these are the very important, opportunities that you can utilize. And we also have the challenges, data quality and availability, expertise for the research, resources required for research, shifting health priorities, changing leadership and buying in by them, tight deadlines, publications, knowledge translations. These are some of the challenges while you are doing the operational research. And finally, few things which I would say is decentralized planning is very important. And that is the key word said by the National Health Mission, and it is the high time that you should replicate it. And sustaining the quality and the standards. You have to see, implement various audits, clinical audits, prescription audits. You are doing it. I am not saying that you are not doing it, but do it in a way that it gives you some message. And clinical governance is a new area where IPHS has conveyed the clinical governance. At least in the high volume health facility, you should initiate clinical governance. If you want at any point of time, separately I can talk with one of your team which can work on the clinical governance and guide them. And equitable fund allocation, then prospective plan. next 10 years, what should be your vision? You are doing this big and very good workshop in the country. So draw down the plans so that for the next year, 10 years, you have a clear roadmap, and you have to also, as I told you, the allocating funds to the primary and tertiary care. These are out of so many areas that you can add. These are some of the important areas. So that is all. And here on this platform, I must also convey that I am thankful to two of my colleagues, Dr. Poonam and Dr. Diksha, who brought all my thoughts in the form of this presentation. Otherwise, preparing presentation is a big job for us. So thank you so much. And Dr. Silva, thank you so much for giving me this opportunity. Bye.
Can we permit one or two questions, sir? If they are having any questions. Now, the hall is open for audience. If you have any one or two queries or any feedbacks. Okay, sir. Actually, we have as our Director of Public Health has already told in his opening remarks, we have our own journal team, scientific advisory team, and ethics committee team, state ethics committee team, which we have formed first in Tamil Nadu, in the whole country. We have been receiving guidance from the ICMR and all. So now you have rightly enumerated all the challenges in conducting OR. This is what we are also facing. That is my feedback, sincere feedback.
So my request will be that, every public health personnel who is sitting here, all of you are icons for me. And you should start doing things with whatever available with you first. You have people like, in your directorate, full of people. They should become your guide, and you should work. And then, of course, some of the research, ICMR, this, that, big organizations is always fine. But please start doing yourself.
Thank you, sir.
We appreciate the wisdom you have imparted, sir. Thank you. We humbly request Director Public Health, Dr. T.S. Selvavinayagam, sir, to felicitate Dr. Himansu Bhushan.
சரி, ஒரு 10 minutes டீ பிரேக் விட்டுறோம். ஆனால் என்னென்னா டீ குடிச்சு தயவுசெய்து 10 minutesல எக்ஸாக்டாக வந்து இங்கே நின்னோம். சரியா? கிளாஸ் நடந்துட்டு இருக்கும்போது இப்படி எப்படி போனால் இட்ஸ் நாட் லுக்கிங் நைஸ். ஸோ வில் பிரேக் எக்ஸாக்ட்லி ஃபார் 10 minutes. 11 o'clock 11:10 எல்லாம் வந்து அசம்பிள் ஆகிடுங்க. அதை அனௌன்ஸ் பண்ண மாதிரியும் கரெக்டாக 11:10 வந்துடுங்க. அதுக்கப்புறம் யாரும் போயிட்டு இருக்கக்கூடாது. இட்ஸ் நாட் லுக் நைஸ். போதுமா?
For your kind information, please scan the QR code displayed at the entrance to obtain photos taken yesterday and at the phone booth. கனெக்ஷன்ஸ் கேமோட கியூஆர் கோட் ஹாலோட ரைட் ஃப்ரண்ட் என்ட்ரன்ஸ்லேயும் லெஃப்ட் பேக் என்ட்ரன்ஸ்லேயும் இருக்குது. அதை உங்கள் ஃபோனில் ஸ்கேன் பண்ணினீங்கன்னா அதில் ஸ்கீம்ஸ் ஐடென்டிஃபை பண்ணுறதுக்கு ஒரு கேம் இருக்கும். அதை நீங்கள் அதில் பார்ட்டிசிபேட் பண்ணுங்கள். எவ்வளோ அதிகமான ஆன்சர்ஸ் வருதோ அதுக்கேற்ற மாதிரி 20 பரிசுகள் வரை வழங்கப்படும். நன்றி.
I kindly request everyone to please be back as we have to continue the sessions. I request everyone to come back and please be seated. Please be back. I kindly request everyone to come back for the discussions.
காலத்தின் அருமை கருதி அனைவரும் அரங்கினுள் அமருமாறு தாழ்மையுடன் கேட்டுக்கொள்கிறோம். அடுத்த அமர்வு ஆரம்பிக்க இருப்பதால் அனைவரும் தயவு செய்து அரங்கினுள் நுழையுமாறு தாழ்மையுடன் கேட்டுக்கொள்கிறோம்.
Now, after the OR, operational research, now we have heard a lot about genetic terminologies like translation, transcription, DNA, etc. Now, the world is going for artificial intelligence and biotechnology. Now, we have a topic which enlightens us on a new terminology as Omics. So, I request all of you to make use of this deliberations by a special speaker, Dr. Shantaram. Please introduce.
Good morning, everyone. We feel privileged to welcome Dr. K. Shantaraman, Additional Director, Medical Education and Research, a highly experienced head of faculty with a demonstrated history of working in public health for a long time. Notably, Sir has held significant positions including Vice Principal at Tirunelveli Medical College and Dean at Government Kanyakumari Medical College. Sir holds numerous nodal officer positions and is actively involved in institutional ethics, research and accreditation at Tirunelveli Medical College. As Chief Editor of Tirunelveli E-Journal of Medical Sciences, he promotes medical research and education. He has been instrumental in the project management for super specialty hospital and a PMSSY scheme. Let us welcome Dr. Shantaraman sir onto the stage to enlighten us about leveraging Omics, technology for predictive and preventive healthcare. Please welcome sir. I request everyone to please be silent.
It's better.
And also please be seated.
Yeah. 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 me start? Yeah. See, good morning, all of you. At the outset, I thank the Director of Public Health, Dr. Selva Vinayakam, and his team of the Department of Public Health for having given me an opportunity to talk on it in an issue which is Omics technologies, which may be slightly high sounding at this point. But once I get into the discussion, you will understand how much it is very close to the public health and the public health specialists in terms of ground management in the community. The session that I would be running I will be going through what are the different types of omic technologies, that is the long read sequencing and the spectroscope based omics, application of genomics in the public health in terms of population risk and population scale pharmacogenomics, and of course a few examples in which I have been a part. So before I get into omics, I need to put in order certain basic issues in public health in the current context. Non-communicable diseases and chronic debilitating disorders are slowly moving into the center stage of public health with the reduction in communicable diseases and those smaller entities which have been commanding the center stage for all these years. When you come to Europe, currently 2/3 of the deaths and 75% of the healthcare costs is because of chronic disorders. And this chronic disorder is of huge economic impact that it actually consumes a lot of the budgetary allocations in these countries. But that is not the way a healthcare can run in the coming years. So, attempt to solve these problems at an earlier phase or in a previous level than it is being done presently has to be thought of. In the US, if you do a hot mapping of chronic disorders, you find that
I request all of you to keep silence, please. If you have anything to talk, you can go out and talk. While leaving also, please maintain a silence. Please. If you have anything else, you can just go out and do it. So discipline is first, please.
Thank you so much. Yeah. So when you come to the United States, we are seeing a very interesting phase where the United States has transitioned into a phase where the predominant disease the public health in the US is facing is chronic disorders, especially the non-communicable diseases and other chronic degenerative disorders, especially the neural and the cardiac and the hepatic disorders. So the public health there has a new issue where the highest prevalence is facing socioeconomic and environmental barriers. This has to be put in mind because we are not transitioned, but we are in the phase of being transitioning, right? So now let us come to our own public health. Years before, the public health was battling to reduce deaths due to pandemics. Slowly it moved to a phase of surveillance where early identification of infectious diseases reduced deaths and morbidity. Then came the phase where vaccination was introduced and vaccination reduced the occurrence of a lot of infectious diseases. Then came nutritional and health support for the mothers and the newborn. So what happened? Maternal and infant mortality reduction was our phase. Then presently, with what we call as the Makkalai Thedi Maruthuvam and also the NCD program of the Government of India, we are now focusing on early identification of, on the early identification of non-communicable diseases, reducing the complication rates in the community by survey and health support. But preventing NCDs, early identification of chronic debilitating disorders and preventing chronic debilitating disorders is not in our framework or in our scenarios at this present moment. What do we do about it? See, basically, I think I will go back to a reference of the WHO where it says chronic diseases are of immense and importance and increasing the toll of lives in the community. We now have much better technology available like risk prediction tools, but we are not systematically implementing them at the required place, is a recommendation of the International Common Disease Alliance for Polygenic Risk Scoring. It's a task force which has specifically said that the public health needs to use better technologies in risk prediction. And one of those technologies which I am talking about here, that is the Omics technology, is going to be a huge tool in public health. So what is Omics technology? Omics technology is a comprehensive biological data. It's a comprehensive, large biological data which comes from major 5 types of omics. That is genomics, proteomics, metabolomics, and transcriptomics. There are 2 other smaller omics, that is the microbiomics and immunomics. They are adjuvants to the whole issue. But we need to remember genomics, proteomics, metabolomics, and transcriptomics. These 5 issues will be driving the public health effort in the next 10 to 15 years. Now, I will go through the process. This omics is a new terminology. I will put it across to you. You take the cell. The center of the cell, you have the nucleus, which has the DNA, which decides what the cell will do in terms of its participation in the human body. So, the DNA is composed of smaller molecules, which we call as the base pairs. So, that globality is called as genome, and the study of it is genomics. When the DNA transcripts or tries to produce proteins, it converts into mRNA, and the studying of all the mRNA in one go is called as transcriptomics. When the mRNA reaches the endoplasmic reticulum, it produces peptides, polypeptides, and proteins, and that entire community of chemicals that are produced is called as the proteome. These proteins structurally and functionally get involved with the metabolism of the cell and produce a lot of smaller products because of the metabolism of the amino acids, the glucose, the lipids, and the nucleic acids. Those molecules together are called as the metabolome, and study of it is called as metabolomics. Now applying this to a timeline from a defect in the cell to a clinical diagnosis of a disease. You will understand that within nanoseconds of a defect happening in a cell or in a nucleus, you can diagnose it if you do a genomic sequencing of the nuclear DNA within nanoseconds of onset of a disease. Nanoseconds to microseconds of the onset of a disease, you can diagnose by finding out the changes in the mRNA or aberrant cell signaling. Microseconds to few seconds, you will see the cells producing aberrant proteins. Then seconds to few hours, the cell will start producing aberrant metabolic products or aberrant cell function will start. And few days to few years, there will be structural and functional changes that the cell abnormality will cause, which will be clinically diagnosed. If you look at this picture, you will understand that the present day public health is relying on clinical, imaging, and laboratory data for early diagnosis of diseases, even for preventive strategies. So, we are using only 1/10 of the data of a human disease process in deciding what the public health intervention needs to be to prevent diseases and to provide a healthy society. So the responsibility of the public health now is to harness the large unharnessed data that lies in front of us in terms of omics or omics-based data or omics-based technology-based data. Now I will look into what is the what is the unharnessed data we have. Take genomics. You have data about 300 million base pairs. Transcriptome gives you 1.5 lakhs data points. Proteome gives you 20,000 data points. Metabolome gives you 2,500 data points. And these data points can be derived using the same material that you are using for the present day clinical diagnosis. But only one thing, the diagnostic technique requires certain specific platforms, which is called as the next generation sequencing or the third generation sequencing, and of course the mass spectroscopy. These are two techniques which can add on to your data. Now, the question comes, is the public health capable of doing it? You should understand that without actually knowing that you were using omics data, you have gone through the process of controlling a pandemic in the last 2 years, where wonderfully you have used omics data of the SARS-CoV virus to actually in January 2020, that is when the first entirety of the SARS-CoV virus was sequenced. In March of 2020, you had the detection kit, which was a prototype sent into for manufacturing. By April, the public health community of the world had produced the prototype of a vaccine, an RNA-based vaccine, and by June or August, it was already under production. And January of 2021, all of us had the first shot of a corona vaccine. That is all because of the use of omics technology by the public health. This is one classical example. And so, omics technology is not new to public health, but there are certain other uses which we have not thought of. Now coming to, I will just go through a few slides where I will describe what these omics technologies are. Number one, the genome sequencing for DNA and the mRNA. In 2003, these slides are here to make you understand how it is easy for you to use omics technologies in public health in the coming years. In 2003, the first human DNA was sequenced in the National Institute of Health in the US by a US scientist called as Craig Venter. He had spent 13 years and $3 million and 400 Sanger sequencer machines to produce the data about one human genome. That is 13 years. 2009, 6 years later, the first Indian human genome was sequenced by the CSIR Institute of Genomics in Delhi. And this was in 50% of the time that the US had taken. In 2020, India had already sequenced 1,000 Indian genomes, which is called as the Indigen program of the government of India. By luck or whatever, I was part of the 50 scientists who were involved in the sequencing of the first 1,000 genomes in this country. Now, you look at this. When Venter did it, he spent $3 million for sequencing one human DNA, human gene, sorry, human, the 23,000 genes. But today in 2022, you can do the same job for less than $400. And what machine which we were trained in genomics is a machine which is almost filling 1,000 square feet space. But today, you have sequencers which use what is called as the nanopore sequencing technologies. All of these in the picture are all handheld machines. You should remember, these are all handheld sequencers which the public health people can carry in their hand when they walk into the community to do sequencing on ground. So now coming to the others, that is mass spectroscopy in metabolomics and proteomics. You have the what you call as the liquid chromatography, which was introduced in 1987, which is one powerful machine available in many hospitals in this state, which can do a proteomic study. Similarly, a machine which is called as a gas chromatography and other types of machines which produce data on metabolomes are also available in our own system. So our system has the machinery and capability today to do proteomics and metabolomics. With a short reference to microbiome, microbiome is the sum total of the physiochemical activity of the microbes that are there in all of us inside our gut. Very interestingly, the amount of the microbes that we have in our gut is so much that you can call it as the second genome, and the physicochemical activity of these microbes alter the body in terms of our disease responses and even our disease risk. So this is one thing that could add to the data of the public health. Now coming to this. See, you have almost 3 million base pair variables. You have 1.5 lakhs of transcriptome variables, 20,000 odd proteome variables, 2,500 of metabolome variables, and 200 to 500 of clinical variable data for almost every patient in the field. You should understand what amount of big data the public health has, the amount of computational skills that our country has put into use. This will give you so much amount of preventive and predictive value that 10 years down the line, 15 years down the line, what is going to be the state of the population which you are handling in terms of risk and risk attenuation, it would be very easy to sit in your offices and predict and prepare the health system to handle them. Now coming to a very interesting law which is called as the Moore's law, which has been used in computational power in the recent years. I reiterate the same law here. We have two disruptive technologies that we have here. One is the computational power in terms of big data analysis and data handling. You have another big is the Omics technologies. These two disruptive technologies are there in the doorstep of the public health today. If you can put them into your control, into your use, the power of the public health or the disruption it will cause, I will tell you one thing, it's not for a joke. The importance of the tertiary care, as many of our speakers were also mentioning, the importance of the tertiary care will dwindle down in the coming years because the public health will be able to prevent diseases, prevent risk, prevent complication due to risks at a very high level that use or requirement for large hospitals with large capacities and large infrastructure may not be necessary in the coming 10 to 15 years. Now coming to what are the current application of omics technologies, I'll go through you very rapidly. Cancers and chronic diseases is going to be the place where these omic technologies work in terms of population risk. I will but mention some of them. Beta thalassemia. I think many of the people in the public health who are in these districts. Yeah, please.
See, technical sessionன்றது கேட்கறதுக்கு தான் பேசுறதுக்கு இல்லை. சரியா? நான் மறுபடியும் ரிமைண்ட் பண்ணிட்டு இருக்க மாட்டேன். சரி, நம்ம அவர் என்ன விஷயம் சொல்றான்றது தயவுசெய்து தெரிஞ்சுக்கங்க. உங்களுக்கு இந்த செஷன் பிடிக்கலன்னா சத்தம் இல்லாமல் வெளியே போய்ட்டு ரிலாக்ஸ் பண்ணுங்க. தயவுசெய்து மற்றவங்கள டிஸ்டர்ப் பண்ணிட்டு இருக்காதீங்க. சரி, ஒவ்வொரு ஸ்பீக்கரும் எவ்வளோ எஃபர்ட் எடுத்து ப்ரிப்பேர் பண்ணிட்டு வந்திருப்பாங்க உங்களுக்கு தெரியும். சரி, சயின்டிஃபிக் செஷன் should be a scientific session. நேத்திக்கு கேலா, சரியா? இன்னைக்கு 6 மணிக்கு வாங்க, சத்தம் போடுங்க, டான்ஸ் ஆடுங்க, தட் இஸ் டிஃப்ரெண்ட். Scientific session should be treated science. Please.
Thank you, sir. So, in the few slides that I am talking is already there in your parlance and the public health is actively involved in this. I know beta thalassemia, Dharmapuri, Thiruvannamalai and Kanyakumari district DDs will very well know that you are looking at this. But here again the effort is we are looking at patients, but have you prevented them through genetic counseling, genetic preconceptional diagnosis? This is the role where we want the public health to work. Preconception diagnostics, preconception counseling, and preventing the occurrence of patients with all these diseases in these districts. Now you have sickle cell anemia in Nilgiris and Coimbatore districts. Alkaptonuria among Narikuravas in the Tirunelveli and Madurai zone. It's a huge problem. They don't come up to the public health or to the hospitals early. And with all the complications of alkaptonuria, they come in very late stages. That is how we first came to know that alkaptonuria is very common among these Narikuruva tribes. But early diagnosis and preconceptionally, if you can advise them, we could prevent diseases and the cost. I will tell you one thing. Practically, everything boils down to the healthcare costs. The moment you have a complicated patient, you are spending 10 times more that you need to spend when you want to prevent a disease. Similarly, congenital heart disease, very interestingly, the national average is 2 to 2.43 per 1,000 live births. But in Tirunelveli district, the calculation is around 10 per 10,000 live births. We don't know what. The data is unclear. The public health here has a huge role. I will talk of some paradoxes. All persons with the BRCA1 or BRCA2 mutation, which you already have heard in terms of breast cancer, do not get breast cancers. Those who have mutation don't have breast cancers, and those who have breast cancers do not have the mutations. It is quid pro quo, it's both ways. Why is it? So why do certain people have risk? It is not because of these two genes. There are certain other complex combination of the genome, the transcriptome, the proteome, and the metabolome that is there in these patients, which needs to be discovered, and that could throw up a huge diagnostic and a risk factor assessment in cases where we want to find out breast cancer very early. Similarly, all obese patients do not have an acute coronary syndrome. At the same time, those who have acute coronary syndrome need not be obese or overweight. Here again, there is a underplay of a lot of other factors which we don't see in terms of their metabolomics, in terms of their proteomics, which will give us a huge understanding of the evolution of acute coronary syndrome, and that can help us to prevent acute coronary syndrome occurring by interfering in a young age, probably in the school level, and that could reduce the amount of money we are spending on our cardiology effort. Similarly, certain regions in our own state have people with similar racial characteristics developing goitrous thyroid with a high risk of thyroid cancer. But very interestingly, what we have seen is when the same racial group migrates to Bombay or Bangalore or Delhi, their risk of thyroid cancer decreases. When I say increased in risk of thyroid cancer in these communities, the first thing is probably something genetic. But when they migrate out, there is a decrease in risk, means there is something metabolic that is helping those people who are out of the community or out of the region. So these regional racial issues are very important data for the public health to manage its interventions. Now coming to very important issue that we are going to see is the newborn screening. India did not have a newborn screening till few years back. There was a pilot study that was done in Karnataka in Udupi where 6 disorders were taken, and the final report was very emphatic in saying that newborn screening as a public health effort is very much essential today because a huge cost is being spent in treating these children, in maintaining these children once the disease process has taken over the child. The statistic shows that 27,000 of our children yearly have intellectual disability because of errors of metabolism, which is preventable. And 2 lakhs and odd children have the threat of hemolysis and acute disease, or what you call as acute change in their metabolism, and even death. There are 5,000 odd children who go for adrenal crisis every time in this country because of the congenital adrenal hyperplasia. These are all issues now limited to the medical college, especially to the super specialty hospitals. But looking at this, you will understand this is an issue which the public health needs to be concerned. If you had found out these disorders early, the moment the child was born, if you had the capability of newborn screening when the child was born, you would have prevented many of these complications, and many of the hospitals who are treating this would have been empty today. But it is the endocrine department or many of the pediatric departments, especially the ICH in Chennai, which is busy combating this. Now coming to the final one, One Health approach. We are now looking at One Health approach as one major wing in preventive healthcare. Here you have the interplay of genomics, but more so an interplay of our own medical science, veterinary science, and of course the social and environmental sciences in one go, where you require the use of Omics technologies, including microbiomics. This is a touch and go. I just like to mention for completion's sake what is personalized medicine. There is a time which has now come where every individual patient has a right to a particular scale of drug or a particular type of regimen based upon his own genomic or omic structure. I will just give you a paradox. 2 patients with similar breast cancers with similar histology, grading and staging at the same age and weight have two dissimilar outcomes at the end of the same chemotherapeutic regimen. One person recovers, one person develops metastasis and dies. This is because of the genomics or the transcriptomics or the metabolomics are all together acting on the patient. If we had data, as a public health person, I can say this person has a good prognosis, this person has a good cancer or a bad cancer. The good cancer can be treated at a local level, the bad cancer requires some kind of a specific therapy. So this is one example where certain miRNAs are associated with good responses in lung cancers and bad responses, just a table to make you understand. Now coming to drug targets, I'll just pass it on fast. This scale of genomics or the omics technologies in the field will help you find out specific drug targets and drug development. The classical example is the vaccine we developed for COVID-19. Similarly, there are a lot of drug research that is happening for cancers which is based upon omic technologies. And of course, adverse drug reaction. I would like to show a very interesting slide, which is a newspaper report in 2006, which was called as the Chettiar problem. There is a very interesting thing is, before 2006, a lot of people from this community, including a few famous doctors, who went in for surgery and never recovered from anesthesia and died after 10 or 15 days of ventilation. That is because of a specific gene deficiency or defect which caused these people, now caused them not to recover from scopolamine injection. But today, there is a gene test, and we know that this population is at risk. This population awareness has been created, and now these people are being given a different drug for the same process. Now I have a couple of case studies in which I was also involved. In 2009, the neurologist in Tirunelveli brought in an interesting case of a 50-year-old person who had tremors, myoclonic jerks, and seizures. And we found out there was a clustering of cases in that part of the district. This is an effort which was taken in a medical college, but I will tell you, as public health experts, when you go into the community, there are small examples which are very similar to this that are there. Use of omics technologies would help you to track diseases, cohort the diseases, look at interventions. In 2010, we went in search of the first patient to a church in Tirunelveli, that is the Antonia church in Puliyampeti. He was a 55-year-old man. When we asked for a clinical history, he said that almost 10 people in his family were already dead with this epileptic disorder. We went in search of patients and finally reported 726 individuals in 122 families who belong to a unique native South Indian community in those areas in South Tamil Nadu. And we had the help of the CSIR IGIB in terms of doing a genomic assessment of the rare disease. And finally, it was published in Brain, where we found that that entire community had a unique genetic mutation. And this is almost a 50 lakh population that is there in south of Tamil Nadu who can have this disease, who require specific drug treatment, and that drug treatment helps them in controlling the epilepsy and gives them a quality of life. So this is where a tertiary care phenotype results in a population scale genomics and tracking down and cohorting of a disease. We came across another set of diseases where a 42-year-old agile man climbs up a tree in his home and was later found hanging dead on the tree top. A 17-year-old boy who was writing the exams just falls out of the table and dies. A 13-year-old teacher walking to the classroom falls down, drops down in front of the class and dies. Very interestingly, these are all sudden cardiac deaths, and all these three deaths happened in a particular area or a particular community in South Tamil Nadu. We went in search of these patients and we did 181 autopsies between 2010 and 2016, and very interestingly, 9.9% of the hearts in autopsy were normal in those dead people. And we continued the study between 2017 and 20. Of 92 autopsies we did, 11% of the hearts were normal. And a genetic analysis for these patients are ongoing. Very interestingly, this is a public health problem. Sudden cardiac death, this is a public health problem which requires an answer where omics technologies would help you. So the take-home message here is, today the benefits of omic technology is relegated to few individuals sitting in few departments in few medical colleges. But the potential of the technology is so much that it can improve the health and well-being of the populations. And so at that point, we can even term it as public health omics. The promise of public health omics lays in analyzing relationships between the data and the health and disease state of populations, and that will help us in making critical decisions in public health. But the challenges that we have in omics is the cost. But once technology improves, the cost is bound to come down. So that is not an issue. But reproducibility of the data between different groups, the noise generated by the huge data set that comes out of the omics technologies, and the technical need to fish for novel markers, these three are major challenges for omics technologies used in public health. So with this short discourse, I stop here and finish with the point, what data that you are handling is like the tip of the iceberg. There is a lot more of data lying in public health in terms of technological diagnosis and technological findouts. The public health needs to rise to the occasion over the next 10 to 15 years. I think public health should have an armory of omics technologies to help you out to find diseases even before it can become clinically evident, and it requires a tertiary care intervention. We will be a happy and a healthy community if we can close our tertiary care hospitals someday in this country. Thank you so much.
Thank you, Dr. Shantaraman. Any queries about closing the medical colleges in Tamil Nadu? Okay.
Yeah, thank you so much.
Thank you. Thank you for your wonderful session, sir.
Thank you for introducing this very new topic, sir. Your insights were invaluable. I now request our additional director to come forward and felicitate our speaker, Dr. Shantaraman, sir. I thank our additional director, Dr. Somasundaram, for moderating the session, and I request Dr. Sampath sir, additional director, communicable disease, to present the moderator memento. Now, I welcome Additional Director, Communicable Disease, Dr. Sampath sir, to continue the discussions.
DPHICON 2024 cordially invites Dr. P. Vadivelan, Director Public Health, Officer on Special Duty retired, Directorate of Public Health and Preventive Medicine, to shed light on the last mile challenges in achieving malaria and filaria elimination. Sir joined Department of Public Health and Preventive Medicine, Government of Tamil Nadu in 1993. He served as Municipal Health Officer in Erodu, Ooty and Coimbatore. He also held the position of Deputy Director of Health Services in Tiruvannamalai and Virudhunagar districts. Sir had served as Joint Director, Health Education Bureau from 2010 to 2014. He was appointed as Additional Director, Malaria and Filaria, Directorate of Public Health and Preventive Medicine in 2014. Sir retired as Director of Public Health, DPH, Officer on Special Duty for Disease Control, in June 2024. Welcome, sir.
Good morning, all of you. First of all, I thank DPH sir and all the officials of the DPHICON for inviting me to participate in the DPHICON conference. And my topic is the last mile challenges in the elimination of filaria and malaria. As DPH sir said in his inaugural session, public health teamwork only will yield good results. The perfect example for the public health teamwork is the control activities of the malaria and filaria so far in the last 50 years. The public health teamwork only led the elimination status for our department now, actually. So, as far as the malaria and filaria is concerned, those are all old age diseases, and particularly the malaria, it causes not only the morbidity and also the mortality. But whereas the filaria is concerned, it doesn't cause mortality, but it causes considerable amount of morbidity as well as the disfigurement and social stigma. So malaria is concerned, see, during the last century, in the 1960s and all, lakhs and lakhs of people have been affected and thousands of people were died. And after the inauguration of the malaria eradication program in India, there are control activities were going on, but some sorts of sense of failure and abandonment of the control activities, there are the resurgence of the malaria cases in 1969 to 2000. So in those period, in the last 3 decades of the last century, the malaria cases have been increased to lakhs in the country, and also thousands of people have died. So because of the improved health technology and improved social economic conditions, housing conditions, and all the other public health interventions, the last 2 decades in this century, there is a drastic reduction of malaria cases in our country as well as the Tamil Nadu. As far as India is concerned, in the last 2 decades, the cases have come down from 20 million cases from 2001 to just 1,60,000 as on 2020. And as far as the Tamil Nadu is concerned, definitely Tamil Nadu is the front runner in all the malaria control activities because of the public health teamwork, as DPH said. And the cases in 1990, we have around nearly 2 lakhs cases in Tamil Nadu, but now it has reduced drastically year by year, and for the last 5 years, the malaria cases have come down below 1,000. Only actually last year, we have around only 300 cases only. And as far as filaria is concerned, Tamil Nadu is already achieved the elimination status. Only the few formalities have to be completed to get the certification. So with this background, I am going for the presentation. It's a simple presentation, short presentation. Next slide, please. So first we will go for the history of the malaria. As I told, prior to 1990, there are no organized malaria control program. Actually, in 1953, the India has launched the National Malaria Control Program, and later it is converted as the National Malaria Eradication Program. And because of some failures in the control activities, and as I said, there are in the early 70s, resurgence of malaria happened, and so many, there is a bursting of cases, malaria cases, nearly lakhs of cases have been occurring throughout the country, and deaths also increased actually. And in 1976, actually if you take 6.46 million highest cases have occurred because of the post-DDT era, because of the resurgence, reasons for resurgence is the resistance to the insecticide for the DDT also. That is one of the main reasons. And in 1997, modified plan of operations implemented, and after that only the malaria cases have come down gradually. In 2006, ACT, the drug was introduced in area showing the chloroquine resistance for the falciparum malaria. In 2008, the ACT extended to high-risk PF districts also. These are the brief history of the malaria control program. Next. And as far as the epidemiological types of malaria is concerned, only in Tamil Nadu, actually if you take only 4 types of malaria we are having. First one is the majority of the malaria are the rural malaria because of the living conditions and poor sanitary conditions and all those things. Actually 50% of the cases in Tamil Nadu are the rural malaria. Anaphylis culcifacies are the major vector for the villages, you know. And urban malaria is another important thing. In the early 70s, urban malaria is also nearly 70% of the cases are from the urban malaria. In Tamil Nadu, about 10 cities are having the urban malaria incidents. So, urban malaria scheme was started in 72 in those 10 towns actually. And another thing, coastal malaria, Tamil Nadu, you know very well, Rameshwaram is one of the classical examples for the coastal malaria because of the diversification of the breeding sites in those areas, mainly Rameshwaram. Now it has brought under control because of some innovative practices in the larval control. And finally, the riverine malaria in the Tenpennai river belt actually, after the Sathrur dam has built, the rocky pits, because of the rocky pits in the banks of the Tenpennai, we are having regular cases of riverine malaria. So these are all the epidemiological common types of malaria that are occurring, that are in the Tamil Nadu. Next. And actually regarding the strategies, actually the NVBDCP, now the NCVBDC is the umbrella program under the VBDC for the integral part of the NHM. And mainly the objective of the malaria control program is the prevention of deaths of the malaria, prevention of the morbidity due to malaria, maintenance of the ongoing socio-economic development. These are all the main objectives. And another important thing, surveillance and case management. These are all the important strategies, main strategies for the malaria control. The surveillance are the case detection. That is very, very important. Early case detection and early detection are very, very important to prevent the morbidity and mortality. And early detection, diagnosis and early complete treatment, that is important. Complete treatment for the both Plasmodium vivax and Plasmodium falciparum. These are all the main surveillance activities that are happening in our state. Next. So, because of the encouraging results of the malaria control, malaria elimination framework has been formed in 2016. The goals of the malaria elimination framework actually to eliminate the malaria, 0 incidence cases throughout the country by 2030. That is the main goals for the malaria, and maintain the malaria-free status wherever the malaria transmission has been interrupted and prevent the reintroduction of the malaria. That is the very important goal in the malaria elimination. Next. And the objective of the malaria elimination framework, eliminate the malaria from all low category 1 and category 2 transmission states and the union and territories by 2022, reduce the incidence of malaria to less than 1 case per 1,000 population. Now it is around 3 cases per 1,000 population as far as the recent data is concerned. And another important thing is interrupt the indigenous transmission throughout the country by the 2027 and prevent the re-establishment of the malaria transmission by 2030. These are all the objectives for the malaria elimination. Almost we have achieved few of the objectives in our Tamil Nadu. Next. And as far as the malaria surveillance is one of the key factor for the malaria control actually. As far as the surveillance is concerned, 2 active surveillance and passive surveillance are very important. Active surveillance, you are very well know, screening of the 1% of the population that is done by our MPHWs. And another important thing that is also lacking now, screening of all the AN cases for malaria smear. That is one of the important thing to prevent any maternal complication during the pregnancy. And also fever screening by our hospital, MMU, Hospital on Wheels. These are all the active surveillance are happening in Tamil Nadu. And passive surveillance, 15% of the OPD cases are screened in all the health facilities, including PHC, government hospitals. Private hospitals also screening is happening. And screening of migrant population also being done. These are all the surveillance activities are being done. And the quality assurance, cross-checking of the slides are happening. That is done by the zonal entomological teams, RD office, IVCs at Osur, and the Central Malaria Laboratory. Quality assurance is the very essential thing because it's one of the important component for the malaria elimination criteria. And vector surveillance and control, very essential. And IRS, one of the important thing, IRS is being conducted every year, 2 rounds in all the 18 endemic districts now. These are all the brief surveillance and the control activities that is being happening in our state. Next. So this is the malaria status of Tamil Nadu. If you take, in 1990, we have around 1,20,000 cases in our state and deaths also happened. Now, because of the control activities, see gradually the cases have come down, and last year it was only 354. Last 5 years it has come down below 1,000 cases. Next. And if you take the malaria comparison, ABEI and API and ABER, see whenever the ABER, you know very well the number of slides collected in the population, isn't it? That should be around 10 per year. That is the quality ABR. So that is in Tamil Nadu, regularly we have achieved ABR above 10 throughout the from 2000 onwards. It's always almost 10 per year. And the API, it has reduced below 1 actually now. It was 0.70 in 2000. Now it has come down around point something actually. So if you see the curve, whenever the ABR is correct, the AP is also very reliable, isn't it? So these correlates the control activity, the quality control activities of the malaria. Next. And the malaria situation, actually regularly, as I told, the ABR is constantly maintained. If you take every year the blood smear collection is very well maintained actually, except 2020 because of the interruption of the COVID control activities. All the other years, if you take the smear controls, nearly more than 80 lakhs, and last year 1 crore 26 smears have collected. And malaria cases, if you see, total malaria cases also has gradually coming down. Last year, 2022, 354 cases, and last year, 384 cases. And indigenous cases, that is the important thing. See, in the malaria eradication, important criteria is to reduce the local transmission, reduce the indigenous cases for the last consecutive 3 years. That is very, very important. If you see the indigenous cases, Actually, the cases are coming down gradually. Last year, only 55 indigenous cases are there. But if you see other words, the imported cases are gradually rising because of the, the obvious reason is the migrant population, and also screening is taken place. And another thing, PV cases is also coming down. PF and mixed cases are gradually increasing. That is also the reason is because of the migrant population. Okay. As I told, ABR, we are maintaining at more than 10, and APA has come down far below 0.001. That is a very clear indication towards the elimination. Next. If you take the stratification of the malaria elimination of the districts, actually in our state, 32 districts have already achieved the status of category 0. Category 0 means districts without local transmission and reporting no indigenous cases for the last 3 years. That is the important elimination status. Already 32 districts have achieved it. Only 6 districts have in category 1. That is the that districts having API having less than 1, but some pockets of the districts are API are more than 1. So that those districts should be brought to category 0. That is the next level aim for towards the elimination. Next. These are all the districts in the category 0 and category 1. Category 1, the Chengalpattu, Ramanathapuram, Thoothukudi, Kanyakumari, Salem, and a major contribution is the Chennai Corporation. Next. And the main next thing is the challenges. The challenges mainly, only 4 to 5 challenges are there. Already we have overcome several technical, parasitical control challenges, vector control, everything we have overcome and achieved this much of status. But few of the challenges still we have to address, and we have to rectify those things to achieve the complete elimination status. The first and foremost challenge is the migration. That is the important thing, the migration of people from the endemic to the non-endemic districts. That is the main thing, actually, the problematic there. Actually, last 2 years, actually migrants screening, we are reporting the Plasmodium falciparum cases. There is one of the risky category, actually, we have reported. Regularly, the PF cases are reported in our state. And that is the important challenge. Another thing is the shortage of human sources for the surveillance, like health inspectors and the lab assistants. Now, as DPH pointed out, the health inspectors number has been reduced from 8,000 to 3,000 now. And another important thing, the urban area, we don't have manpower for the active surveillance. That is also an important handicap in the malaria surveillance. And another thing, insecticide resistance for vector mosquitoes also be there in some parts of the state, actually. That should be addressed in the future. And the capacity building of the malaria for medical and paramedical, that is very, very important. That is not only for the private, even in government sector, the periodical capacity building training for in all aspects of the malaria is very, very important. That means the quality of the smear, right from the quality of the smear, examination capacity, and declaration of the positivity, and RT disbursement, everything is requiring this capacity building. That should be improved, actually. And finally, the poor disease surveillance in private health facilities. That is one of the important challenge nowadays we are facing. Actually, the passive surveillance is happening in all the government health facilities, right from PHCs till the government hospital, medical colleges. But in private hospitals, we are not conducting the passive surveillance. But even though dengue and other fevers are there, all fevers are malaria unless otherwise it is proved. That is the NVBDCP guidelines. So, wherever, even in the private hospitals, whenever the fever cases comes, the malaria smear should be taken actually. That is the dictum, and we have to improve the private hospital passive surveillance also. These are all the major challenges we are facing towards the elimination of malaria in our state. Next. Recommendation, as I already told you. Okay. Next. So that's all about the challenges of the malaria. Next we will take up the filaria control program. You know, filaria, actually as far as the filaria is concerned, Tamil Nadu is already achieved the eligibility elimination criteria. Only the documentation and other formalities are there. That should be done actually. As far as the malaria program is concerned, in 1957, the program was implemented. About 25 control units and 44 night clinics are functioning under the 5 filaria units actually. Chengalpattu, Chidambaram, Vellur, Kumbakonam and Nagarkoil. Next. The main activities under the filaria control program, anti-larval operations, mainly the minor engineering works, decanalization, de-weeding, that is all done by the health inspectors and the workers are there. And another important thing is the source reduction. That is also being happened in under the program. Under the night blood survey, that is one of the important thing to detect the early cases, early microfilaria cases in the society and to treat them and prevent the transmission. That is the another important thing, night blood survey, that is also being done by the filaria units. And another important thing, community participation, training, IEC, these are all happening under this program. Next. And actually the filaria elimination in Tamil Nadu is concerned, besides the routine activities, actually Tamil Nadu is the first state. We have started the MDA program in Kadalur in 1995 itself. After that, actually throughout the India, this program has been launched and full-fledged MDA has been launched in 2003 in Tamil Nadu in the 18 endemic districts actually. And we have successfully conducted the MDA till 2014. After that, the parasitical survey has been conducted in 3 consecutive years and we have achieved below 1 microfilaria rate. So we stopped the MDA and we started the filaria elimination activities like post-MDA survey and the transmission assessment survey, TAS. We have completed the TAS also 3 rounds and passed in 2022 and we are eligible for the filaria certification in all the 18 districts. Now these processes are going on. Okay. Next. So these are all the 26 endemic, LF endemic districts are there. Next. And as far as the data is concerned, 38 districts and 26 LF endemic districts are there. And the total number of non-endemic districts, confirmatory mapping, 12 districts completed. And the last round MDA conducted in 2014. And post-MDA surveillance activities conducted in all the 26 districts. Tasks completed in 26 districts. So these are all the activities have been completed in the state. Next. So innovative steps in the filaria elimination Tamil Nadu, you all very well know, we have established 42 M&F clinic, malaria and filaria clinic in all the GH of the endemic districts. And the Tamil Nadu is the only state giving the financial assistance of 1,000 rupees for all the lymphedema cases. Nearly 8,000 cases are getting every year, every month, 1,000 rupees. The state fund, government of Tamil Nadu is spending around 8 crores every year actually. And DEC medicated salt program has been conducted in the Kanyakumari district in 1998 to 2000 and results in the 95% reduction of the microfilaria rate in Kanyakumari. And we have also, under the state fund, we have distributing the morbidity management kit to the all the lymphedema cases every year. Next. So regarding the challenges in the LF elimination, actually by 2030, the illness is expected to be eradicated as a public health issue. That is the important goal. Actually, now, as I said, all the activities are over. Only the dossier preparation for the assessment by the committee is under process. A committee has been constituted for appraisal of LF in Tamil Nadu is constituted. And as far as the challenges is concerned, poor sanitation in certain areas is still pose a challenge for the breeding of the Culex mosquitoes and the complexity of the disease transmission cycle. That is one of the important thing. And another important thing, asymptomatic carriers in the community act as a potential source of the spread. That is the important thing. See, asymptomatic carriers, they will have microfilaria in their blood, but they don't have any symptoms. They don't seek for any screening. That is the important challenge for the transmission. And another important thing, longer incubation period for the manifestation. That is the important thing. Clinical incubation period is very long, months together. Usually it will be 8 to 6 months, but even years together, years after, the disease will appear after the entrance of the microfilaria in the blood. So longer incubation period is also a challenging period. And finally, the migrant people, like malaria, filariasis is also, the migrant population is one of the posing a major challenge in Tamil Nadu. Last year itself, we have detected more than 100 cases of migrant filaria positives in few of the districts. That is the important challenge. In future, regular screening of the migrant population is the important criteria for the filarial elimination. Next. So that's all about the challenges in the malaria and filaria elimination. Thank you so much.
Thank you, sir. Nice presentation about last mile challenges in malaria and filaria elimination. He insisted on active surveillance as well as passive surveillance. What are the challenges we are having? He highlighted, especially the passive surveillance in the hospital setup as well as private hospital setup, as well as the main challenge is migrant. We are doing the microfilaria night blood smear for migrant population. The survey is continuing, but similarly, we have to conduct a survey for migrant population for malaria also. That is one of the point take-home message. Another area is the capacity building for the healthcare worker as well as the entomological team. There is a need of our. We are in the initial remarks by our director, he insists on capacity building and the right people for right post. That is the entomology wing. We are giving that lateral entry to the health inspectors, to the junior entomologists, thereby the DMO like that. Now we are direct recruitment of, we are think of direct recruitment entomologists. We place the policy to government. I request to all take the message. What are the area we are weak in area? You have to sort it out. Any question from your side? Any question from audience side? Yeah.
Good morning, sir. I am Raghunath, BSc Public Health student from Ramachandra University. So you mentioned surveillance and control measures for rural, urban, coastal and riverine areas. Then what about tribal communities, sir? So on the tribal community ku or outbreak vanda, so avangaloda cultural belief thandi andha edathila nama eppadi control measures implement pannalam?
Yes, actually tribal malaria is also an important thing actually. We are actually tribal malaria in Tamil Nadu. Tribally, we are doing the regular surveillance, active surveillance by our health inspectors. And apart from that, some of the people are going for the wood cutting in the forest regularly. to the nearby Andhra Pradesh and other places, Kerala and other places. When they return, some of them are contracted the Plasmodium falciparum infections. So regularly we are identified those who are going regularly to the wood cutting work into the forest. When they return, immediately they are screened by our health inspectors, and if they found any positive, they are giving treatment immediately. That tribal malaria surveillance is happening regularly, especially in the Vellore, Thiruvannamalai and Salem districts, some the hilly, some area. Those areas happening regularly, and Dharmapuri also.
Thank you, sir.
Thank you, sir. Now let us welcome Dr. Kalpana Barua, who will be joining us online to discuss about last mile challenges in achieving malaria and filaria elimination. Dr. Kalpana Barua is a senior consultant, National Center for Vector-Borne Diseases, and she is a distinguished medical entomologist and vector control expert with 38 years of experience. She has been associated with the National Center for Vector-Borne Diseases since 2004. Since 2006, she has led Dengue and Chikungunya Division of National Vector Control Board, where she has been instrumental in developing surveillance strategies and enhancing integrated vector management initiatives. Welcome to the session, ma'am.
Thank you very much. So, good afternoon to all. Am I audible? Can you hear me? Dr. Badivalan, am I audible?
Yes, madam.
Okay, thank you. So, respected chairperson, dignitaries and friends. So, first of all, it is my apology for not attending this important conference in person, though I wanted to be. Due to some important meeting at the last minute, I had to cancel my program. So, however, I got an opportunity to be connected with you all online. So, I'm really fortunate for that. And thank you all for that. Congratulations to the organizers for organizing this 3rd Annual International Public Health Conference. And I'm wishing a great success to the event. The topic given to me is last mile challenges in achieving malaria and filaria elimination. Next, please. So, next. What happened? Yeah, these are some of the glimpses of the activity. Now, all of you know that for malaria elimination, the country has been categorized into a different category, like category 0, where there is no malaria at all. Then category 1, category 2, and category 3. Category 1 is that state and UTs with API less than 1 in all the districts. Category 2, that is state and UTs with API less than 1, but some districts are having more than 1. And category 3, that the red one, it is API more than 1. And you can see the comparatively 2015 and 2023, when we have started, the government of India has started the elimination process. That time the basis was on 2015 data, and in 2023, out of these 10 states in the category 2, remaining 8, it has either become category 1 or category 2, but 2 states, that is Mizoram and Tripura, they are having some international borders also. They still remain to be one, there is no challenging for malaria elimination. And in 2015, there were no area with 0 category, but now we are having 0 category 3 states or UTs, that is Ladakh, Chandigarh and Lakshadweep. They are having 0 malaria, indigenous malaria transmission. Next, please. You can see the cases, how it is declining. And, for last 2 years, India has achieved a lot in 2022 and 2023 in the World Malaria Report also India has been applauded for the achievement. Next. So annual parasite incidence also you can see in 2015 it was 0.92 and it has brought down to a significant level, and it was sustained at 0.1 hovering over like that for last 2 to 3 years. And last year, due to the improved surveillance in certain areas, the little marginal increase has been recorded. And in 2023 annual blood examination rate, so if you see it, it was it was less than 0 initially, then it was brought to the near to the brought to the 10, not 0, sorry, which is the national target. During the COVID time, it dropped. There was a dip due to this COVID activity, but even then our surveillance was ongoing, and now there is a significant increase in 2022 and 2023. That's why in 2023 cases were also increased. Next. But there are certain districts, you see 33 districts, which are the most problematic districts, and you can see they are having more than API1 and they contribute 70% of the country's cases and 55.4% of the death due to malaria during 2023. Next. So Government of India has taken many initiatives. Launch of National Strategic Plan from 17 to 2022, and when the 2022 there's no strategic plan period was getting over, then the second plan for 23-27 was also prepared and it was launched last year. Then Government of India has come out with the Tribal and Forest Action Plan, in collaboration with Ministry of Tribal Development. So that because tribal areas get special focus and we are having certain problems in those areas to eliminate the residual foci. Then enhance intersectoral and interministerial engagement. So malaria is one of the 12 basic health packages ensured at Ayushman Arogya Mandir delivered through CHOs, community health officers. It is delivered. So it got now priority. So district action plan for all those 33 districts which I have shown there, the specific district action plan has been developed for all those districts. And for near real time, there is reporting. IHIP has been onboarding of the IHIP has been initiated. States were trained, and many states have now started paperless reporting. Next. So key achievement, you can see the cases declined by 80.5% and death by 78% in 2023 when we compared with when we started in 2015. API reduced to 0.16 from 0.92 in 2015. And the greatest achievement is 122 districts reported 0 malaria cases in 2023. And out of that, 56 districts continuously for 3 years they have reported 0 malaria. That means they qualify for subnational malaria certification also. So high burden districts with API more than 1 reduced to 33 from 155. Saturation of all subcenters more than API 1 with LLIN. Then IRS is also selectively done. All 36 states and UTs onboarded with IHIP, as I said, and 18 states have now started paperless. Next. but there are certain key challenges. Those 33 districts, as I have mentioned, where possible solutions are that special focus, action plan has to be there, then the intervention has to be separate for those areas. And the tribal area, which contributes almost 64.58%. So for them also separate tribal action plan prepared. Then surveillance and involvement of the private sector, timely preparing the report, these are also challenged. For that, we are ongoing mapping on inclusion of the private sector. Then involvement of the traditional healer, because in the tribal area, most of the people initially they go to the tribal healer for their for their treatment. That's why a decision has been taken that the tribal healer, if they are providing some treatment, there should not be any wrong treatment. So they are also getting sensitized so that they know the regimen of malaria, so that before many a time it is observed that when the case deteriorates a lot at that time at the terminal stage, they will be saying that now you take the patient to the hospital. So that's why the tribal healers they have to be sensitized. Now these go back. The districts, as I have said, 122 districts, they have reported zero malaria in 2023, and 56 are maintaining for last 3 years, 21 to 2023. But it's not mean that they are safe from reintroduction of malaria by importation of Plasmodium parasite via the movement of infected people. That is the key challenge. So regular entomological monitoring to assess the receptivity of these areas are to malaria transmission, that has to be monitored. And our entomological component, it is a bit strong in Tamil Nadu in compared to the other areas. So Government of India is trying to develop the capacity. We have organized 9 trainings also for the entomologists, so that whatever the entomologists we are having, they are really their capacity is built, and the district VVD consultants, they are also well versed with the entomological monitoring, and they can undertake the surveillance. Next. Next. Filaria, as you are aware that Filaria is another disease. 3 diseases are targeted for elimination: malaria, filaria, and Kala-Azar, that is visceral leishmaniasis. And Tamil Nadu is lucky that you don't have that disease. And filaria, it was endemic in 20 states and UTs across 345 districts. So out of that, 7 states, including Tamil Nadu, has stopped MDA. So 138 districts, that means out of 345, 40% has stopped MDA. 159 reported microfilaria rate more than 1, and they are continuing with annual MDA. And in August, this August 24, 63 districts of the 6 states, they have they got 25 got double drug, DEC and albendazole, and triple drug, DEC, albendazole, and ivermectin, 38 districts. Knowing the problem only since 2018, this triple drug strategy was initiated. And it was now in 74 districts, they are under this triple drug. And 48 districts are in various stages of assessment, that is TAS 1, TAS 2, TAS 3. Next. So this is the disease burden as per 2023. There were more than 6 lakhs of lymphedema cases, and then hydrocele cases more than 1 lakhs are there. So morbidity management and disability prevention kits, MMDP kits were distributed there, but distribution is not the end. So the patients, they need to take proper care and they have to utilize this kit. That is a challenge. Next. And you might be aware that initially in 2004, when we initiated the Filaria elimination strategy was two-pronged. We used to say two pillars, that is MDA, annual mass drug administration to interrupt the transmission, and morbidity management and disability prevention to reduce the suffering for the individuals who are already infected. But realizing these issues, so it has started, 5-pronged strategy, and it was released last year in the January 2023 by Honorable Health Minister. Those strategies are mission mode annual drug administration, at one in the February and the other one in August. Then morbidity management and disability prevention with focus on early diagnosis and treatment with engagement of medical colleges, integrated vector control with multi-sectoral coordinated effort. Earlier you can see the vector control, when the elimination strategy was initiated, it was thought that only MDA is enough to eliminate the filaria. No need to continue the vector control part, but now it has again brought to the, as a main strategy. Then high-level advocacy with allied ministries such as water and sanitation, Panchayati Raj, education, rural development, urban and rural development, etc. Then leveraging existing digital platform for lymphatic filariasis and explore alternate diagnostics. Next. See, these are the recent achievement. We have started in the mission mode 10 February and 10 August. And one of the very revolutionary change, that is we shift from of the focus from distribution to consumption. Earlier, the drug distributor used to visit the houses and they provide the drug there and they leave it with the community. Whether they take or they are not taking, that depends on the community's will. But now in front, like TB, DOT, here it is DOC, directly observe consumption. In front of the distributor, the drug has to be consumed. So 170 districts in 12 states conducted mass drug administration in 2023. And there, 82% of the coverage among the total population was reported. And you see, 96 districts, they conducted MDA in February and coverage was 95% of the eligible population. 199 medical colleges, they have been engaged for this, evaluation of MDA. Then engagement of the allied department for Jan Andolan to eliminate the LF by 2027, and there is NITI Aayog also reviews for the aspirational districts where LF is a problem. Next. So mission steering group approved the additional monitoring and social mobilization support, that is 13.95 lakh per district for 10 high endemic block, and piloting and onboarding of the IHIP, line listing of all the hydrocele and lymphedema cases, and then training of the trainers on this lymphatic filariasis microscopy in collaboration with ICMR BCRC at NRL at our headquarters. Next. So these are some glimpses of the achievement. Next. But what are the biggest challenge? Routine activity. So efforts not matching leading to suboptimal compliance even in MDA with your IDA at ground level. That was the challenge, due to which now DOC strategy has been brought, directly observed consumption, clearing all the 3 tasks. So test of partial success and failure by some districts in clearing the task. That's why it has brought to the block level now. Earlier days, at the days, our units were district level. Now it has there's smaller units have been made. Then these 3 VVDs are targeted for elimination. So districts and the this health workforce, it is a burden. They feel it is a burden that they have to work for all these 3 elimination diseases, and then outbreak prone diseases are there: dengue, chikungunya, Japanese encephalitis, and other state specific diseases. So MF survey block level to the implementation unit and the related funds, sometimes it also poses as a big challenge for the states. And FTS, for these tests, we need the FTS, but it is a WHO supply. It is gratis for WHO, and many a time we are not receiving timely and unable to supply to the states. So Government of India is trying to explore some other sources so that we can get the FTS on time. MMDP clinic, one at each implementing unit, have to get in the block level. That has to be ensured. And LF entomology and vector control and post MDS scenario, this is yet to be ensured in all implementing units. So who are entering in the post MDS stage. That is also one of the biggest challenge, and we need to plug these issues so that there is no resurgence, or we can find out any residual foci. Next. Thank you. Thank you. You can stop sharing.
Thank you, madam. You presented present status of India, states of India. Tamil Nadu concerned, only 32 districts free from malaria eliminations, only 60 districts less than API less than 1. Filaria concern, we cleared all task 3 survey. Now we are doing morbidity management and disability prevention, as well as surveillance on migrant population is going very well. We are doing very well, madam. Any question, audience, to madam, from audience side?
You can take the question. I will be responding later on because I was waiting for the morning, rescheduling the meetings. Okay. So if you have any urgent 1 or 2 questions, I can take. Otherwise,
thank you so much, madam.
I would like to.
Please continue.
I would like to express my gratitude to both the speakers for their insightful presentations. Thank you, ma'am. Thank you, sir. Now I request Dr. K.C. Cheran, Director, Madras Medical College, in the cadre of Additional Director, to honor our speakers, Dr. Vadivelan with a memento. And we thank Dr. Kalpana Barua for joining us online.
Thank you. Thank you so much.
We also request sir to present the moderator memento to Dr. Sampath, Additional Director, Communicable Disease. Thank you.
We request Dr. K. Vinay Kumar, JD Immunization, to moderate next session, please. DPHICON2024 renders hearty welcome to Dr. Sundararaman, Chair Health Technology Assessment in Technical Advisory Committee, to explicate on interface between primary health care and Chief Minister's Comprehensive Health Insurance Scheme. Sir secured MD in Internal Medicine from Madras University. He has worked for 22 years as faculty in Internal Medicine in Jipmar, Puducherry. He served as Dean in School of Health System Studies in Tata Institute of Social Sciences and Jawaharlal Nehru University. Also continues as adjunct professor in JIPMER's International School of Public Health and in the Department of Humanities in IIT Mumbai. Sir was awarded with the K.N. Rao Memorial Oration in the annual conference of the Indian People's Health Association 2021. He was Director of State Health Resource Center, Chhattisgarh, and was Executive Director of National Health Systems Resource Center. Currently, he chairs the Technical Advisory Committees for Health Technology Assessment of the Department of Health Research, Government of India. Thank you.
So good afternoon, everyone. I extend my sincere thanks for Professor Sundaraman sir for accepting the invitation to attend this conference and deliver an important topic on the role of interfacing primary health care with insurance scheme. We know the CM insurance scheme is happening since 2008 and 9, and now it's a time for us to interface the primary health care setup into the insurance scheme. I request the audience to make the best use of this and get the inputs from him. Thank you, sir, and the forum is for you, sir. Thank you, sir.
Thank you. Can we have the slides?
Slides, please.
Slides. So, I was listening to a number of the impressive achievements the state has made. A role I have served even now as chairperson of the advisory committee is actually to point out some of the problems that you are having, the challenges you are facing, and the future directions that you need to go. I would have liked to have shared the full details of the CMCHS report of the committee with you, but it's still not in the public domain. But there are certain insights related to primary health care that I would very much like to share with you because of this particular reason. I'm therefore going to take my 10-15 minutes and to actually talk about this problem of primary health care. Because I noticed that even in this audience, we are all primary health care, but the interfaces that we need are not in the room. So we call this preventing fragmentation of care, building synergy between the different components and moving to the right to health care. Why is synergy required between primary health care and secondary and tertiary care? We do our thing and they do their thing. Is that not enough? But we know it is not enough. There is no effective primary health care which is not backed by appropriate secondary and tertiary care. You take care in pregnancy. You spend so much time doing antenatal care to detect complications. But if you detect complications, to handle it requires secondary or tertiary care. Otherwise, the lives you save will be very limited. This is true for almost every other area. Okay. And the second thing is that for a patient, if I am a pregnant woman or if I am a person with the diabetes and a cardiovascular condition, I require follow-up at different levels. I am not bothered whether this is primary care or secondary care or tertiary care. Sometimes I need a specialist, sometimes I need just to take my regular medication. But if my regular medication is at one department and then my specialist care is another department and they don't connect, continuity of care is not established. And when we talk about this notion of people-centered healthcare, this is a big buzzword around. What we really mean is how do you break fragmentation and ensure a continuity across the boundaries of care providers. And it's not as if it is only you who require CMCHS help. I can tell you as chair of the committee, the CMCHS desperately needs your help also. And therefore, working together is 1 + 1 is 3, or I would say 1 + 1 is 5, not just 2, because the coming together is giving an added value that both by themselves cannot give. Now, the strengths of the Chief Minister's health insurance scheme, we all know. For one thing, it has legitimized financial protection as a goal. Before also we practiced it, but now there is an acceptance of it. It has improved access, it has annual performance in numbers is huge and impressive. And there is a mix of services available now with the public provider. Before, the public hospitals would not get into high-end quaternary procedures. They would be doing ordinary level secondary care. But whether it is a joint replacement or a liver transplantation or a renal, the public sector has been incentivized and motivated to come in. And this whole new medical colleges you have built depend critically on CMCHIS to provide the range of care. It has made a template of how you can engage with the private sector. It has put in place the dimensions needed for universal health care, digitization, monitoring, grievance redressal. There's a very good interface with an independent emergency care system and a huge number of quaternary care also, what we call, in place. So I am going to talk of the problems, but please remember I said good things about CMCHIS before I went into the problems, because sometimes we get a bit challenged when we talk about that. But there are limitations. If we don't understand the limitations, we cannot move. To a small percentage, getting a card is still a problem, 12 years after we started out. And many services are not part of the package. So if I go to a public hospital, only about 20% of services are technically, even by rules, qualified as part of the package. In a private hospital, the access may be less. Locating a provider is not an easy issue, because for this particular treatment that he requires, which provider offers care under the scheme is a non-trivial question. Even doctors guiding them doesn't know it. Public provider denial has been a problem despite a clear rule that no person can be denied care due to the absence of a card. There are still many micro-level problems why it occurs. Private provider denial can be even the norm. Insurance denial because of so many procedural papers. So if there is a delay in filing the papers of 48 hours, then it's denied. But as you have argued, that the entitlements of a patient to care cannot be abridged by the failure of a procedure by a provider, and therefore there are issues on that. And finally, denial of cashless care, though there is the norm. But what can primary care do about it? I do not say they must do about it. This is something that you can do even now without any government order. You don't need a government order to do it. But there is a role of government orders and there is a role to make it obligatory, and one must see on this. First, I don't see why there should be anybody without a card or referred without a card, because you know the population in your area. You have made population-based registries in some place, and it is not too difficult a matter to check whether all of them have a card, especially if we universalize, but even otherwise. Second, there are many functions you do, like pregnancy registration, like registration for non-communicable disease treatment, for medication of compliance. Whenever you make a reference, why should it be that you refer a patient with a CMCHIS card and the patient goes to the hospital and there he is told that you have not brought the card? If you have made the reference, it would have been worth your while to remind the patient of do so. And there are so many IDs, patient IDs floating around. You need to make sure they are aligned at some point. And the worry is not that our coverage is weak. The worry is that some of those missing the card are the most vulnerable. So I am not worried that some people are not having the card or making misuse of the card. I am worried that some of the people who desperately need the card otherwise will not get any treatment, and these most vulnerable, only you at the primary health center know, the migrant community, the illegal migrants, many different people who are there and not categorized, and you need to map the vulnerable in your area. This is much, much more a problem in the urban PHC, where you have homeless people, you have street children, and at some point the notion of vulnerability requires the primary care provider to have a special attention to it. And finally, our messages on basic health education do not even tell what are the details of the entitlements under the scheme. If they face a denial, they don't even know why they are denied or what they can do to avoid that denial. So I think the primary provider as friend and guide, as a family provider who is a help to them, is a role that we must all uptake as one of the central roles of primary providers. But then there is another role, the role which in international journals you will find it under the role navigation. Navigation we use for ships. But even in the USA, navigation is an important role of primary care provider. When you go with, suppose you have been detected with a breast cancer suspicion, where to go, how to get care. If they delay, what do you do? If they say, no, come after 1 week, we need those tests, what do you do? How do you cope with it? Finding the appropriate provider is a challenge. It is not possible. People tell me that you can go to the website and see. I can't find it out from the website. There is a call center that is effective, but don't expect the patient to ring up the call center. Your staff, your providers in the hospital can ring up the call center and see this patient seems to have glaucoma. Where should I send him for a good glaucoma referral? That facility is available. Never refer a patient without knowing where to refer to. And every primary care provider must have a list of priority sites for the appropriate referral for each clinical difference. All referrals must be facilitated and no denials due to a lack of cards. So at this complex is something that the primary care provider, we are referring. It's not that we are not referring. We are making referrals every day. But exactly having in the district a card devised for every primary care provider so that he knows where to refer is another thing. And you know, there are NGOs that are providing referral for ethical providers. There's one NGO in Dindigal, Piney area, which rings up, people contact them, they say, go here, they don't make the charges. Don't go there, they will make charges. If they can do it, certainly we should be able to refer and look at the rate parts. The second set of problems regarding CMCHIS relate to the fact that they have a budgetary constraint. Eventually, the package is small because the budget is limited, and therefore a number of techniques are used to keep it within the package. Now, there is nothing much we can do with the CMCHIS budget, but one thing is there. A majority of the cases that go there, the caseload of cardiovascular and this could definitely have been reduced. But very selective care, supply side inequalities, insurance, package rates. These are the problems of CMCHS. Now I come back to what will synergy with the primary care provider do for these problems. The first set of problems related to the card and access. These are supply side problems. One important point I want to make is that synergy is life-saving. In the 30 to 70 age group, Tamil Nadu has a very high level of what is called preventable mortality. And within that, the death rates of men are 3 to 5 times higher. We have a scheme from the Chief Minister for providing support to single women households. But many of those single women households are not single due to desertion. They are single because of death, premature mortality, which is largely cardiovascular in origin, but it is also renal in origin. When I was visiting places as part of the committee, I expected renal failures to be old people, but I am surprised that renal failure is so common even in a younger age group nowadays. And this is all undetected hypertension. So you cannot, to give all of them care as CMCHIS is unaffordable if you do not reduce the load of cardiovascular, chronic respiratory disease. It also won't save lives. Once a person has a heart attack, the fact that he can achieve is not the best thing. To prevent that is important. And it's always the combination. Like Makkalthediya Marutvam is a great scheme. But its effectiveness in health outcomes will be seriously limited if you do not have the referral backup in place, and that referral backup gets facilitated.
Sorry for the interruption, sir. With your permission, may I request a silence, please? Excuse me. The audience, please behave. Please keep silence. Because the topic is discussing may be not useful for you, but for other participants. Please be silent. You can't browse it from the internet.
And my apologies for standing between you and your lunch also. So I understand that, but this is a thing. And outcomes depend on sustained follow-up. So most care is not, CMCHS only covers a procedure. It does not cover coronary heart disease. It covers a stent or a bypass surgery. But you need before and after. If you're doing a joint replacement, you need physiotherapy before or after. It is not covered by CMCHS. And to do that follow-up at secondary care is very inefficient and very costly. So the need for much more effective this is there on that. So the same point, so it is synergy is cost saving because routine follow-up, a lot of it. Why must a person with mental health disease line up at the medical college to get 2 weeks worth of drugs? If it is for consultation with the psychiatrist, one can understand. It is cost ineffective to provide care that way. In a country like Australia, 80-90% of this regular medication is accessed at the community level. Over here, it is 80% of essential medicine will be at the medical college level. And therefore, this synergy makes care much more affordable for a system. When we were not paying for tertiary care, it did not matter to us. Because some fellow takes the care. That is not the way government should be. But once we have declared a Chief Minister health insurance program and we are taking that burden of that care, we are unable to cope with both burdens unless we can see them together. And finally, I must emphasize that if we are able to take both of these together, then the right to health care becomes possible. Without this synergy, you cannot have. It is only fragmentation. People's right to health care, that entitlement is registration in your primary health center, the health and wellness center. A mandatory registration through which, if you are referred, the care at the higher levels will be free. And it will be efficient. And boards, the first three of it, in theory, already exists in Tamil Nadu. Tamil Nadu, I would say, is the problem of having universal health coverage without necessarily having universal health care. Everything is done. Everybody is covered. But having said that, your premature mortality remains extremely high. Maternal mortality is different, but premature mortality, and that is because of this gap. And these last two, when the budget allocation becomes, so now in CMCHS you are responsive to the volume of services, yes, volume of services that you provide. That same logic extends in right to health care to the entire range of services. And the second thing is that the referral is not obligatory. You cannot be turned away at the door. You have to be reached to next. So you go on breast cancer. For example, I know in JIPMER, sometimes waiting list can be 3 months. What does it mean to have an early detection of breast cancer if my start of treatment will be 3 months later? It means nothing. It's actually criminal in most parts of the world. It's a 28-day standard, non-punishable up to 6 weeks. That should be the standard. But that means JIPMER gets 63 new cases of breast cancer every week. How can it cope with that cumulative load unless there is a system of mandatory, obligatory referral where if your public system gap is there, you can bring in the private sector. That you can do now. You can see the complementary strengths On one side CMCHS and another side primary health care. This has a certain system of identification, that too. There is digital architecture. The public financing system should learn lessons from each other. There is a comprehensiveness in the primary care, the care packages. And whereas the CMCHS has an individual grievance redressal system, primary care has community-based systems in the form of the district health assembly, in the considerable engagement with local bodies, etc. So bringing it together, both sides of these halves into a program, this integration, and I'm going to take my liberty to make this comment, is more difficult at the level of the directors and easier at the level of the facility. The down you go, easier to integrate. The higher level you go, more difficult to integrate. But these are things that are essentially needed, and you do need a legal framework for that. So why is a right to healthcare desirable in a Tamil Nadu context? Firstly, that everybody needs to know an entitlement and where it can be exercised. If I have a ration card, I know where to go to get that rice for you. I can't go to any shop. Similarly, the establishment of a care pathway as a mandatory, obligatory system is a cost-saving and life-saving device, preventing indebtedness, improving the financing of public institutions. That is all you are struggling with, and ensuring equity and social justice. It's also required, these are the larger political reasons, for preserving federalism. Otherwise, you're going to have a central act, and it's not good for you. In many places, they don't have a public health system of this size and this depth, so they won't lose as much as you would lose if there is a privatization push that comes through. And therefore, if you need to even safeguard public health services, I think it is important that it is protected by a legal framework, ensuring public health services, fulfilling obligations, and we all aspire for a 1 trillion economy. Why do you need a 1 trillion economy if you cannot guarantee right to health care? And how do you get to a 1 trillion economy if you do not have right to health care? The CMCHS also teaches you the terms of engagement with private sector. Simply put, it's voluntary, never mandatory. Try to make it mandatory and you will have the Rajasthan disaster. Rajasthan was a bad act, badly passed. You never should have tried to make it obligatory, and later on withdrawal is not the issue. And the way it is costed and priced, there are technical issues about it. So let me just conclude with saying the linkages across levels of care are essential in universalizing healthcare. The incidence of the three main consumers of the CMCHS budget and the main causes of mortality both require the synergy between primary care and secondary care, and the challenges faced are completely similar in many ways, and we need to do that. We have, please, if you can note down, many of these things will be available on this website and these links. We have a regular thing on the problem solving and the challenges that we keep going on that. I think it is important that we keep ourselves abreast of the policy dimensions of our work and don't leave it to many of these work. And I would make a strong call for two good programs, but they need to come together to make it much, much better. Thank you.
Thank you, sir. So thank you, sir, and for the wonderful presentation on this interfacing the primary care with the CM insurance scheme. So as a public health administration and as state health administrators and my fellow district administrators, what the lessons learned from your presentation is the take-home message, sir. We are discussing about the premature mortality as well as the maternal mortality and many other factors. The scope you are giving right now is about taking this interfacing system, a synergy model of primary health care into the insurance scheme may help us, may give us an answer for this decreasing the maternal mortality or the premature mortality also. So it's a very good eye-opener presentation for our district administration as well as state administration. We'll definitely take a call with the state authorities, sir. And again, you also said about the continuity of care, and the patient is not bothered which center they have to go. Ultimately, they need the continuity of care. With this, I think it's a great presentation from you, sir. And any questions from the audience, please?
Sir, good afternoon. I'm Dr. Ajit, District Health Officer, Mailadurai. So, in addition to the points that have been discussed, I would like to bring to consider one more point into this scheme. So, the allocation of insurance amount that has been given to hospitals always neglects the primary care part. We do not receive any allocation from the insurance costs that have been recovered. So, for example, I will take the RBSK scheme. It takes a great deal of effort and time to mobilize children to have their cardiac surgeries done. There are unwilling patients who needs to be convinced, make multiple visits. So we do all these things. So when we finally get them to the hospital and get the surgeries done, the insurance cost is being claimed only by the tertiary care center or the secondary care center where the surgery is being done. But the cost, the part of amount that I'm speaking is the upgradation, hospital institution development cost that has been allocated as a part of CMCHS. So that's being given only to the primary care center. It doesn't include the it doesn't include the primary care center. It is given only to the medical college hospitals or private hospitals where it's being done. The effort that's being put before that, it's completely being neglected. And regarding, this is one point, sir, I need your inputs on that. The second point, still they are insisting on physical cards. We have come to an age where digital cards are being accepted. For example, I will take the driving license. Even the police have begun accepting digital cards that are stored in DigiLocker, apps that are officially from the Government of India. And I feel it's time to take these into the next level, apart from ABA ID. Thank you, sir.
Thank you. I think the point on primary care linked costs is well taken. Other than what I am saying in the way we approach it in right to health care, it's difficult to give cost by cost for each referral. You would not like it because your paperwork will be too much compared to the money you get. The money you get will be small, the paperwork will be large. So people who do this financing do it in a different approach. They look at the total number of people of a particular category you save and give a lump sum cost to that. So yes, such financing should reflect your larger service. That is something that is important to bring about. But two, it need not be delivered in the way the classical fee-for-service insurance is delivered. So you get that. It is not there, but it should become there. The second was on, yes, on, if you ask the insurance, and I've asked as chairperson, according to them, it's already there. So you are saying it should be there. They are saying, no, if you give the number, we can detect the card. And since it is linked to ration card and Aadhaar number, if you link Aadhaar number or ration card number, we can extract the CMCHS card number. You do not need to present these three cards as physical cards. However, in all humility, I agree that what you say is the problem. Though the rule-wise it is not there, in practice, insistence on a card is more common, on a physical card is more common than it ought to be. Some of it is what she will call informal forms of rationing. You have to find some reason to keep the claims low. But some of it is just pure, what shall I say, pig-headedness. They are just being stubborn. No, actually we should insist that the number, the production of a number and any one of these three identities, Aadhaar there is a problem, but they say for CMCHS that ration card they will back and forth. From this to that or that to this is guaranteed. And you don't need the physical card. That is the contention. Okay? So we need to make sure that it is there in policy. I hope when the report comes out and some of these are part of the public domain, you can enforce these things better.
Got the answer, right? If my understanding is right, sir, to answer his question, he called us two answers. So one is the allocation to the primary health system. So if you follow this concept of synergizing the activity of primary care into the insurance scheme, definitely the procedures will be included in the insurance scheme. We may get the revenue of it. That's point number one.
But not through the insurance.
Not through the insurance, yeah. Again, the second point is about, we have the presentation from Rahul Pandey coming out with the integration of IT platforms. That may be a solution for your answers also. Thank you. Thank you. And
thank you for enlightening us, sir. We humbly request Director Nirmalsan, Joint Director MCH, Dr. Nirmalsan, Joint Director MCH, to felicitate Dr. Sundararaman. We also request you to felicitate the moderator, Dr. Vinay Kumar, sir. Thank you, sir. DPHICON2024 renders hearty welcome to Dr. Ramya, ANC Technical Officer, WHO, to moderate the panel discussion on strengthening antenatal care services and way forward to ending preventable maternal mortality. We also welcome the chairpersons, Dr. Krishna Leela, JD Maternal Health NHM, Dr. Pushpa Chowdhury, Team Lead RMN CAH, and the panelists, Dr. Uzge Tunka, Medical Officer WHO Geneva, Dr. Hidie Mataz, WHO Geneva, Dr. J. Nirmalsan, JDMCH, Office of Directorate of Public Health and Preventive Medicine, Dr. Kalu Sivalingam, DHO Sivakasi, Dr. Yasoda Mani, DHO Virudhunagar. Welcome all.
I call upon Ozgi to continue the presentation from HQ.
Thank you very much, colleagues. Greetings from Geneva, Switzerland. We would have definitely wished to be there with you on site. Unfortunately, we couldn't, but thank you very much for accommodating us online. I think we're going to start this presentation, and my colleague, Dr. Mertash, will be taking on to tell you a little bit about how the antenatal care recommendations and guidelines came about at the global level, and how, with the trailblazing efforts in Tamil Nadu and with partnership with India and other countries, that we've actually been seeing how we can implement it in an efficient, effective, and in a way that actually improves quality of care for women and communities with this implementation research, in the context of implementation research. So it is a great pleasure for us to be here to share some of this thinking and some of this work with you. And with that, I will leave the floor to my colleague, Hidie. Over to you.
Thank you so much, Özge, and hi, good afternoon, colleagues, and thank you for tuning into this session. We're really excited to present our sort of global level recommendations on antenatal care. So just to give you a snapshot of how the guideline development process occurs here at WHO, and specifically for this set of recommendations, it's a rigorous process that follows multiple systematic reviews and really taking on an evidence-based approach and person-centered care approach to develop the guidelines. And here we just have a few of the publications that were used to inform part of this process. Next slide, please. And so as a result, in 2016, the new antenatal care recommendations were published. They're grouped under 5 areas: nutritional interventions, maternal and fetal assessment, preventative measures, interventions for common physiological symptoms, and health systems, in addition to other routine ANC recommendations that were used as part of the guideline, totaling up to around 49 recommendations. Next slide, please. With the overarching aim to provide women with respectful, individualized care to ensure clinical practices such as tests and interventions are provided in a timely manner, inclusive of emotional support and well-functioning health systems. So really taking on this really holistic approach to be able to deliver good quality antenatal care services for women. Next slide, please. So just to give you a snapshot of what some of the key updates were in this document. So previous to the 2016 ANC recommendations, the number of contacts were 4. But based on new evidence, the contacts are now up to 8 weeks, up to 8 contacts, up to 40 weeks. So encouraging, it's part of to encourage women to attend antenatal care sessions more as part of their pregnancy journey. And what is a contact versus a visit? It's really about having all the outcomes improve towards maternal health. So really ensuring that all the tests and all the different areas that need to be addressed are addressed within those 8 contacts. Next slide, please. Thanks. And the other one was around ultrasound. So recommending ultrasound before 24 weeks and initiating early ultrasound for women to ensure that anomalies and other issues are addressed. And the other area was also health systems. So ensuring that there's continuity of care and integrated as part of the continuum of maternity care, and ensuring that health workers have what they need to deliver a good quality of care. Next slide, please. So we have the global recommendations that were evidence-based, and we just gave you a snapshot of sort of what the recommendations were. In addition, WHO has developed an adaptation toolkit. So this was the adaptation toolkit and monitoring framework that was used by the countries in the study, but also available to use for countries globally to be able to adapt the recommendations to the global setting. As we know, different settings have different contextual requirements. And so as part of that, as part of this process, we have an adaptation and tool and monitoring framework that countries are able to use to adapt these recommendations. And our colleagues in both Tamil Nadu state and Assam, with our partner DPHICON, were able to use this to be able to adapt the recommendations to the local setting. And our colleague Ramya will go through how that was contextualized and operationalized in India. Next slide, please. So just to give you a background of what we wanted to give you a quick snapshot on. So we also, as mentioned, like we have the adaptation toolkit, we have the guidelines, but how can we actually implement and test and evaluate the effectiveness and the acceptability and feasibility of this package contextualized across different studies? And so that's how the new antenatal model of antenatal care in Africa and India research study came about. It's an implementation research study using these guidelines with different adaptations across different contexts to really transition from the planning phase and having a sort of set of recommendations to how do you actually now test these country-specific practices and ensure that we have the right results to be able to move forward for sustainability and scalability of these recommendations in country. And so it's really been a collaborative effort over the past 4 or 5 years with the WHO country office, with regional office, with the national ministries of health, state health, other partners, including DPHICON, for example, in India, and local research partners that have really been able to form this consortium to move this research forward. Next slide, please. So just to give you a snapshot, it's happening, and it's this testing of the applicability of these recommendations has occurred in 4 countries: Burkina Faso, India, Rwanda, and Zambia. And specifically in India, as you may know, it's been in Assam state and Tamil Nadu state, and the results will inform hopefully what will happen after. So next slide, please. And a brief snapshot of how this study was actually designed. It's a stepped wedge cluster randomized control trial. So since it's a large package, a step wedge control trial allows you to implement the package in various intervals. So it's not that, every facility receives the package at the same time, which then could potentially overwhelm the health system. And so in this sequential manner with a step wedge control trial, it was done across 6 periods, each period consisting of 4 months. So in India and Burkina Faso, these were done in 4 clusters with 1 to 2 facilities per cluster. And so there was a baseline to be able to baseline both quantitative and qualitative to be able to assess sort of what the formative sort of what is the understanding of ANC services, and then the adapted package was implemented across each country. So this is just giving you a snapshot of how this was, and then by the end of period 6, all facilities were receiving the package, which is really exciting then to see sort of over time how the implementation of the package was received. Next slide, please. And in order to support sort of how this was implemented, there was a series of co-interventions that were developed, which include training of staff on the ANC package, supportive supervision on the recommendations, ensuring availability of supplies and commodities such as tests and other areas and for supplies that are needed. Community sensitization, as we know, or the ANC initiation, is critical to have sort of a community component that's contextual. And also there was a digital component in certain countries that wanted to test the package digitally. Next slide, please. And so this is just a snapshot of our outcome indicators. Our protocol is published online, but just to give you a snapshot, these were some of the outcomes that were around sort of early initiation of ANC, syphilis, hemoglobin testing, and then total number of ANC contacts for us to see the trend across time and to be able to, advocate for the fact that this was successful and that we can really plan for sustainability and scale up. Next slide, please. And just to give you sort of looking into the future, what can be done. So WHO is now shifting from the ANC recommendations that are, of course, it's a document, but how do you actually now integrate this as part of countries' digital health systems? And so moving to that, we have this is just a snapshot of how one can transform the guidelines into a digital module that can be integrated within the current digital systems or used separately within facilities as part of that. And so it's just sort of next steps for like how the recommendations can be used more effectively. Next slide, please. So looking into the future, I've mentioned that giving hints of what we're really anticipating in the next couple of months and the next year. So really we're now wrapping up the study. Tamil Nadu has just finished their study. Assam, we are cleaning the data. And so we're working with all the country partners across those 4 sites to publish the results of the study, which will be critical and crucial to sort of inform the next point that I have, is to engage with stakeholders that are in the room. I apologize that we're not there, but to engage with you on dissemination and planning of how we can now sustain this package and sort of move forward to make sure that it's embedded within the health system. And of course, to incorporate, so our global guidance doesn't stop here. So how do we incorporate the study findings and WHO's global guidance for implementation, and so that we can use these findings to be able to then have a global guidance on really implementing it and sort of best practices through this study. That's all from us. Thank you so much, and happy to take questions thank you. And thanks to all of our teams and research partners. We're really, we wouldn't be able to have done this without them. Thanks.
Thank you very much. On behalf of chairs, we would like to introduce this session. Actually, we started very abruptly. Warm greetings to all of you on behalf of WHO India. Our SQ colleagues, they had to disconnect at 1:30. So we started with this presentation. Now Dr. Ramya will introduce the panelist and chair, and she will share with you about the India story, the Tamil Nadu story. So we will have a lot of sharing and a lot of learnings, and it will be really a good example of very good high-performing states, how they can implement the new ANC guidelines. Yeah. Okay, so over to Ramya.
First of all, thank you everyone. And thank you so much, Oskay and Hedaya, to take time and support us throughout the study with all the time restrictions that we've been having. I would also like to thank Dr. Pushpa ma'am, the team leader of RMNCAH, without whom had spearheaded the project of ANCIR in India. I also thank all the other dignitaries, Dr. Krishnalila ma'am, JD NHM, Dr. Nirmalsan sir, JD DPH, Dr. Yashodamani ma'am, and Dr. Kalusalingmu sir. Special thanks to Dr. Priyanka, who couldn't be here because of certain reasons, and Abu as well, who's my counterpart in Assam. Also, I would like to specially thank my predecessors, Dr. Manoj and Bharani, without whom we could not have come so far. So, shall I continue with my presentation? Slides, please. So, I would be talking about field perspectives and observations. And the next slide. So like Hedaya and Oskay had already mentioned, this is the study aim, and it was to use implementation science for systematically introducing and testing the applicability of the adapted WHO antenatal care package for positive pregnancy experience. There's also another document that all of us could go through for positive pregnancy experience as well. Next slide. So the two states were selected based on Government of India's recommendations. One was Assam and one was Tamil Nadu, in which 2 blocks were selected. In Tamil Nadu, we selected Virudhunagar and Viluppuram, of which 8 blocks were again selected for implementation. So the objectives of implementation research, I think Hedaya and Oskay have already covered. So in a nutshell, what we did was to implement an 8 ANC contact model. We initially started to understand the existing system in Tamil Nadu and Assam separately, because we do have separate systems. Tamil Nadu being a high-performing state, and we've already crossed the STG, we had to conduct rapid baseline assessments to find out where we stand. Secondly, we had to reorganize the existing ANC system. It's just that the stakeholders involved were also involved in these meetings. Leveraging on mid-level service providers, that's where the DDs and JDs were involved. Training of ANMs, MO on new revamped ANC package was done. This was done in 6 different types and in the implementation category that was explained in the step wedge ladder pattern. Regular assessments were also done to measure the progress. Next slide. So a short thing about how we contextualization of India and in Assam and Tamil Nadu was identification of states by GOI. I already told you that. And then the second thing was situational assessment conducted in both the states. That was done by a third party in 2019, post which JPHICO was introduced as an implementation partner. And then tag teams were selected in both the states, which conducted of NHM and other partners. The next slide. In Tamil Nadu, so we had focused on 4 different patterns. One was training of ANC staff package, supportive supervision was given, ensuring availability of resources. For the same, there were 8 versions that were conducted and all of the resources were regularly monitored. Community outreach was also done. This was done during the ANMs and the MOs as well. Next slide. So this was the initial Oskay score that we had conducted to know about the knowledge assessment pre and post training. Next slide. This is the achievement that we see so far. The 8 contacts were actually incorporated into the new RCH register that Maternal Health Department had presented. Next slide. And this is the how it looks on the page on the register. I think medical officers here would know it better. Next slide. Next. And this is the way forward. So like Oskay and Hedaya had told, time motion study data collection is completed. qualitative data completion is collected, but in Virupuram we are still collecting period 6. And then continuous improvement of data quality is also being done because we have implementation partners from Japaigo going in person and getting the records done. Sharing preliminary results with the stakeholders and finalizing data analysis and dissemination plan would be in 2025. That's all. Thank you. So if there's any questions, do let me know. Yes, ma'am.
So, good afternoon all. So I have 3 questions to you. So first is, that is the baseline is AN visit, 4 AN visits to be given, should be given to the AN mother. In Tamil Nadu, that is non-high risk women, antenatal women have 8 visits and more, and high risk women around 10 visits or more.
Yes,
so in that condition, how, why you have chosen Tamil Nadu and Assam? First question. Then second, why you have chosen that 2 blocks, Vilupuram and Virudhunagar? Right. The second one is, so far in this study, that is, what are the positive points you have observed from the healthcare providers as well as from the patient, and the gaps to be fulfilled from the patient as well as that is AN mother and healthcare patients. The third one is, what's the special important outcome of this study? So based on some indicators, you have told something, but what do you expect? What is your expectation? That is the outcome, important outcome.
The outcome. So initially, to answer your first question, ma'am, India as such is got out 4 ANC, government national guidelines. But Tamil Nadu State, being a medical officer myself, I started my career in the corporation. We've done more than 13 visits. But to standardize that and make sure that it's become a formation of guidelines. So in case we have these results in a positive manner, we can show these results to the GOI and they can implement it throughout the country. That was the first way. The second thing why Assam and Tamil Nadu were selected was in comparison of a high performing state and low performing state, ma'am. That was why these 2 states were selected. The third, to answer your third question, the positive outcome is the experience that the mother has, ma'am, altogether. There's a difference between a visit and a contact. So initially, when we used to see patients, even if they come for a fever or some kind of ailment, that was also considered a contact or a visit. But in this, we have a particular reason as to why they're coming for a contact and what needs to be measured during the contact, ma'am. It's just to standardize the care all over the country and the world. It's just that, ma'am. Thank you.
I would like to add, these 2 districts were selected by the government of Tamil Nadu, and there was initial delay because they selected another district first, but that was changed. Actually, the government of India chose 1 high-performing state and 1 low-performing state based on MMR. And the reason is like this new ANC model, if it is implemented in a state with very strong health system, what are the learnings? There is always some learnings, how it is different when these visits are changed into active contacts. They are added a package of intervention that were not there. So these learnings could be replicated in those states who are, better performing or high performing. So this is on the recommendation of Government of India that Tamil Nadu state was chosen.
All right, thank you, ma'am. We should proceed to the moderating session. The session chairs will be Dr. Pushpa ma'am and Dr. Krishnila ma'am. So I have just 3 questions. It's a common question, sir. So one was, I think this is more of a HQ question. So what contextual factors have you identified as critical to the successful implementation of antenatal care programs in diverse settings? So Osgi, do you mind answering that?
Of course, thank you very much, and thanks colleagues. I'll have to leave after this for another workshop related to quality of care and respectful care, actually. Very related areas, talking about positive pregnancy and birth and postnatal experience. But I think one of the things about context is we have been very focused as we are developing recommendations on the effectiveness of interventions, which is very important. But when you think about how those interventions can be implemented in the settings that we would like to make that impact, then it becomes a bit more trickier. And one thing that we started doing is, before waiting for the recommendation to come out, I think one of the things now we are more constantly doing is trying to understand the aspects of acceptability, feasibility, and implementation of any recommendation that WHO is putting out there. So how can we synthesize the evidence from the health work perspective, from the health system perspective, from the communities and women and partners and families perspective, so that when we actually issue a recommendation, we can already start talking about context and some contextual factors that will have implications on the success of an intervention or not. So for the whole antenatal care guideline, this is the approach that we did. So we actually did a huge Cochrane review, synthesizing evidence from around the world, high, low, middle income country settings, trying to understand what actually affects women to come to the services and keep coming to the services. And also from the provider's perspective, what are the factors that actually enable them to provide the good quality care? So when you look at those co-interventions and when you look at the way we have been adapting the ANC, WHO's ANC package in the context of Tamil Nadu, for example, these are all the factors that we've already started thinking before going into the field. Because health systems, community, the teamwork that is happening at the level of service provision, financing, how the financing works, the continuity of care, all of these factors can make or break the successful implementation of an intervention. And in the case of antenatal care, it is basically a platform of interventions. And I want to say integration because when you think of antenatal care, and when I talk to our colleagues as well, we always think of maternal health. And, you know, maternal health, of course, that's where the basis is. But if you look at the recommendations and if you look at the kind of care a pregnant woman needs during pregnancy, it includes malaria care, it includes HIV, it includes maternal immunization like tetanus, and possibly into the future RSV. So how do we ensure that when we are implementing a platform of interventions or strengthening a platform like antenatal care, how do we ensure that across the house, in the Ministry of Health or in WHO across different departments, how can we make sure that we are all coming around the same table? Because at the end of the day, person-centered care means that we come around the table to be able to provide the most complete and good quality services to the user, in this case, women and families who are coming to care, to get ready for their birth and for their life as a family. So I think those are the kind of factors that are really important for us to think about at the development stage, planning stage, and implementation stage. And if you look at all the countries who have been doing this research, there are differences between Tamil Nadu and Assam. There are differences between Burkina Faso, Rwanda, and Zambia, which is what it should be, because we are operating in different health systems and different populations with different needs. And those are the things that we need to think about across all of these stages if you really want successful implementation and impact. So I'll stop here. Thank you very much.
Thank you so much, Ashke. That was very well. Thanks. So, ma'am, do you have anything to say about anything to add? Anything to add, sir? Priyanka, ma'am, do you have anything to add?
Thanks, Ramya, and all the points are covered, and I thank Dr. Pushpa and the Tamil Nadu team, DPH and NHM, and our HQ team to be here. So most of the points are covered. In interest of time, I'll over to you, Ramya.
All right. Ma'am, should I proceed with the next question? All right. The next question is, so what do you think are the primary barriers to implementing antenatal care interventions, and what approaches have been effective in overcoming them?
Self DHO Virudhunagar. The main barrier was shortage of skill training healthcare providers, which was addressed by the JAPIGO team. Various level of training and capacity building were given to the VHNs and ANMs and Anganwadi workers also. Another barrier was the distance to the healthcare facilities. That is a constraint, and the travel cost and also loss of wage while seeking the healthcare behavior, and also lack of awareness among AN mother while seeking healthcare. Culturals and customs beliefs were there. Recently we have lost one mother due to this she was possessed by a spirit, and they were taken to a temple and all. So these are the barriers need to be addressed. Thank you.
Thank you, ma'am. Thank you so much. The next question, do you have anything to add, ma'am? Okay. Do you have anything to add, sir, for the same? Any barriers that you would see?
Yes, sir. So this we want to have a research gap. We want to do what are the what can we do our best regarding the antenatal care. What are the gaps? As rightly pointed out by our respected direct DPs sir in the early inaugural session, ANC care is equally important as conducting delivery. So we have to sensitize all our staff regarding the quality, efficient, effective antenatal care. Thank you.
Thank you, sir. Thank you. So for the final question, ma'am, in what ways technology can enhance the implementation and delivery of antenatal care services? Krishnila, ma'am, your thoughts?
Of course, technology plays a dominant and important role in healthcare delivery system. So in Tamil Nadu, we are having on that is a web portal that is PICME, Pregnancy Infant Cohort Monitoring and Evaluation. So in that we can capture the detail, all the data related with the antenatal as well as postnatal women since from conception till 16 years of age. And another important point is in this portal, the portal is be integrated with the other departments, that is ICDs, 108 ambulance service, 102 service, and private medical colleges and hospitals. And the portal can be used, we are having 3 directorates, that is the Director of Public Preventive Medicine, the Director of Medical Service, and Director of Medical Education. All the directorates can be easily use the portal, and they can enter the data. So like this, from this portal, we can give the healthcare service continuously, and can reduce indirectly or directly reduce the infant mortality rate as well as maternal mortality rate. And we can trace the high risk antenatal mothers as well as postnatal mothers. So that's why IT platform is very useful in healthcare provisions.
Thank you so much, ma'am. We can conclude the session, sir.
So thank you, ma'am. So from WHO side, we want to extend our, to WHO, ma'am and Pushpa ma'am and Priyanka Singh. So we like to extend our sincere thanks to you for coming all over from Delhi to here. So we like to have this innovative technological partnership from WHO side to implement that in the future. Because as Madam said, we do have the PICME portal, but to enter into the PICME portal, we need to enter manually through the computers. So we do have some sort of, we have ensured on Bluetooth linked devices which can tap other things. So from when we are taking the investigations in the field, it can automatically go into the pick me portal or in that kind of a thing. So there is a lot of Bluetooth linked available devices are there, so that we can link that to the app. So if possible, we are expecting from support from the WHO to do that in Tamil Nadu, ma'am, on a pilot basis. Thank you, ma'am. Thanks for your support. Thank you.
Thank you, everyone.
So as Tamil Nadu is trying to achieve that last mile of reducing low MMR to further low, this is very challenging. And I understand that you are really focusing very well on tracking all high-risk pregnant women. The last mile is always about equity. Who are those and which pockets are those who are not coming into the system? So I'm very glad, to have partnership with Tamil Nadu government, as a technical partner. We are always there to support. And we are, waiting for the findings of this implementation research, because that will really give us some, idea about how to improve further, how these learnings can be replicated and further improved to detect all those high-risk pregnancies, that need immediate interventions. So this implementation research is really, we are glad that Government of India brought it to Tamil Nadu, and we could work with people who are so much dedicated and motivated in a strong health system, because ultimately it's the accountability that really matters, and we can see a high-level accountability here in people who are serving in the public health system. So we look forward to further engagement, and we assure you that it's a partnership that we also very privileged of. Thank you, Ramya, and thank you everyone for coming to this session and sharing your viewpoints and enriching this session of WHO. Thank you.
Thank you for the wonderful session. I would like to request Dr. P. Sampath, Additional Director, Disease Control, to felicitate the panelists. Dr. Pushpa Chowdhury, Team Lead. Dr. Krishna Leela. Dr. Nirmal Sen. Dr. Kalusuvalingam. Dr. Yasodamani. Dr. Ramya. Now we'll break for lunch and assemble again at 2:30. Photos download பண்றதுக்கான QR கோடை ஸ்கேன் பண்ணி photos download பண்ணிக்க அன்போடு கேட்டுக்கிறோம். கனெக்ஷன் கேம்க்கான QR கோடை யூஸ் பண்ணி எவ்வளோ அதிகமாக நம்ம சரியான பதில் சொல்கிறோமோ அந்தளவுக்கு பரிசுகளை வெல்லலாம். இன்னொரு முக்கியமான அனௌன்ஸ்மெண்ட், டாக்டர் சாரதா பரமேஸ்வரன் அவங்களோட செம்பியன் மாதேவி ஹாலில் போஸ்டர் ப்ரெசன்டேஷன் பண்ணிகிட்டு இருந்தப்போ DPHICON கான்ஃபரன்ஸ் பேக்கை வேறு யாரோ தவறுதலாக எடுத்துகிட்டு போயிட்டாங்க. டாக்டர் சாரதா பரமேஸ்வரனோட பேக்கில் வயலட் கலர் வாலெட் இருக்குது. அதில் அவங்களோட டிரைவிங் லைசன்ஸ் இருக்குது. ஸோ செம்பியன் மாதேவி ஹாலுக்கு போயிருந்தவங்க தங்க கையில் இருக்கிற டிபிஹெச் ஐகான் பேக்கை கொஞ்சம் செக் பண்ணி அதில் அவங்களோட ஐடி இருந்ததுன்னா தயவு செய்து மாற்றி உங்களோட பேக்கை வாங்கிக்குமாறு தாழ்மையோடு கேட்டுக்கிறோம். அனைவருக்கும் வணக்கம். மதிய அமர்வுகள் இன்னும் 4 நிமிடங்களில் ஆரம்பிக்க இருப்பதால் அனைவரும் அரங்கினில் கூடுமாறு அன்புடன் கேட்டுக்கொள்கிறோம். ஃபோட்டோஸ் டவுன்லோட் பண்ணுறதுக்கான கியூஆர் கோடை ஸ்கேன் பண்ணுறதுக்கும் கனெக்ஷன் கேம் விளையாடுறதுக்கான கியூஆர் கோடை ஸ்கேன் பண்ணுறதுக்கும் அனைவரையும் அன்போடு கேட்டுக்கிறோம். டாக்டர் சாரதா பரமேஸ்வரன் அப்படிங்கிற கோயம்புத்தூர் டாக்டருடைய டிபிஹெச் ஐகான் கான்ஃபரன்ஸ் பேக்கு செம்பியன் மாதேவி ஹாலில் தவறுதலாக வேறு யாரோ கையில் போயிடுச்சு. அந்த பேக்கில் அவங்களோட வாலெட் இருக்குது. பார்த்தவங்க அந்த பேக்கை கொடுத்துட்டு உங்களோட பேக்கை திரும்பி வாங்கிக்கலாம். நன்றி. The afternoon session is going to commence in few minutes. All the participants are asked to assemble in the hall immediately. DPHICON 2024 மூன்றாவது வருடாந்திர சர்வதேச பொது சுகாதார மாநாட்டின் முதல் நாள் மதிய அமர்வுகள் இன்னும் சில நிமிடங்களில் ஆரம்பிக்க இருப்பதால் அனைவரும் அரங்கிலில் கூடுமாறு அன்புடன் கேட்டுக்கொள்கிறோம். The afternoon session of DPHICON 2024 is commencing in few minutes. All the participants are asked to assemble in the hall immediately.
Superstar da, Hunter, Hunter, Chudada.
afternoon, everyone. Our session is about to start, so kindly maintain silence and please be seated. I welcome Dr. Sendil, Joint Director Communicable Disease, to moderate the session. I'm excited to welcome Dr. Manoj Murekar, Director ICMR NIE, to present the topic on advancing public health through wastewater surveillance, essential tools for understanding disease spread. Dr. Murekar leads the Field Epidemiology Training Program at the National Institute of Epidemiology. He has also served as a consultant for WHO, Western Pacific Regional Office, and as a professional staff member in Papua New Guinea and the Philippines. Please join me in welcoming him. Please maintain silence.
தயவு செய்து அமைதி காக்கவும். அமர்வு ஆரம்பிக்க இருப்பதால் தயவு செய்து அனைவரும் அமைதி காக்குமாறு தாழ்மையுடன் கேட்டுக்கொள்கிறோம்.
Hello. So good afternoon all. Welcome to the afternoon session of our day 1 DPHICON 2024. So we are going to listen an interesting speaker. As we all know, in the public health department, we are doing a lot of sample analysis, especially biological samples, and drinking water analysis, and any outbreak samples, including any xenomonitoring, that is presence of dengue virus in mosquito and other things. The current focus is on wastewater surveillance, that we can able to predict before the occurrence of any outbreak. This wastewater surveillance is a current trend, and we are also on it. Through State Public Health Lab, we are planning to introduce that wastewater surveillance. In this regard, so we have a lot way to go. So we are keen to listen from our guest lecture speaker, Dr. Manoj Murekar, from National Institute of Epidemiology, Chennai. So over to you, sir. Thank you. I request the audience to please keep calm and settle down, please. So we are going to start the session. அனைவரும் அமைதி காத்து அன்புடன் அமருமாறு கேட்டுக்கொள்கிறோம். Silence, please. Thank you.
Good afternoon. At the outset, I want to thank DPH sir and the organizers for this invitation. Before I start, I also want to confess something, that I have never done wastewater surveillance, never involved in wastewater surveillance, but have read number of publications which talks about the strength of wastewater surveillance. And therefore, what I am going to do in the next about 30 minutes is going to give an overview of wastewater surveillance and present to you what it can offer, what this wastewater surveillance can offer as a complementary tool to the existing surveillance that is ongoing in the state as well as in the country. So I am going to talk or give a brief background about wastewater surveillance, its principles, why it's rational, and I am going to present to you some use cases of wastewater surveillance, and finally some of the challenges, And if time permits, I'll talk about some of the methods. But I really don't see we will have enough time for that. So now, globally, if you see, we have brought communicable diseases under control to a large extent with the use of antibiotics, antimicrobials, vaccines, various public health measures. But emerging and re-emerging diseases continues to be an important challenge, causing substantial morbidity and mortality. And there have been several reasons for these emergence or re-emergence of infectious diseases. And that includes increased human-animal interface, increased travel, urbanization, land use, climate change, etc. If you see the important emerging and re-emerging diseases in the last 20 years, these are some of the important diseases, which includes SARS, dengue, and recently we had COVID-19. And these diseases have caused substantial morbidity as well as mortality, and as well as a significant economic burden. And to control for these emerging and re-emerging diseases, we need a system to detect them early. We need a good surveillance system. Now, traditionally, if you see, there are two kinds of surveillance systems that are operating in India in most countries. One is the indicator-based surveillance system, where we do surveillance for selected diseases of interest. And there is the event-based surveillance system, where we surveil for certain events of interest. The important challenge of these surveillance systems is that the first challenge I would say is sensitivity. These systems are not able to capture all the events, all the cases that are occurring in the community. They are often not representative of the entire population, and therefore we often detect the outbreak very late. And by the time we detect, already the outbreak is at its peak. Second important point is about health-seeking behavior. And we know that a lot of people may not seek public health care from public health system, may seek from either private or another traditional system, which may not be under surveillance umbrella, and therefore cannot be such diseases cannot be detected by your surveillance system. Another important challenge is that there are several diseases or several patients who are mildly symptomatic or asymptomatic, but may be shedding the virus or shedding the organism. And such cases are less likely or not likely to be detected by the routine surveillance system. And therefore, sewage surveillance system or wastewater surveillance system could serve as a complementary system for the existing surveillance system. So, sewage surveillance system or wastewater surveillance system is a type of environmental surveillance. And if you want to tell you the principle of this system in a simple word, is that anything that is shed in the sewage, either through feces or through urine or through respiratory system, can be detected in sewage. So this is the principle of sewage surveillance. And this anything could be pathogens, could be bacteria, could be viruses, could be chemical markers or drugs, or could be certain genes which reflect resistance to antimicrobials. So AMR genes could also be detected through sewage surveillance system. So there are certain important characteristics of wastewater surveillance system. It systematically analyzes the residues, that is pathogens, chemicals, or certain genes in the wastewater. And irrespective of whether a person is symptomatic or asymptomatic, we could detect infection in the wastewater. And this is a very objective system. It is a passive surveillance system. But very important thing is it is representative of entire population. Because the sewage from entire community is going to come to one place. irrespective of the fact that whether this person seeks public health care or private health care. So in that context, it is a representative system. Now, let me go in the history and give some backgrounds or some origins of wastewater surveillance system. This has been used since several decades globally. It was primarily used for tracking fecal-orally transmitted diseases. And it has been extensively used for polio surveillance to complement the AFP surveillance. And in India also since 2012, we have been using sewage wastewater surveillance system in the country. Subsequent to polio virus, it was also extended to certain other pathogens, especially gastrointestinal pathogens, that is Salmonella, S. typhi, cholera, and certain viruses. But in the last 3 years, if you see, in the 3 years of pandemic, it was extensively used to track the presence of a SARS-CoV-2 virus in the sewage, including in several projects were conducted in India where they tracked the COVID virus in sewage. So these are some of the pathogens which can be detected in sewage with certain specificity and certain sensitivity. And these pathogens include certain bacteria like Campylobacter species, E. coli, Salmonella typhi, Shigella, and Vibrio cholerae. Some of the viruses includes adenovirus, enterovirus, including poliovirus, hepatitis A and E viruses, rotavirus, as well as norovirus. So certain parasites also have been used, have been detected in sewage. And several respiratory pathogens can also be detected in sewage. And we all know during COVID, several countries had sewage surveillance system. Influenza could also be detected, RSV and other viruses could also be detected. Apart from viruses or bacteria, one could also detect chemicals or drugs in sewage. And this has been, this is one example where certain chemicals were detected in close communities, such as prisons or juvenile homes, especially certain drugs which are abused or misused. And you can see in this graph, like certain drugs like cocaine, ecstasy, amphetamine, and cannabis were detected in a prison population by doing sewage surveillance. So this is again a very important tool, a passive tool which can detect what is happening in the community. The drug consumption, what is happening in the community. As I mentioned earlier, there are several advantages of sewage surveillance over the routine or the indicator-based surveillance system. It does not depend on whether patient has access to health care. So it is independent of access to health care, a patient's access to health care or testing capacity. And it is therefore not biased because whether person seeks health care or not. It is real time in nature, provided you are collecting samples with regular frequency. And it again can cover a large population if you have a good sewerage system in the area, in the city. It can monitor several infections, several diseases, and in the long run, it can be a cost-effective proposition. So let me tell you one important distinct advantage of sewage surveillance system is that it can detect pre-symptomatic or asymptomatic transmission happening in the community. And this is example from COVID, SARS-CoV-2. And our routine surveillance system basically included surveillance in hospital which tracked mortality, which tracked about ICU occupancy or hospitalization. And our lab-based surveillance tracked about testing symptomatic patients. But in the bottom of the pyramid, if you could see, there are people who are infected, who were infected, and sewage surveillance system could detect occurrence of transmission or presence of transmission in the community at a pre-symptomatic or asymptomatic, when patient is pre-symptomatic or asymptomatic. So now, having given a brief background about sewage surveillance system, let me present to you certain use cases, and that will tell you as the power of sewage surveillance. And first, I'll talk about the use of sewage surveillance system in poliomyelitis. Now, we have two types of country now currently when we talk about polio. There are countries which are polio-free, which have sort of eliminated polio several years back, and India is one among them. And there are some countries where polio transmission is still happening, Pakistan, for example, or some of the neighboring countries, or some of the African countries. So in such countries, the role of sewage surveillance system is that it supplements AFP surveillance system in detecting the virus, and also provide increased evidence as well as confidence that circulation has been interrupted in the event it is interrupted. So let me give one example. From Pakistan. So this was in Pakistan started sewage surveillance system in 2009. And at that time, about 17 districts which were bordering Afghanistan, polio circulation was rampant that time. A lot of AFP cases, a lot of polio cases have been happening. And so they started a sewage surveillance system as a complementary, a sort of supplementary tool for AFP surveillance system. So as a part of that, they collected samples from different provinces and different cities every week. And this graph basically shows the virus positivity in sewage sample every week. And yellow indicates that sewage was negative for wild polio virus, whereas red indicates it was positive for polio virus. And as you can see in this graph, at least in 2011 and 12, there was wide circulation of polio virus, as was detected in stool samples. And as I mentioned, there are another type of countries which are free for polio. And in such countries, the sewage surveillance system can detect reintroduction of WPV or local circulation of circulating VDPVs. Eventually, they can monitor progress towards interrupting the respective outbreaks. So let me give one example again. This is from England. England had the last case of polio was detected in 1984. Since then, there has not been any case of polio, wild polio virus in England. And since 2014, they started sewage surveillance for polio virus. So they have been collecting samples on a weekly basis, sewage samples, testing for polio virus. And England has been using inactivated polio virus, the Salk virus basically, Salk vaccine. They have been using the inactivated vaccine, IPV. So during sewage surveillance on 8th February 2022, they detected two poliovirus type 2 vaccine isolates from London Beckton region. So two Sabin virus or SL, the Sabin-like viruses were isolated. And since the country was not really using oral polio vaccine, so this was not expected in the country. So what they did was they strengthened the surveillance, and since April 2022, they have been seeing more number of cases, as can be seen in the graph there. There was increasing number of proportion of cell culture flask with positive type 2 poliovirus isolation. So following that, they instituted a rapid response measure, conducted several rapid response measure activities. As I mentioned, they enhanced surveillance. They initiated IPV vaccination. And what they also did was, during this February to July, they isolated about 118 polio viruses from sewage. And this is basically the distribution of areas or communities where polio virus positivity was higher, that is indicated in the red. And in the yellow, again, it was a lower positivity, but polio virus was positive in the sewage samples. So what they did was they again did a whole genome sequencing on all isolates. And they found unique recombination in these isolates. So 98 of the isolates were found to be Sabin-like virus isolates, which are the vaccine, OPV type of vaccine, virus isolates. Whereas 20 isolates were the circulating VDPVs, circulating vaccine-derived polioviruses were isolated. So this is, and because of IPV vaccination, the transmission ultimately eventually came down. So this is one important use of poliovirus, the sewage surveillance, where one can detect circulation of poliovirus. I will give you one more example. This is the case in USA, in New York. Again, New York had last case of polio in 1979. In 2012 July, there was a suspected AFP case, a case of acute flaccid paralysis, which was from Rockland County. And as a surveillance protocol, they collected stool sample from this patient and isolated circulating VDPV from this stool. And then, because this was an isolation of circulating VDPV, a public health response was mounted, which included enhanced AFP surveillance, which included IPV vaccination. And since USA that time was conducting sewage surveillance for COVID, they also tested this sewage surveillance sample for polio viruses. So this is the timeline, what happened. At day 0, you can see here, this probably is not working. At day 0, this patient developed symptoms of paralysis. And we know the incubation period of polio is about 7 to 21 days. And they interviewed this case patient and found that this patient attended a large gathering. On day 5, this patient was admitted in hospital, and day 11, the VDP was isolated from the stool. And then, as I mentioned, this sewage surveillance system for COVID was ongoing, and they tested these sewage samples for polioviruses. And at different time point, they detected poliovirus from Wastewater in Rockland County. And the further genetic analysis indicated that the virus that was isolated from the sewage and from the patient were closely genetically linked, meaning that this patient essentially was infected locally, because this patient never had traveled outside USA. Not only that, they also found the poliovirus in another county, this same virus was circulating in another county. Although the origin of this VDPV, vaccine-derived poliovirus, could not be ascertained, but they ultimately found that this was closely linked to the outbreak in UK and Israel, the UK outbreak which I just described. So this again is one important use of sewage water surveillance in tracking the infection. Now let me talk about SARS-CoV-2, and we all know sewage surveillance was extensively used for tracking the progress of the COVID outbreak, as well as finding out early detecting the outbreak. So let me give this example from South Africa, wherein they documented or they tracked increasing as well as decreasing trend of SARS-CoV-2. So they had sewage surveillance since initial stages of COVID pandemic. And by the week of 34, the Delta wave had come down, as you can see in the epidemic curve seen there. And environmental surveillance also showed virus at either it was not detectable or below the detectable level. But from week 43 to 45, again you can see that orange bar. They saw increase in virus detection, SARS-CoV-2 virus detection in environmental samples. And about 2 weeks after, there was another COVID wave in the country. And subsequent genetic analysis revealed that this was because of Omicron. We know Omicron, in fact, emerged in South Africa and it spread across the globe. So this is one example where they could detect a variant, or they could detect a virus in the stool, in the sewage samples, at least 2 weeks before the COVID wave of Omicron. And this is not one example, as I mentioned. Several countries used it primarily to as early warning signal for impending outbreak. And very interestingly, there is a meta-analysis which documented or which estimated the lead time between detection of virus in the stool and occurrence of outbreak. And the lead time, as you can see, ranged from 2 to 12 days in USA to about 14 days in India. And there were several reasons for this variation in lead time, including health-seeking behavior, including the clinical testing sensitivity and so on. But what important point is that sewage surveillance can give you about 2 weeks time in advance to that an impending outbreak is occurring. Okay, this is another example where one could also identify variants through sewage water surveillance. And as you can, this was environmental surveillance in Utah, where on 19th November they detected Omicron variant in sewage samples, and 10 days later they detected cases because of Omicron in the hospitals. Again, a lead time of about 10 days. This is the example from Pune, where they have been tracking variants over last 2 years of pandemic, and you can see the changes, the tracking of viral variants during the pandemic. So this was about COVID, we all know that. And now let me talk about influenza. And this is the example from Canada. In 2022, the first half of 2022, when SARS-CoV-2 outbreak was occurring in Canada, there also was an outbreak of influenza. As can be seen that this is the curve which shows the COVID outbreak, and there was an outbreak of influenza ongoing in the country. So they again used the sewage surveillance system that was ongoing for SARS-CoV-2 and tested the sewage sample for influenza and detected influenza virus at least 2 weeks before the peak of influenza outbreak. Here again is the lead time, and as you can see, lead time for first detection of influenza virus in the stool and in the clinical case was about 17 days. So that is a big advantage for a public health system to respond. Monkeypox is another example, and we know now WHO has issued a has declared monkeypox as a public health emergency of international concern. And last year, when it was again declared as a PHEIC, and we know that most of the transmission occur because of sexual route. There's a lot of stigma associated with Mpox testing. And since this virus is shed in urine, in stool, it can be detected in sewage samples. So this is one example in Poland, and they started sewage in 2022, environmental surveillance, in 2 places, and they detected monkeypox genetic material on week 29 and 43 in first system, and during week 37 to 43 in the second sewage system in the country. Last year, there were 22 cases of monkeypox reported from the country, and most of the cases were during 28 to 32 weeks. And that time, there was no positivity in sewage sample. And the main reason for that was the sewage that is discharged from the hospital is chlorinated. It doesn't have basically any virus. So the presence of sewage, presence of monkeypox genetic material in sewage indicates that the transmission is ongoing in the country. People are not getting tested because of the stigma associated with that, and that's why you are getting sewage the monkeypox virus positivity in sewage samples. This is the last use, that is antimicrobial resistance. Sewage sample can also be used to detect the level of antimicrobial resistance in the community by identifying genes, AMR genes. And this is one example from China, where they did large-scale sampling throughout China from 17 major cities, and they detected diverse and abundant resistant genes conferring resistance to almost all antibiotic bacteria, and they mapped this data geographically, and they found that there are certain certain areas where the ARG burden is higher, and there are the upper part or the western part basically has a lower burden of ARG, the antimicrobial resistant genes. And this again they correlated with the population density that is available in these areas. I'll just conclude in the next 2 minutes because we know the power of wastewater surveillance, but it doesn't come free. It comes with a lot of cost. And this is true because most of the environmental surveillance that happened during COVID, the funding for that ended, and there was a question how to sustain these surveillance activities. And therefore, a costing exercise was done in 12 countries where environmental surveillance was conducted in 12 LMICs. And they estimated the cost. It was highly variable across countries. The lowest was in India. The cost per sample was $34. And it was, in Costa Rica, it was about $500. But again, as you scale up, the cost decreased. And if you add additional biomarkers other than SARS-CoV-2, there may be only marginal increase in the cost and a lot of benefits by adding additional pathogens is what the conclusion of this study. Sewage surveillance also has several challenges. It's not that it is a magic bullet. There are communities which either do not have any sewage system, and such example could be rural areas, or prisons, as we saw an example in Poland, or in hospitals where sewage is already treated. They may have a separate sewage system, and we may not be able to detect pathogens from these communities. Then again, the low level of viremia cannot be really detected in sewage samples. We may not be able to estimate the size of infected people in the community with the sewage surveillance system. So in summary, sewage surveillance system can complement the ongoing indicator-based as well as event-based surveillance system. But the decision to implement or introduce a sewage surveillance system is based on 3 important components, I would say. One is we need funding for instituting a sewage surveillance system. We need a good lab expertise to do all the assays. And sewage surveillance system cannot be done by one single agency. It is a multi-sectoral engagement is required. And that is the third requirement which I feel is necessary if Tamil Nadu or if any state wants to introduce sewage surveillance system into a sewage surveillance program into their surveillance system. Thank you very much, and I'll be happy to have any questions.
Thank you, sir, for enlightening us regarding the advancing public health system through our wastewater surveillance. The forum is open for audience for any questions. Yes, sir. Can you pass on the mic to JD Elimination, sir?
It's not a question, just information, sir. We are doing for polio, but we can extend for other diseases as you rightly mentioned. So we are doing with King Institute the sewage monitoring systems.
Yes, sir. Again, it's to complement sir's note. We already submitted a proposal to World Bank through Tamil Nadu Health System project regarding the wastewater surveillance, sir. So this is not a dream, it is a reality in near future. So we are planning on AMR also, with the drinking water surveillance, other things also going to be linked in that, sir.
Thank you, Vinay. Actually, in some cities, Pune is one example where they used the AFP, the samples that were collected as a part of polio surveillance or sewage surveillance for polio that was happening. And they had a surveillance, and the graph which I showed basically, the graph of variants from Pune was from the sewage surveillance system for polio that was used. So certainly, because we have I think about 20 sites where we are doing sewage surveillance for polio, and we can definitely add testing for additional viruses of interest to the country.
So apart from that, there is an NGO called Catalyst and Swasti is already, they have done a wastewater surveillance in Trichy Corporation. Hopefully CHO Trichy Corporation might know it. So they are also going to provide technical support through NCDs, Ministry of Health and Family Welfare, sir. And this is the lead time which I am very much concerned. So it is definitely, it will save a life. In case of, if you predict an outbreak well in advance, that 2 weeks before, we definitely will move our resources and will reduce the morbidity and mortality of the community, sir. So hopefully we'll aim for the best. So thank you, sir. Thanks for your excellent, wonderful presentation and also coming here. Thank you, sir. Okay.
Thank you for your thought-provoking session, sir. Now I request Dr. Vinay Kumar, Joint Director, Immunization, to felicitate our speaker, Dr. Manoj Murekar. I also request sir to present the moderator memento to Dr. Sendal, Joint Director, Communicable Disease. Thank you for moderating this session, sir. Thank you, sir.
We humbly request Mrs. Sumati, JD, SBHI, to moderate the following session. Welcome on stage, ma'am. DPHICON2024 renders gracious welcome to Dr. Manju, District Health Coordinator, Civil Registration and Vital Statistics, WHO India, to elucidate on District CRS approach, navigating obstacles and celebrating milestones. Dr. Manju graduated from Chettinad Medical College with MD in Community Medicine. Formerly, she worked as Assistant Professor at Savita Medical College. She has 4 years of academic and research expertise. Dr. Manju transitioned to public health leadership as District Health Coordinator for Civil Registrations and Vital Statistics, appointed by WHO's Health System Team, Country Office, India. She drives the District CRS approach, a pilot project to strengthen the mortality statistics in the districts of Krishnagiri and Karur, Tamil Nadu. Welcome, ma'am.
Thank you for the warm welcome, ma'am. So good afternoon, one and all present here. First of all, I thank the Directorate of Public Health and Preventive Medicine for providing me this platform to provide an insight of what is happening with the district CRS approach, which is a pilot project. So this project was launched in the state of Tamil Nadu, in the district of Karur and Krishnagiri in October 2023. To be more specific about the project, this is first of its kind globally. There are so many other countries who actually ascertain, okay, so this district CRS approach is to improve the mortality statistics of our state. So even though many other countries have followed so many measures to improve the vital statistics system, district CRS approach is first of the kind where we have implemented it throughout the district, covering 100% of the deaths that is happening for a single year. So first we'll start with comparing the death registration level as well as the availability of MCCD, which is the medically certified cause of death of Tamil Nadu with the national average. So the green ones are the national average throughout, and when we consider Tamil Nadu has achieved 100% of death registration since 2014. So of these 100% death that has been registered with the Tamil Nadu government, we only have cause of death certificate for 43% of the deaths. So we have a huge lacunae here where around 60% of the death that has been registered are without the cause of death. So this project was aimed to improve or to stabilize this gap that is present in the community. So when we look into the occurrence of death, with the the place of death where the death happens, only 24% of the death actually happens in the institution. Rest of the deaths happen in non-institutional place. It can be either at home or other places other than home. So of these 73% non-institutional deaths, only 30% of the deaths that happen other than institution has the cause of death certificate. So to be more specific, the medically certified cause of death certificate is provided by the doctors who attend the patient during the death in the hospital. So who provides it in the home is that a doctor who sees a patient during the period of final illness can issue them with a cause of death certificate. So comparing that, for the 24% death that occurs in the institution, we have 100% of cause of death availability. Tamil Nadu government has made it a mandatory to submit a cause of death certificate form since 2021. But the deaths that are happening at home, we still have a huge lacunae in those deaths. So looking into the the death registration place, around 47% of the deaths are registered in the village panchayat with the VAOs. So of these deaths that are registered with the village panchayat, we have cause of death only for 5% of cases. Okay, so RGA has stated that 100% of all the deceased has received some kind of medical attention during their terminal illness. So this means that we are eligible to have cause of death certificate for all the deaths that are happening in our state. So to enhance this availability of cause of death, to improve the mortality statistics, this pilot project called District CRS approach was launched in Krishnagiri and Karur district. So taking into consideration, for institutional death, 99.9% we have cause of death availability, and for non-institutional death, only 20 to 30% cause of death availability is available. So the project was started in Karur and Krishnagiri district. So what were the selection criteria that we used to select these specific districts were? We looked into the MCCD availability of both the districts. So both the districts had MCCD availability below the state average value. And in addition to that, we also made sure that the rural population are more than the state average values. And along with that, there should be availability of all types of registration unit in the district and more than 1 million population. And other availabilities of tertiary care centers and training institutes, and the major focus were availability of adequate manpower to run the project. So the aim of this pilot project is to enhance the reliability of cause-specific mortality information in Tamil Nadu. And the objective is to test the utility of the WHO 2022 verbal autopsy tool, which was translated into Tamil, and to integrate the verbal autopsy with the routine CRS with existing human resources, and to strengthen the cause-specific mortality information at district level by pilot testing it in 2 districts. So the key stakeholders of the district CRS project were the DPH, WHO, Institute of Community Medicine MMC, ICMR NIE, the district health office of both Krishnagiri and Karur district, medical colleges of both the districts, regional training institutes present in the districts, as well as the Greater Chennai Corporation.
So the focused area was in Tamil Nadu. What do we do in this district CRS approach is that we conduct verbal autopsy for all the cases that are that don't have cause of death certificate. So MCCD is nothing but the form 4 which is issued in the hospital, or the form 4A that is issued for the home death. So for those deaths which doesn't have an MCCD, we do this verbal autopsy using the WHO 2022 verbal autopsy questionnaire, which was translated into Tamil. And in order to have a qualitative data being obtained from the field, we had to train the medical officers as well as the verbal autopsy interviewers along with stakeholders engagement. So we also had to use the information technology for data collection process. So this WHO 2022 tool that was translated into Tamil, it was incorporated into ODK app. So this app was installed in a tablet and was provided to the interviewers for the purpose of collection of verbal autopsy data. So by doing all these things, we expect to have a reliable cause-specific mortality information at the district level in Tamil Nadu. So before implementing this in the district of Karur in Krishnagiri, we had a pre-pilot that happened. So the pre-pilot was done in the district of Krishnagiri with 100 verbal autopsy cases. So in order to do the pilot project, we had to follow certain steps, like we had to do the situation analysis and develop the partnership with the stakeholders, conduct technical working group meetings in order to formulate a plan for implementing the project, translating the questionnaire into Tamil, incorporating it into ODK, and selection of the pre-pilot cases. So the pre-pilot was done in 3 rural and 1 urban area in the district of Krishnagiri. So following this, capacity building of both the health inspectors as well as the medical officers of the district for the pre-pilot project was done, and an action plan of how to complete the cases along with supervision. I mean, like when the interviewers go and complete the case, they are supposed to be supervised by a medical officer or other district level supervisors. So supervisory plan was also formulated, and communication was given from the DPH to implement the pre-pilot project. So as I already told, first step was conceptualization along with the stakeholder consultation and development of tool. Followed by that, we did the pre-pilot testing. So once the pre-pilot testing was over and we had an idea of how to go about with it, we had to train the trainers who can keep the project sustained in the district. So training of trainers of 80 medical officers from both the districts were done. So with the help of these training of trainers, we trained the medical officers, health inspectors, SHN, VHN, HI, BHS in the district regarding the verbal autopsy. The health inspectors were given a 3-day intensive training regarding the utilization of tool and data collection, whereas the medical officers, BHS and other supervisors were given a half-day sensitization program. So in addition to the people from the public health department, we also involved the BAOs. BAOs being the primary birth and death registrar at the PHC level. The interdepartmental coordination here was very useful. So finally, in October 2023, the pilot was implemented in the district of Krishnagiri and Karur. So how does the data flow? We already saw that Tamil Nadu has 100% of death registration. So these details of death that has been registered is entered into the CRS portal. The line list of the deaths that are present in the CRS portal for the specific year was taken, and the cases without MCCD was extracted from the list. So after the cases were extracted, the cases were mapped with the specific healthcare facilities, with the specific PHCs. So once the case has been mapped with a specific PHC, the interviewer of the corresponding PHC will go and perform the verbal autopsy interview. So this verbal autopsy interview, as we already told, the questionnaire was incorporated into ODK and the data was collected. This data has been stored with the DPH server. So from this server, the data will be transmitted to the medical officers in order to ascertain the cause of death from the data that is being collected by the health inspectors. So these probable causes of death ascertained by the medical officers, this probable cause of death ascertained from the medical officers will be filled in a form called Form 4VA. So on a longer run, we are planning to integrate this Form 4VA along with the MCCD that is available in the CRS portal. So other than these steps happening, we also happen to do in manual analysis of the pre-pilot project, and we had a outline of things to be expected. In addition to that, we also happen to do manual analysis of certain indicators to assess the progress of the project as well as the qualitative indicators. So what happens at the field level is that once a patient goes and registers the death with the birth and death register, and there is no provision of MCCD for that specific case, the birth and death register sensitizes the respondent or the family member regarding the district CRS approach, as well as he sensitizes them to preserve the medical records of the person of the deceased person. So in our verbal autopsy questionnaire, there are three important components. One is the questionnaire, which contains of all your medical history, treatment history, and other histories pertaining to the death. In addition to that, we also document the medical records, as well as we do a open narrative. Open narrative is something the patient tells, which is documented in the patient's own words. So these three components are essential for the doctor to ascertain the cause of death. So the verbal autopsy, the birth and death registers initiates the respondent to preserve the medical records. So once the cause of death line list is received at the level of the PHC, the interviewer, the VHN supports the health inspectors, who are the interviewers, to fix appointments as well as pick up the appropriate respondent to provide the answer with. So once this is done, the VA interviewer reconfirms the appointment, goes visit the family, conducts a verbal autopsy, enters it in the ODK app, reviews the questionnaire before he submits it, which is stored in the DPH data. So in order to maintain the quality of the data that has been collected, we have also formulated a supervisory plan. Supervision is done at three levels: the block level, district level, as well as the state level. So at the block level, the BHs, BMOs, and medical officers go in for supervision. District level, DHOs and second level medical officers go in for supervision. And there were also members of the technical working group committee who goes in for periodic supervision to both the districts from the state. So once the data has been stored, it was extracted in form of MS Excel, and it was provided to the medical officer during the pre-pilot phase. So from this MS Excel, the medical officer ascertained the cause of death and probable cause of death and filled it in the Form 4VA, which was done a quality check at the state level and was analyzed for the reports. So due to the voluminous nature of the questionnaire and the variety of data that was present, medical officers felt it very difficult to ascertain cause of death using the Excel sheet. So in order to make it an easier component, we developed a web portal where the data that is being collected by the health inspectors will be incorporated and presented in a categorical form for the medical officers to ascertain the cause of death. So by the end of the presentation, I'll also show a demo regarding the web portal. So as I already told you, block level supervisor, district level supervisor, and state level supervisors monitored the verbal autopsy interview. And in addition to that, to improvise the quality of the data collected, we also formulated an open narrative assessment tool. So with the literature search, there were no tool to assess the open narrative that has been documented in the verbal autopsy. So this was a newer initiative that was taken along with the district CRS approach to formulate the tool to assess the open narrative. And these data were reviewed periodically with the technical working group committee at the PHC level, block level, district level, as well as the state level. So these are all the indicators that we took into account to maintain the progress as well as the quality of the verbal autopsy. So to monitor the progress, we just looked into how many verbal autopsies being completed per month. Along with that, how many verbal autopsies were conducted with supervision and with the PCVA, physician certified verbal autopsy. That is your cause of death. To determine that, how many PCVA were completed per month were taken into consideration. And coming to the quality, as I already told, open narrative and medical records are two important components in our verbal autopsy questionnaire. So to monitor the open narrative, we had open narrative assessment tools, and we also had an account of how many cases were provided with the medical record. And there are several other components in our questionnaire that were set as quality indicators. So in addition to that, we also looked into the time interval taken to complete each and every questionnaire. So other than this, with the cause of death, we are looking into the percentage of cases with specific cause of death and percentage of cases with timeline. So the challenges, we had operational challenges, technical challenges, as well as implementation challenges. So operational challenges, participant recruitment and training and retaining the interviewers and medical officers in the district. Since it's a pilot project that is involving only 2 districts, this was one of the greatest challenge that we faced. And sometimes the respondent, the family there is difficulty in accessing the family due to migration or other work-related, occupational-related reasons. The accessibility was also a challenge that we faced. And managing sensitive and complex cases. Cases like a 1-year-old kid, infant death, unnatural deaths were all very sensitive and complex cases where the interviewers had to put a lot of time and effort to convince the respondent to provide them with data. So the technical challenges, we had to translate the WHO 2022 questionnaire into Tamil, and open narrative assessment, quality check need to be done. And initially, before the formulation of the web portal, we were manually analyzing the data. That was also a technical challenge. So implementation challenge, integrating this verbal autopsy into the existing CRS system and other cultural and linguistic challenges that we had in the field. So achievement regarding the data collection and quality, we are provided with a standardized questionnaire, a standardized tool to collect the verbal autopsy interview. So we have formulated one such tool, and there is a lot of improvement in the documentation process with constant monitoring and supervision, and with constant meetings and sensitization sessions. There has been a drastic improvement with the data that has been submitted. As well as we have sensitized the medical officers, not only with the government setup, but as well as the private medical officers and the VAOs regarding the importance of MCCD. So regarding MCCD, our Form 4 and 4A that has been provided by the doctors are the gold standard method for cause of death ascertainment, whereas this verbal autopsy was brought into place only to support or to address the gap that was present. So the idea is not to go about with verbal autopsy for a very long time, rather improvise the MCCD availability in the state, especially by improvising the Form 4A availability in the state. So we had a sensitization program regarding the same. So with data management, we have successfully completed around 10,000 verbal autopsy, including both the districts. There has been a very enormous support from the, right from the district level officials till the field level workers from both the districts, which we find it to be a really great achievement, because acceptance is the first step that proves positive to move forward. And we also have a standardized tool to capture our data, as well as the PCVA web portal to ascertain the cause of death. And we have seen that ICD, we are slowly transforming from ICD-10, that is the International Classification of Disease, ICD-10 to ICD-11. So we have successfully incorporated ICD-11 in the verbal autopsy. So our district CRS approach is the first platform to incorporate the ICD-11 into practice. So we have also trained 169 health inspectors and 91 medical officers regarding verbal autopsy and 123 medical officers regarding PCVA. And all these things, the major achievement is all these collection of 10,000 data and training and other steps were done with the existing manpower. There were no additional recruitment. So this is one of the positive finding or a positive notion to ensure the sustainability of the project on a longer run. So coming to the performance monitoring, constant supervision, quantitative, qualitative indicators and ONQAT were developed to assess it. So at many places, we only concentrate on treatment or how to treat once a disease emerges. So the preventive aspect of health is something that needs to be improvised at all levels. So why do we have to address the gap? What is the necessity to know the medical certificate? What is the necessity to know the cause of death for all the deaths that is happening? So with whatever knowledge we have and with whatever statistics is available, many of us would have read that cardiovascular diseases are the major cause of death all over the world internationally. So these statistics are only derived by this 24% of the institutional death that is being available. So the rest of the 75% could have some other reasons that are being missed out. So to cover this gap, it is very essential, and depending on this mortality statistics, we could go about with different planning and organization, policy making and decisions. So at a short term, the benefits with obtaining this mortality statistics is that you have a statistic report at the district level, and this could be scaled up at the Tamil Nadu level. On a long term, this verbal autopsy cause of death will be integrated with the CRS cause of death, which will give us an improved mortality and accurate mortality statistics, which will be reliable. So the outcome that will be obtained from this project is that we'll have a strengthened health system with informed health resources allocation, targeted intervention for priority health issues, and informed decision in policy making. And we also have, we can also improve the effectiveness of the program that is existing, as well as enhance research and surveillance capacity. So this is the login page of the web portal that was developed. I'll just, there's a short video of run through the portal. So once you log in, so this is how things appear. This is the detail of one single patient that has been displayed. And so this is the, okay. So it runs up very fast. Pause pannunga. Konjam back poi pause pannunga. Oh. Okay, so we have different slots of the questionnaire that has been available in the video recording. And this is how the information will be provided to the doctors in order to assess the cause of death. A final summary of what are all the positive or the important findings in the case will be displayed. So once the medical officer, once a medical officer is sure about okay, so once a medical officer gets to know the cause of death, there is a form 4VA that is available where the medical officer can document it. So if so this is a generate summary part. So you have this ICD-11 that has been integrated. The best part with ICD-11 is that for ICD-10 coding, we had to sit and search for each and every diseases, whereas ICD-11 had made it very easy for us, where you type in the disease, it gives the list of diseases that is available with your word that we are typing into. It is just like the Google search that has been present. So to explore more into it, you can just Google ICD-11 coding tool in your Google, which will give you a proper and detailed explanation of what the coding tool is. So with this ICD-11 coding, we also have post coordination, whereas initially with ICD-10, when you tell it is a breast cancer, so you just tell it is a a female died of a breast cancer. Whereas in ICD-11, we have the type of cancer, the site of the cancer, the location, and all the things have been included as post coordination in the ICD-11. So this district CRS approach has been implemented in the district of Krishnagiri and Karur to strengthen the mortality statistics. And our intention is not to go about with verbal autopsy over a long period of time, rather to strengthen the availability of Form 4 and 4A that is available with the state. Thank you.
I thank Dr. Manju for the elaborate session on district CRS approach, which is implemented in Karur and Krishnagiri districts. Any questions from the audience? Okay, thank you.
Thank you for the elaboration, ma'am. We humbly request Dr. Nagarani, JD Training, to felicitate Dr. Manju and the moderator, Mrs. Sumati, JD SBHI.
Moving forward, we will begin the session, Lessons Learned from the Field, where our district health officers and city health officers will share their invaluable public health experiences and insights gathered from their work in the field. To start this session, I kindly invite Dr. Cheran, Director, Madras Medical College, to moderate the session. Welcome, sir. We would like to invite Dr. Sendil, District Health Officer, Kanjipuram, to share his experience.
Beloved director and respected all others. So I would like to share my experience on VBDC and communicable diseases and interdepartmental coordination. Next slide. Next. I have joined at Kanjipuram district during February of this year. So our district collector has arranged the first interdepartmental meeting. I have presented all the details of chlorination at 1950 OHTs in all the village panchayats and municipalities. I have listed even what are all the local bodies which is not having stock of bleaching powder, which does not do the chlorination in time. Everything I have, including the periodical tank cleaning is not happening. That is also I have listed. And I have placed hotspots for dengue and all other communicable diseases, including scrub. I have listed out and engagement of DBCs and other support for fogging. Everything I have listed in the first interdepartmental meeting. 1 month has passed, then suddenly we had an outbreak of ADD in a small village very near to Kanjipuram district. 2 deaths and 204 cases has happened. So this time the district administration murmured the statement that public health has shown a right direction, but we only missed to follow. So this low voice murmur echoed in the entire district in a loud voice. We got the importance, public health department really got the importance during that time. Consequently, the district collector has suspended village panchayat secretary and also tank operator immediately. This has mad shivering of spine of all other concerned departments. Really, we have got a good grip over during those period. Next slide. So immediately, next slide. Next slide. What's next? Immediately we arranged training for all the administrators, including the panchayat presidents and the local public representatives. We arranged training, tank operators, all the concerned department, training of chlorination, mosquito control, other communicable disease control, and including the very critical areas we have touched teenage pregnancy and NCD and the public health acts, how it is going to be implemented if any violation, everything we have given in a training. And after that, all the medical officers and HIs, BHS, all were instructed to give written communications to all the village panchayats and town panchayats periodically. Whenever cases and even chlorination is not there, the OHT cleaning is not there, everything is recorded in a written manner and it is intimated to all the village panchayats, which has done a better improvement in all the aspects. Next slide. And we have written communications to all the private doctors in the entire districts to notify the notifiable diseases. And also we have formed a WhatsApp group also. In the WhatsApp groups, they have started notification of all the diseases, including fever, ADD, everything. They have started intimating us. In response to that, we instructed health inspectors or block health supervisors to acknowledge the message, acknowledge the notification what they given. So noted for follow-up or noted for field activity. This this reduces the gap between the private and our department. And we have started providing alerts and protocols of our government treatments regarding communicable and other diseases. Alerts means what are all the villages or hotspots at the current period or current month or current week. We have started giving the list and alerts, re-imaging, emerging diseases and news clips, videos. Our DPs are he's frequently giving videos on lot of communicable diseases that we are providing to our private doctors. That definitely improves the even reduces the gap between public health and the private sector. And we have started giving public health notices to the defaulters of the private doctors. If they are not giving the proper notification, if any cases are admitted without our knowledge, we immediately started giving public health notices. This also alerted the private doctors and the things got improved. Next slide. And training, apart from the other department training, we have started our department staffs well trained and other staffs like sanitary workers and self-help groups, the related staffs they have also been trained in a better manner. And teachers, we have given RBSK and RKSK trainings to all teachers, nodal teachers of 960 schools. All the teachers have been trained in the aspects of communicable and including non-communicable diseases also. Every month on 3rd Wednesday, Ungalai Thedi Ungaluril, the CM's special program is being implemented. On that day, 1 minute. On that day, all the district level officials will visit a block completely. So all the officials are given with a checklist of communicable and non-communicable diseases and other communicable diseases, including vector-borne diseases. They have started checking all the parameters of chlorination, OH2 tank, everything have got improved, and the agenda is being repeatedly placed at Gram Sabha also, and at the PH level, patient welfare societies and JAS meetings, village health and sanitation committee meetings. These subjects of BBDC has been started placed, so it gives improvement. Next slide. So my conclusion is interdepartmental meeting doesn't mean that it's a meeting at the level of the district alone. It should be happen at all the levels, village level, block level, and the district level, and the regular trainings. That is very much essential, and the proper WhatsApp groups with the various departments that will help. Periodical written communications to all other departments regarding the situation and alert that will help us, and interpersonal communications. Finally, at the end, if nothing is happening, then we have to give public health notices. Definitely that will attract the other departments or other private persons towards our goal to be achieved. Thank you.
Nice presentation by the DHO Sindil. He explained about the interdepartmental review meeting with the head of collector and trainings to the local bodies and involving the private doctors. Very nice. What is the outcome?
So it has reduced, sir. July and August month we have dengue cases of around 140. The current month only 45, sir.
Very nice. Very
yes,
nice.
Sir. Thank you, sir.
Thank you, sir. A warm welcome to Dr. Bhanumati, Vellore DHO, to share her experience on the mobile medical units.
Hand mic கொடுத்துருங்க. And all my higher officials and my colleagues and dear friends, this is our general profile of my district, where we have 17 lakh an odd population, which we have 7 blocks and 2 municipalities, 1 corporation, 4 town panchayats, and 247 village taluk 6 and revenue villages 317, schools 1275, and number of Anganwadi centers 1075. So this is our mobile medical unit, is delivered which is to the rural and the most underserved and hard to reach areas and inaccessible areas. This is a key component of our outreach programs in public health. The purpose is to bridge the healthcare accessibility gap and also to provide a preventive diagnostic and also to treat the minor treatment ailments. The strength of the MMU is which takes our healthcare to the remotest areas, the underserved areas, hard to reach and inaccessible areas, where the hospitals, the PHC, HSC or any even private NGO clinics also cannot access. The cost-effective service delivery, which reduces the need for patients to travel to distant healthcare facilities, saving time, money, and also the quick diagnosis. Rapid response during crisis, again, it's a very boon. It's a boon. All our MMUs are boon to especially during outbreaks, natural disasters, and public health emergencies. And also, it helps to create awareness about preventive measures, sanitations, and lifestyle changes in rural communities. So totally we have 7 MMUs, each for each 1 block, and tribal again NGO CHAD, which is attached to our Christian Medical College Vellore, and 1 labor MMU. So totally we have 9. These are all regular MMU, our camp, our respected district collector and our MMU team. This is again in Makkaludan Mudalvar scheme also our team is there, and also we also do track our antenatal and high risk mother tracking, and this is one of the postnatal visit by our MMU team where our medical officer is sitting on the floor and seeing our postnatal mother and the baby at her home. This is again one of our MMU team is visiting old age home, and again our patient support group meeting is also been conducted. This is again our particularly vulnerable tribal group camp which is being conducted in the hill areas, and again this is again visiting hard to reach area, the Irular colony. So these are the total MMUs where we have 7 mobile medical units where we have conducted 101.3 camps are conducted. These are the number of persons attended, and also we have referred the cases from our MMU also. This is our tribal MMU activity. Again, our own MMU as well as the NGO Chad Hospital, they also take care of them. So this is again a medical camp, our at PVTG group area, and this is a school screening by our medical officer and the VHN and our WHV, all the teams are there. This is again a tribal performance for MMU from April 24 to August 24. We will be completing the rest of the camps. This is again our labor MMU activities in our district, where we have done our work-based screening in our district. We have gone to the industries, and this is our respected collector, our mayor ma'am, and our political people political commitment is also very important in this aspect where we can reach easily. This is again for migrant worker screening, and the construction site screening also we do take care. This is again a cutaneous leishmaniasis case detection, which is an initiated treatment also, which is detected by our labor MMU. Is one of our patient from North India, is a migrant. So this is a yearly report where we treat a number of camps are being conducted, and lab investigations are being done, and also persons treated, and also referral also we take care. This is again from April to August 24, where we do all types of investigations and screening and treatment also. So we do face some challenges, particularly in MMUs, because it's the most hard to reach area. Our team is there, vehicle is there, fuel, no issues with from public health side, but the issue is with the road. So the road's accessibility is very difficult. That constraint has to be dealt only with the district administration help as well as with the forest department. So I had that, I went and requested our district collector, former district collector, to the problem in the reaching this MMU in time, or whatever challenges we are facing. So sir immediately called forest department, had a meeting there, and roads were laid, and now wonderful roads have been laid to reach the surrounding hills of Pinjamandai of Odukatur block. And not only the roads have been laid, even he provided us a vehicle, extra vehicle also, which is stationed at the hill itself, so that people can be transported from there, our AN mother or PN mother or any sick child, and especially the snake bite cases also have been transported from there to medical college or our nearby Anikat GH or at Odukatur, our block. And we do have regular upkeeping of vehicles, and medical equipment is also required, and leading to frequent breakdowns or operational issues also we do face. And staff retention issues again is a problem where we are managing. We motivate them during our block review meetings, and we also keep them motivated so that we do not face such challenges. And sometimes the cooperation of NGOs, the non-compliance of FTPs, or sometimes the overlapping of the areas, because our same team must have visited the area. The very next day, the team from the from the Chad, they also go and reach the same area. So I called them, I made a meeting for them, told them not to overlap. I discussed with our BMO, discussed with our medical officer, you prepare a FTP so that there is no overlapping, unnecessary waste of time, money and manpower. So I think we can have these opportunities integrating telemedicine services like e-Sanjeevani and more involving NGOs enhance the funding and support and service quality. Only one NGO right now working for Vellore. And MMUs again provide opportunities for training healthcare workers and increasing their exposure to rural health challenges. So there is definitely no doubt about it. They are offering essential healthcare services in areas lacking access, but face capacity, staffing and logistic challenges also. So by addressing this operational weakness and leveraging such as technology, MMUs can further improve healthcare outcomes in the rural areas. I thank our respected DPH sir for providing me this opportunity on this platform. Thank you.
Thank you, Dr. Bhanumati. But one thing I want to enlighten, there should be some coordination with the PSC works. I mean, with the MMU and should coordinate with the PSC in certain things.
PHC sir, this MMU block is in each block we have one vehicle. So we conduct regular block review meetings where we call even this our MMU doctor also to be available in the meeting so that we can review his performance.
Okay. Okay.
Thank you, sir.
Thank you.
Thank you, ma'am, for that wonderful presentation. We kindly invite Dr. Govindan, District Health Officer, to render his presentation on Anganwadi screening and its effectiveness.
Good afternoon, respected DPH sir, other dignitaries. My topic, teenage pregnancies analysis in Tenkasi district. Yes, it's a cross-sectional study. Next slide, please. So, globally, around 21 millions become pregnant among the teenagers. Among them, 12 millions birth giving teenagers. This is around 10 to 20% contributing the maternal death. So during the complication of the teenage pregnancy and the deliveries. So in India, NHF survey 5 says, so 6.8% is women teenage pregnancies. In Tenkasi, it shows 4.3%. Next. Study objectives to estimate the burden of the teenage pregnancies in Tenkasi district in Tamil Nadu. So time plus persons study. Next. So the cross-sectional analysis, data shows PICMI and ANC registration 2021 to 2024 up to August. So definition, teenage pregnancy defined as the girls registered in the antenatal period up to 17 years of completed ages. So analysis percentage of teenage pregnancies among the total ANC registrations. So descriptive study, time plus persons, both urban and rural and age group. Next one. So total teenage pregnancies, so 231 in year 2021, so 180 22-23, so 159 22-23, 77 up to August. So next one. So all blocks teenage pregnancies present. So among the age group, so 17 highest 52 persons, 16 years 20, so 15 years 4, 14 years 1, total 77 during the current year. Next one. This is the block-wise distributions. 3.5 years average. So Vasudevanallur is our highest, then Kuruvikulam, Kadayam, Tenkasi, Melanidinallur, like that. Next one. So ANC registration, teenage pregnancy percentage plus total ANC registrations. Teenage pregnancy presented in the both urban and rural, so little higher on the rural side. Next one. So marital status and pregnancy data. So 70% of the pregnancy occurred before marriage. So 6.5% at second pregnancy, G2 pregnancy, before turning of 18 years. Next ones. Married before teenage pregnancy in Tenkasi districts, around 2/3, 58 mothers become pregnant, then going for marriage, 19. After marriage, then going for pregnancy. Next. Gravida wise, so G1, 72 mothers, G2, 5 mothers. Next. Marriage and educational status. So place of marriage, teenage marriage at home 43%, at the temples search like that 43% marriage occurring. Educational level of the teenagers, higher secondary education, sir. Those studying in the higher secondary educations around 45%. High school going teenage girls is getting pregnant 44%. Next one. So leading cause of pregnancy is love marriage is around 41%. So in males occupations, 86% of the males occupation daily wages, workers like that. This is the reason for teenage pregnancy. Love marriage 34%, arranged marriage 30%, family situation like single parents, girl with living with a grandparent like that, 13. Next. So boys occupations, daily wages 66%, own business 2%, and salarized persons 9. Next one. So most age group 17 years age is the most affected. Highest incidents reported in the especially northern Tenkasi districts is Vasudevnallur, Kurivikulam, like that, Malnutrition, like that. But the prevalence is entire district is teenage prevalence present. Second gravida also is noticed. Targeted interventions. So say teenage pregnancy is most concern. So we knew on the chairman of district collector. So multi-sectoral, social welfare, education department, local body, municipality, corporations, and town panchayat. We need to give continuous awareness and each and every meeting, including Grama Sabha also. So we need prevent the teenage pregnancy. It's a long term and sustainable one. That's all, sir. Thank you, sir.
Nice presentation by Dr. Govindan. One thing I want to say, economic correlation and economic and education correlation between the illegal pregnancy to be identified. Is there any study there?
What, sir?
See, nearly 44% of illegal pregnancy, that
Yes,
is
sir.
before marriage. So is there any economic and educational correlation between the illegal pregnancies? Any study? Is there any study to correlate? The illegal pregnancy is more in uneducated people and in the low income people. Is there any study? Do you have any?
So, daily wages like that, sir.
Yeah.
Low socioeconomic status, sir.
Yeah.
Love marriage like that.
You have to identify. And if you identify whether
Yes,
the
sir.
educational and economy is the main reason, you have to improve
Okay, sir.
with the help of the district administrations.
Okay, sir. Okay, sir.
Thank you.
Thank you, sir. Thank you, sir.
Yes. Just one or two queries. One is regarding, you have not written anything regarding the what is the connection between the RKSK program and what you have done. So number one. Number two is whether percentage of these girls who are out of school children, who are not going to school. So if that is the issue, then whether the line list is available in the Anganwadi centers for our people to follow.
Yes, sir. So one is RKSK, sir, the RBSK, sir. We are giving awareness to the education department through CEO and also other department also, sir. We are utilizing the RKSK clinic also for giving awareness, peer pressures and also sexual transmitted infections we are giving, sir, regularly, sir. So out of school going children around, we are taking the list also, sir. We are taking continuation of the education also. We are with the collector chairmanship and the CEO, we are readmission in the schools also we are following, and also we are giving the sanitary napkin and all remaining services through the Anganwadi, sir. We are providing it, sir.
You didn't come to the point, but
Okay. Thank you, sir.
Thank you, sir. A hearty welcome to District Health Officer Dr. Geeta Rani to share her experiences.
Good evening all. This is Dr. Geeta Rani. I am coming from 350 kilometers away from Tanjore towards south, which is located on the southernmost tip of the Deccan Plateau, which is also called the Oxford of South India. It is the only district which has perennial river, which originates from Podigai Hills and flows into Gulf of Mannar. So it is none other than the city of Halwa, that is Tirunelveli district. Before entering into Tirunelveli, I know how to eat halwa. Now I know how to give halwa. And also I myself have $1 million question, that is how Geeta Rani is surviving at Tirunelveli district, how she boldly coming here and presenting in front of our respected Director of Public Health and Preventive Medicine. That is because of our public health team at Tirunelveli who are here. So I take this opportunity to thank my lovable VHN, SHN, CHN, HI, medical officers and my most respectable BHS, BMOs and second level officers and others. Coming to my district, that is we know malnutrition. Malnutrition refers to deficient or excess nutrient intake. Regarding our 2022 WHO data, 250 million children were affected by malnutrition. Among them, 250 million children, 49 million children were overweighted and 200 million children were comes under undernutrition. Among the 200 million children, 149 children were wasted and 41 children were overweighted. So coming to why this is important, our stunting and wasting and undernutrition. Because it is nearly half of the deaths among children under 5 are linked to undernutrition, who are more prone to catch disease and death, and also more occur in low and middle income countries in the form of wasting, stunting, underweight, and deficiency in vitamins and minerals. Coming to the definition of wasting and stunting. Wasting which means low weight for height, less than 2 standard deviation, which indicates the acute undernutrition. And coming to the stunting, which means low height for age, less than 2 standard deviation, which indicates chronic undernutrition. And with both conditions are associated with poor socio-economic conditions, that means the poverty and low education, poor maternal health and nutrition, and frequent illness such as the respiratory infections and acute diarrheal diseases among the children, and the contaminated environment, and lastly inappropriate infant and young child feeding. Here already I mentioned the prevalence of stunting and wasting. Here we show the tabular column. It shows the prevalence of children under 5 years of age in percentage, stunted, wasting and underweight between Tirunelveli, Tamil Nadu and India. Here the prevalence of Tirunelveli of stunted children is around 29%, which is 6.5% more than India and 4% less than our Tamil Nadu. Similarly, wasted prevalence in Tirunelveli is around 18%. It is around 3.5% higher than India and 4.5% higher than Tamil Nadu. In the 4% lower in India. Similarly, underweight also 5% higher than India and lower than Tamil Nadu. And how we address this undernutrition and district level? Here we see the Anganwadi screening twice a week, and we identified 1,560 children were SAM and MAM. 226 children we identified as SAM from April to September 2024, as well as 1,334 children were identified as MAM. And among these shunting, 1,352 children we identified, and we refer both wasting and shunting children 100% to the DEC for management as well as the evaluations. And also we have monthly every second Tuesday we have interdepartmental coordination meeting. We are addressing the field level challenges. And also our district health officer advisors as well as our district collectors are regularly reviewing our program week wise as well as the month wise. This is Anganwadi screening. This is interdepartmental coordination meeting at block level, and at DEC Center for Evaluation and Treatment of Referred Children. This is our review at block level. These are the challenges we face, that are discrepancy in the number of children in portion tracker and number of children in the Anganwadi register and actual number of children present in Anganwadi while screening. And also variations in number of SAM and MAM children in the portion tracker and actual screening due to entry of weight and health with the old data. Thank you all. Nandri Vanakkam.
Beautifully explained by DHO Dr. Geeta. I want to note only one thing. Regarding malnutrition, now obesity is also a part of malnutrition. But I hope it is not common in India and Tamil Nadu. But overweight is also an important thing. So you have to concentrate some extent.
Yes, sir. Thank you, sir. I focused on my title only, sir.
Okay.
Thank you, sir.
Thank you. Thank you.
Thank you, ma'am. We request Dr. Satish Raghavan, JD Tansax, to felicitate the moderator of the session, Dr. Cheran, Director, MMC, Madras. Let's have a short tea break and reassemble again, reassemble at the hall after 10 minutes. Thank you. பத்து நிமிட தேநீர் இடைவெளிக்கு பிறகு மீண்டும் அரங்கில் சந்திப்போம்.
என்ன புது பொண்ணு விசேஷமா?
விசேஷம்லாம் இருக்குக்கா. ஆனா இந்த நேரத்துல குழந்தை பெத்துக்கணுமான்னு யோசிக்கிறேன்.
ஏன் அவ்வளவு யோசிக்கிற?
இல்லக்கா, என்னையும் பாப்பாவும் நல்லா பாத்துக்கிறதுக்கும் சத்தான உணவு சாப்பிட்றதுக்காகவும் கொஞ்சம் காசு சேர்த்து வச்சுட்டு அதுக்கப்புறம் குழந்தை பெத்துக்கலான்னு யோசிக்கிறேன்.
அதுக்குதான் நம்ம அரசாங்கம் கொண்டு வந்திருக்காங்க டாக்டர் முத்துலட்சுமி ரெட்டி மகப்பேறு நிதி உதவி திட்டம்.
இந்த மகப்பேறு திட்டத்துல எங்களை போல கர்ப்பிணி பெண்கள் பயன்பெற நாங்க என்னக்கா பண்றது?
இந்த திட்டத்துல நீங்க கர்ப்பம் உறுதி செய்யப்பட்ட 12 வாரத்துக்குள்ள உங்களோட ஆதார் எண், தேசிய மயமாக்கப்பட்ட வங்கியோட பாஸ்புக் மற்றும் போட்டோ இதெல்லாம் எடுத்து சென்று அருகிலுள்ள துணை சுகாதார மையத்துல பதிவு செய்ய வேண்டும். இத்திட்டத்தின் முதல் தவணை தொகை ரூபாய் 6000 உதவி தொகையும் இது தவிர தாய் சேய் நல பெட்டகமும் கிடைக்கும்.
சொல்லு சுமதி.
மா, டாக்டர் முத்துலட்சுமி ரெட்டி மகப்பேறு திட்டத்தோட முதல் தவணை ரூபாய் 6000 என்னோட அக்கவுண்ட்ல நேரடியா கிரெடிட் ஆயிடுச்சுமா.
சந்தோஷமா இருக்குமா? இது மட்டும் இல்ல, உன்னோட 6வது மாசத்துல 2000 ரூபாய் மதிப்பிலான 2வது ஊட்டச்சத்து பெட்டகமும் தருவாங்க.
தாய் சேய் நலன் மற்றும் ஆரோக்கியத்திற்கு வேண்டி கர்ப்பம் தரித்த 101 நாளில் இருந்து பிரசவம் வரையும் மேலும் 6 மாத காலத்திற்கு இரும்புச்சத்து மற்றும் ஊட்டச்சத்து மாத்திரைகள்.
அரசு மருத்துவ நிலையத்துல பிரசவம் முடிஞ்சு இன்னும் 4 மாசம் கூட ஆகல. அதுக்குள்ள நம்ம அரசாங்கம் 2வது தவணை தொகை 6000 கொடுத்ததுனால எனக்கு எந்த சிரமமும் இல்லாம என்னால சுமதியையும் என் குழந்தையையும் சந்தோஷமாவும் ஆரோக்கியமாவும் பாத்துக்க முடியுது.
என்ன சுமதி, பாப்பா எப்படி இருக்கா?
நல்லா இருக்காக்கா. 3 மாசம் தடுப்பூசி போட்ட கையோட கடைசி தவணை தொகையும் அக்கௌண்ட்டுக்கு வந்துருச்சு. தமிழக அரசு தமிழ்நாட்டு பெண்களுக்கு மிக சிறப்பான சேவையை பண்ணிட்டு இருக்காங்க.
உங்களுக்கு மட்டும் இல்லம்மா, எங்களை போல வெளி மாநிலத்துல இருந்து வர்றவங்களுக்கும் பிரசவத்துக்கு அப்புறம் 4000 ரூபாய் உதவி தொகையும் அதுக்கு முன்னால 2000 ரூபாய் மதிப்புல நியூட்ரிஷன் கிட்டும் தமிழ்நாடு அரசு தர்றாங்க. எங்க அரசாங்கத்தை விட தமிழ்நாடு அரசு சிறப்பா செய்றாங்க.
எங்களை போல பெண்களின் நலம் காக்கும் தமிழக அரசுக்கு நன்றி.
மதிப்பிலான 2 ஊட்டச்சத்து பெட்டகங்களும் மொத்தம் 18000 ரூபாய் மதிப்பிலான பயன்கள் வழங்கப்படுகின்றது.
இப்படி 18000 ரூபாய் இந்த திட்டத்துக்காக தமிழ்நாடு அரசு ஒதுக்கி இருக்காங்க.
இவ்வளவு சலுகை கொடுக்கறதா இருந்தா ஏழை ஜனங்க கூட வீட்டுக்கு 3-4 புள்ள பெத்துக்கலாம் பாருங்க.
கிழவிக்கு ஆசைய பாரு. மொதல் 2 குழந்தைக்கு மட்டும்தான் இந்த திட்டத்தோட முழு பலனும் கிடைக்கும். அதையும் மீறி 2க்கு மேல பிறந்தா 2 நியூட்ரிஷன் கிட் கிடைக்கும். குழந்தை பிறந்த உடனே இந்த தம்பதிகள்ல ஒரு ஆளு குடும்ப கட்டுப்பாடு ஆபரேஷன் பண்ணிக்கிட்டாதான் ஒரு தவணை 4000 ரூபாய் உதவி கிடைக்கும்.
மகப்பேறு தாய்மார்களின் நலன் கருதி வெளியிடுவோர் பொது சுகாதாரம் மற்றும் நோய் தடுப்பு மருந்து துறை.
ஏய் செல்வி, அம்மா செல்வி வந்துட்டா, நான் போயிட்டு வரேன். பாடி போலாம்.
வாசன்முகம், இவ்வளவு அவசரமா நிலத்த வைக்கிற அளவுக்கு உனக்கு என்ன பிரச்சனை?
என் பொண்ணுக்கு கல்யாணம் பண்ணி வைக்க முடிவு பண்ணியிருக்கேன். அதான்.
நீ செய்ய போற பாவத்துக்கு எங்களை ஏன்பா உடந்தையா இருக்க சொல்ற?
அண்ணே, உங்களுக்கு என்ன புத்தி கித்தி கெட்டு போச்சா? கல்யாணம் பண்ற அளவுக்கு நம்ம பிள்ளைங்களுக்கு அப்படி என்ன வயசாயி போச்சு? மேற்கொண்டு படிக்க வைங்க. அவ வாழ்க்கைய அவளே பாத்துக்குவா. உங்க 2 பேரையும் சேர்த்தே பாத்துக்குவா. இந்த சின்ன வயசுல கல்யாணம் பண்ணி வச்சீங்கன்னா அவ குழந்தைய சுமக்கிற அளவுக்கு மனசுலயும் உடம்புலயும் தெம்பு இருக்காதுன்னு. ரொம்ப சின்ன வயசுல கர்ப்பமானாலும் தாய்க்கும் பிள்ளைக்கும் உயிருக்கே கூட ஆபத்தாகலாம்.
அப்படியே குழந்தை நல்லபடியா பிறந்து வந்தாலும் அந்த சூழ்நிலை எதிர்கொள்ளக்கூடிய அளவுக்கு பக்குவம் வர்றதுக்கு இன்னும் வயசாகும்பா.
இந்த வரனை விட்டுட்டுனா சரியான மாப்பிள்ளை கிடைக்கிறது ரொம்ப கஷ்டம்.
அவ எதிர்காலம் நல்லா இருக்கணும்னா அவ கல்யாண விஷயத்த கொஞ்சம் தள்ளி வைங்க. 18 வயசுக்கு மேல கர்ப்பமாகிற பொண்ணுங்க தான் டாக்டர் முத்துலட்சுமி ரெட்டி மகப்பேறு நிதியுதவி திட்டத்துல பயன்பெற முடியும்.
டாக்டர் முத்துலட்சுமி ரெட்டி மகப்பேறு நிதியுதவி திட்டத்தில் ஏழை எளிய கர்ப்பிணி தாய்மார்களுக்கு மகப்பேறு நிதியுதவி தொகையாக 3 தவணைகளில் 14,000 ரூபாய் நிதியுதவியும் 4,000 ரூபாய் மதிப்பிலான 2 ஊட்டச்சத்து பெட்டகங்களும் மொத்தம் 18,000 ரூபாய் மதிப்பிலான பயன்கள் வழங்கப்படுகின்றது.
சண்முகனா, உங்க பொண்ணு டிவில வருது பாருங்க. 12th ஸ்டேட் ஃபர்ஸ்ட் வந்திருக்குனா?
அப்படியா?
ஆடா
ஏங்க,
ஏய் நம்ம பொண்ணுடி.
நான் ஸ்டேட் ஃபர்ஸ்ட் வாங்கினதுல எனக்கு ரொம்ப சந்தோஷம். டீச்சர்ஸ்லாம் என்ன ரொம்ப நல்லா என்கரேஜ் பண்ணாங்க. எங்க அப்பா அம்மா என்ன ரொம்ப கஷ்டப்பட்டு படிக்க வச்சாங்க. பெரிய சயின்டிஸ்ட் ஆகணும்ன்றது தான் என்னோட கனவு.
இப்படி படிக்கிற பிள்ளைக்கா கல்யாணம் பண்ண பார்த்தேன்.
எல்லாருக்குமே ரொம்ப தேங்க்ஸ்.
வளரிளம் பெண்களின் சிறகுகள் வானம் நோக்கி பறக்கட்டும்.
மகப்பேறு தாய்மார்களின் நலன் கருதி வெளியிடுவோர் பொது சுகாதாரம் மற்றும் நோய் தடுப்பு மருந்து துறை.
தமிழ்நாட்டின் மகளேவா, தாய்மையில் ஜொலிக்கும் அழகேவா, உன் மகப்பேறு கால சந்தோஷம் அதற்கு உதவி செய்து நம் அரசாங்கம். தாலேலோ தாலேலோ தாலேலேலோ தாலேலோ தாலேலோ தாலேலேலோ. உதவித்தொகையும் ஊட்டச்சத்தும் தாய்க்கும் சேக்கும் சேர்ந்தே கிடைக்கும். வருவாய் இழப்பை ஈடுகட்டி சத்தான ஆகாரம் இத்திட்டம் கொடுக்கும். பேறு காலத்தில் ஆரோக்கியம் சீரக்க, இரத்த சோகை வராமல் தடுக்க, கோழு கோழு குழந்தை பிறக்க, சரியான தடுப்பூசி கிடைக்க, இவை அனைத்தும் எங்கள் பொறுப்பென்று உறுதி தருது தமிழ்நாடு அரசு இன்று.
டாக்டர் முத்துலட்சுமி ரெட்டி மகப்பேறு நிதியுதவி திட்டத்தில் ஏழை எளிய கர்ப்பிணி தாய்மார்களுக்கு மகப்பேறு நிதியுதவி தொகையாக 3 தவணைகளில் 14,000 ரூபாய் நிதியுதவியும் 4,000 ரூபாய் மதிப்பிலான 2 ஊட்டச்சத்து பெட்டகங்களும் மொத்தம் 18,000 ரூபாய் மதிப்பிலான பயன்கள் வழங்கப்படுகின்றது.
தமிழ்நாட்டின் மகளேவா, தாய்மையில் ஜொலிக்கும் அழகேவா.
தாய்மார்களுக்கு மகப்பேறு நிதியுதவி தொகையாக 3 தவணைகளில் 14,000 ரூபாய் நிதியுதவியும் 4,000 ரூபாய் மதிப்பிலான 2 ஊட்டச்சத்து பெட்டகங்களும் மொத்தம் 18,000 ரூபாய் மதிப்பிலான பயன்கள் வழங்கப்படுகின்றது.
இப்படி 18,000 ரூபாய் இந்த திட்டத்துக்காக தமிழ்நாடு அரசு ஒதுக்கி இருக்காங்க.
இவ்வளவு சலுகை கொடுக்கறதா இருந்தா ஏழை ஜனங்க கூட வீட்டுக்கு 3-4 புள்ள பெத்துக்கலாம் பாருங்க.
கிழவிக்கு ஆசையை பாரு. மொதல் 2 குழந்தைக்கு மட்டும்தான் இந்த திட்டத்தோட முழு பலனும் கிடைக்கும். அதையும் மீறி 2க்கு மேல பிறந்தா 2 நியூட்ரிஷன் கிட் கிடைக்கும். குழந்தை பிறந்த உடனே இந்த தம்பதிகள்ல ஒரு ஆளு குடும்ப கட்டுப்பாடு ஆபரேஷன் பண்ணிக்கிட்டாதான் ஒரு தவணை 4,000 ரூபாய் உதவி கிடைக்கும்.
மகப்பேறு தாய்மார்களின் நலன் கருதி வெளியிடுவோர் பொது சுகாதாரம் மற்றும் நோய் தடுப்பு மருந்து துறை.
I request you all to please be back. Kindly reassemble because we have to start the session on panel of discussion.
அனைவரும் அரங்குக்கு திரும்புமாறு அன்புடன் கேட்டுக்கொள்கிறோம். ஆறு மணிக்கு கலை நிகழ்ச்சிகள் ஆரம்பிக்க வேண்டியிருப்பதால் வெகு விரைவில் அனைவரும் அரங்குக்கு திரும்புமாறு அன்புடன் அழைக்கின்றோம்.
I kindly request all to come back as we have to start the session. Welcome to our panel of discussion on vital role of primary care to overcome challenges in TB elimination. To start with, I would like to invite Dr. P. Sampath, Additional Director, Disease Control, to moderate the session. Welcome, sir. I'm excited to hear the insights from our panelists, Dr. Raghuram Rao, Additional Director General, Central TB Division, Dr. Nirmal Jo, Senior Regional Director, Health and Family Welfare, Dr. Asha Frederick, State TB Officer, Tamil Nadu, Dr. Ra Prabhu Ravanan, WHO TB Consultant, Mr. P. Rajeshwaran, Social Health Specialist. I welcome you all for this panel of discussion.
Good evening to all. First, I welcome Dr. Raghuram Rao, AD General, Central TB Division, Ministry of Health and Family Welfare, GOI, and Dr. Nirmal Jo, Senior Regional Director, Health and Family Welfare, GOI, and Dr. Asha Frederick, State Program Officer, TB, and Dr. R. Prabhu, WHO TB Consultant, and Dr. Rajeshwaran, Social Health Specialist, REACH NGO. I welcome you all, sir. First, the vital role of primary care to overcome challenge in TB elimination. That is the panel. First question is, what are the current barriers to detect early TB diagnosis in primary care setting, and how can they be overcome, sir? Question over to Dr. Raghuram Rao, sir.
Good afternoon, everybody, and thanks to the state government of Tamil Nadu for organizing this. Very happy to be here, and also happy to see how the public health cadres in the team. So, with the primary care, the question that we are trying to answer, to answer this question, it is not possible to answer from Delhi. So, yesterday and today I went to the field. In Coimbatore, I went to urban area, rural area, public sector, private sector, spoke to patients in Coimbatore and in Tanjore, and so the answers is based on that, right? So, first of all, at the primary care level, the comprehensiveness is not there, in the sense that for tuberculosis, it is vertical. So, the MLHP or the field people have limited role in tuberculosis, apart from just maybe any symptomatic they find in the community, refer them, and then we get tested. What happens is that we miss cases, or when we find cases, it is passive. It is too late. They are so late that we have a very high death percentage in Tamil Nadu as compared to rest of the country, and there are multiple factors why death is high, including comorbidities and low BMI, primary reasons for that. But when I want to add it as part of primary health care, then I think we should first articulate the health cadres. There is a health inspector, there is a MLHP, there is women health volunteers, male health volunteers, and then an MO. In that, apart from the MO, the others have very limited role as of now, and that too at primary health center and above. But below that, at the community level, there is limited role that is being played. So I think we need to define the roles for each in terms of one, which population in the PHC area is TB going to occur from. You've done your own prevalence survey in Tamil Nadu. Wonderful exercise, wonderful insights from the data. But the data is useless unless we put it to action in the field. That action is that all my sub-health centers, all my PHCs should have a line list of those population which account for 80% of the TB cases in Tamil Nadu. And that is just around 6-7 categories. And there's a very standard principle in management, a 80-20 relationship. So 20% of the population in the district is giving you 80% of the cases of TB in that district. So focus on them, and the focus should be on early diagnosis and prevention. That's the reason why, because when we catch TB, it is too late, and we have 8, 9, 10% mortality that is happening. So there, as part of primary care, the job of the peripheral staff is to know which population, regular screening at the health and wellness center and the PHC as part of master health checkup that we do once a year. But here in this population, let us get them to the PHCs and sub-health centers at least once in a quarter. Try and get an X-ray. Without an X-ray, even in the prevalence survey for Tamil Nadu, we have seen half of the cases are asymptomatic. And hence, if you don't do an X-ray, they'll wait for symptoms to develop, and then when they come, it is a full-blown TB case, 3+ max, We see that in the microscopy and TrueNat. So early detection, one, is in terms of the field to be able to pick up the population, catch them, make it part of routine job. Unless it is part of routine job, it is part of the key performance indicators which the block MO reviews with the PHCs, the district reviews with the blocks, the state reviews with the districts. Make it a key indicator as part of primary care. And once we start doing that, automatically it is ingrained, and then they start looking for it. So early screening, reaching out to the right population, collecting the sample, putting in mechanisms by which we are able to decentralize our diagnosis and treatment. Sub-health centers currently do not have TB medicines in Tamil Nadu. But we can, when we have a MLHP now, we can decentralize TB care to the sub-health center level where treatment can happen. There is telemedicine, but it is not getting used for TB, right? So you can always utilize the 12 package of services in the health and wellness centers that has now been given. Of that, all the other packages have an implication for TB. 30% of the population of TB have diabetes. So the NCD program is important for you all to do that. So what is happening is all these programs are in silos. There was a wonderful proposal from Tamil Nadu on the one-stop center, right? Now that's a concept where, irrespective of why somebody has come into this, you provide all services in one window, in one opportunity. So it's opportunistic screening for everything. So I think that is something which, if we are able to do it at the block and at the PHC level, where everything, all your priority programs, we have done epidemiology, all our public health people here will have seen, what is driving what disease in which population in the community. That's where I think we need to focus, and you do that in terms of activating the one-stop centers and the comprehensive primary care at the PHC and sub-health center level. We need to take TB down to the primary care level. As of now, 80% of the diagnosis is happening block and above, which means that primary level we are missing those diagnoses. They would have walked in, they would have definitely walked in for something or the other, but we would have missed, an opportunity for screening them. So I think that's probably the way forward. And you'll have been able to up the testing rate over last 2-3 years to almost 3,000 per lakh population, but the number of cases is the same yield out of it. Then we say, why are we not getting positive cases? In the field also, I have increased the testing rate, you told us to do that, we have done that, the cases are not coming. The sample that is collected, is it coming from the population from where 80% of the cases are going to come? Unfortunately, no. So we are testing, but we are probably testing the wrong population, and we are missing X-ray in terms of the screening level. So we'll be able to prioritize. I think that those are actions which in primary care, if we make it an integral part, definitely TB, both incidence and mortality reduction can happen and will happen in Tamil Nadu. I'm sure we have the systems to do that. Yeah.
Thank you, sir. Another one question is, the Government of India gave the target of 110,000 case notification for Tamil Nadu. Out of 38 districts, few districts got already eliminated status. Few districts still we have more number of cases. There where we are lack of getting notification from government as well as private side. But private sector, you are giving notification incentive that 1,000 rupees per case. Why we are not giving a case notification by our field staff or primary health care staff?
Yeah. So, incentives for public sector, right? So, one is that you and me who are employees get our salary, right? But like in Tamil Nadu also, the women health volunteers or the male health volunteers or anybody in the community who is a community volunteer, if you collect samples and they send or refer and then they get diagnosed, there is an incentive of 500 rupees. So even in the existing public health system, the most peripheral level field worker can get incentives. It's one awareness about that incentive to them. So when I sat with the ANM to say what is the schemes that you have, so little bit of lack of awareness in terms of her being able to know that what can I do and what will I get, or what will my female health worker get if we do it. So when the PHCMO and the block MO says samples should come in, samples come in, but from where or which population you want it, and if it is positive, you'll get this additional incentive. So once a few places we could see that also. So they were enthusiastic and they started doing it. So I think probably demand generation from both public health and community side, both sides. Once they know what are the different schemes, incentives, I think surely this can be done.
Thank you, sir. Next question, Dr. Nirmal Jo, Senior RD, sir. How can primary care providers improve early detection of TB in high-risk populations? Who are the high-risk population?
I just want to explain it with a few slides. I'll just go there. Next slide. Next. So, usually when we go to the primary health centers, first high-risk group, I always ask, who are the household and close contacts of the previous index cases? So the TB case is not going to develop from infection to disease within 1 or 2 days. It may take some time, we don't know. Sir, we checked, he was normal. He may develop the disease later on. So I think we have to bring in a concept where we've, just like the post-treated TB we follow up for 2 years, we'll have to bring a concept where we are going to follow up the contacts of these index cases a few months or a few years, so that we see that they develop from the infection to the, or we are also giving the preventive therapy, but still we'll have to check that. That is number one. Second high risk will be our treated TBs. Always our treated TBs are our another high risk. These treated TBs, we have a system now where the guidelines have been given for follow-up. But at the primary care health level, whether the line list of the treated TBs are available for the medical officer to know or for the male health worker to know to follow up that patient for the next 2 years. So this line list also should be available. Next is our pediatric and adolescent. So now just now we saw that our NFHS 4 has given SAM, MAM, so many patients, so much percentage. But whether the SAM line list is available at the PHC for the medical officer to screen for TB, this is another point which I wanted to make. So this is one thing. Whether, and one more thing what I thought was low BMI or stunted patients, pediatric patients in the PHC, nobody checks for height and weight in the PHC. Maybe we'll have to make a point where the pediatric OPD in the PHC level is checked for height and weight, just like our NCD patients. Next is our undernutrition I already talked about. In the pediatric population, what I was thinking was whether we will be able to bring in a induced sputum type of testing at the block public health unit, which is now being sponsored by our PM ABEAM scheme.
So whether if we can bring the induced sputum, which is a very simple way of getting sputum from pediatric population at the block level, then our primary care diagnosis of pediatric population will be good. Next is our alcohol dependence. Alcohol dependence, I think you know that we have so much of patients in the de-addiction clinics, and the government has also now proposed for another 19 more de-addiction clinics. So these types of line list should be available at the primary care level. These are the patients who were admitted in the de-addiction clinics. They also should be screened for TB. And another thing is, in the NCD screening, the checklist which they are having, the NCD screening checklist says history of alcohol, history of tobacco. That is also taken. So maybe we can get those line lists who are giving the history of alcohol and history of tobacco from the NCD clinic and screen them also for TB. So this is one more thing. Regarding our diabetes, I think everywhere in all the PHCs it's being done. Regularly all diabetes patients are being referred. But what I would like to say is all uncontrolled diabetes should be referred for TB diagnosis. That is a must. Next is with reduced immunity. I think this at the primary care level, only the pain and palliative in Tamil Nadu, the pain and palliative unit at the block level is having the line list of all patients who are malignancy, who are on treatment, and they are giving daycare chemotherapy centers at the GH, and they have the line list. Dialysis also, the MTM staff nurse is providing CAPD bags for the CAPD patients at the household level. So even this line list can be taken, and they also can be screened for TB. PLHIV, I think we are doing a very good job till now. We screen all of them at the ART centers. Next slide. One more thing, I think ANC. We are having a very good system of ANC screening for all others. But to include the ANC screening for TB, because we have our underweight numbers in our ANC clinic, underweight mothers. So whichever mother is less than 18 BMI can be screened for TB. So this type of screening also we should start at the primary care level. For infertility, now the government of Tamil Nadu has started infertility clinics. So all infertility clinics, they also should be screened for TB. That is number one. Gynec patients who are coming with gynec problems, they also should be screened for TB. Congregate sittings, this is very important. Refugee camps, long-term residential cares, mental health, MR homes, old age homes, night shelters, orphanages, destitute homes, government tribal and residential hostels, all these congregate settings, the PHC medical officer knows which are the centers in his area. So he should plan for a mobile medical unit for a screening in those centers, in those hostels around in his area. Geriatric population now, our geriatric population now we are having our MTM. In MTM also we have a line list of the geriatric population where they are going house to house. So that line list also should be used. Mental health. Mental health is another thing. PHC and CHCs are having drugs for all mental health patients. So mental health patients are coming and they are given drugs at the PHC and CHC in Tamil Nadu. So these patients also should be screened for TB. They have seen a very good correlation between TB and mental health illness. Next is viral hepatitis. That is also showing a very good correlation between hepatitis B and hepatitis C. So this line list also should be available at the PHC. Slums at the UPHCs. At the UPHCs, all the urban PHCs are already mapped the slums. So at the slum level, they should have, and at present we are having even our urban health and wellness centers. The urban health and wellness centers are staffed with medical officers and with one staff nurse. With the male MPW male is also available in all urban health and wellness centers. So these male workers also should be utilized for our screening of TB in those centers. Next. Migrants, this is available in rural and in the urban areas. So this also to be done. And the third gender and MSM, I think already we are doing a good job. Last but not the least, I think healthcare workers are missed out in the screening most of the places. So this is also, I think we should make it a very, very important part of our primary screening of. These are all the places where the primary care can be involved in screening for TB to increase our screening numbers. Next. This is another Ayushman Arogya Mandir.
Yes.
I can just go ahead with that. The Ayushman Arogya Mandir or our Nalavalva Mayam. Previous slide. So I think this is one part where we are not able to focus much. Awareness generation in the community. There I think we'll have to use our Ayushman Arogya Mandir for awareness generation. Awareness regarding TB services, health promotion, health seeking behavior. Because most of the barriers, if you say most of the barriers is the concept of drugs in the government sector are not good. The doctors won't be available when we go. So these are all the concept barriers. So cough etiquette, what are the NPY funds which are available? Fixed day awareness program to be concerned in every Ayushman Arogya Mandir. TB champions or survivors to be included in the Jan Arogya Mandir, in the Jan Arogya Samitis. They should be included in the RKSK, the Rogi Kalyan Samiti or the Patient Welfare Society, in Village Health and Sanitation Committee, in Mahila Arogya Samitis. Anti-stigma and non-discrimination. This is another barrier in our community. So this also should be, we have a health promotion and health seeking behavior in the Ayushman Arogya which we have to utilize for all these community level facilities. Next. So in the CHO and MLHP, like our additional DDG was telling, what all we can use? We can utilize our MLHPs, CHOs in other states and MLHP in our state, early identification. There is a target for all MLHPs, 20 OPD per day. That is the target. So that target, how much of screening of TB they are doing, whether our WHVs are utilizing our CBACs, active screening done with other programs. Leprosy is doing active screening, malaria we do active screening, sometimes filaria survey is being done, for immunization survey is being done. So many surveys are going on. Whether we are doing active screening along with those survey, quarterly screening of uncontrolled diabetics. The MLHP is one part of our NCD screening, so they also can be utilized for quarterly screening. Presumptive entry into Nikshay. All the presumptives, they can enter into the Nikshay. Sample collection and transport. Tamil Nadu has started IELS. So sample transport for both sputum and for NAT testing. Stocking of anti-TB, I think our additional DDG has already said, stocking of anti-TB at the sub-center wherever MLHPs are available. Next. Public health action, contact tracing. I think nowadays most of the public health action is done by the STS. Or the STS is doing major activity. It is not being inculcated along with the MLHPs or with the MPW male. So a public health action along with the MLHPs, along with the male health worker at the some certain level is very important for contact tracing. In some places we have seen the VHN or the male member will know this patient was here, sir, he was staying in his grandfather's house for nearly 3 years. The VHN will know, but STS to find that out is very difficult. So that is very important to have. And then they also can follow up the patients for adverse drug reaction. They can also follow up the patient for follow-up sputum, for post-treatment follow-up, for complications. Loss to follow-up patients also can be tracked by the MLHPs. Palliative care at the end. Lot of patients are having destroyed lungs and at the end they end up with, they need some oxygen for some time. Next. See at the UPHC level, Ayushman Arogya, UPHC and the PHC level, all the other factors have to be taken along with extra is X-ray, utilization of the X-rays. So this we have been always saying, X-ray at the block PHC, the X-ray technician is there or the X-ray is non-functional. Something should be done for availability of X-ray at the block level. If it is not available, some voucher scheme also should be formed so that the patient does not have to go to the district level for the X-ray. DRTP, dispensing drugs using telemedicine. So dispensing of drugs by the UPC medical officer. Risk assessment also and NPY. Next. Thank you, sir. I think I have covered most of the things which can be done from sub-center to the primary health centers. What all things we can do. Thank you.
Thank you, sir. Any question from audience side to Nirmal Jo, sir? Sir, next question to our state program officer. As per our director as well as honorable minister declared the floor of the assembly, we started one-stop TB center each block. What is the plan as a state TB officer, starting from district TB unit to integrate with a one-stop TB center?
So, good evening, everyone. So, I thank the director and the entire team that has put a very nice show and a very proud moment for the Department of Public Health and Department of Health as such for organizing to such a huge way. And the same way, so the integration starts from the director here. I would like to answer additional sir that he's invited us to talk about how we are going to start this horizontalizing the entire vertical program of tuberculosis elimination. So thank you for that, sir. Thank you for the question as well, because the one-stop TB solution is something that was conceived and was declared in the floor of the assembly. So this is something to do with the health system strengthening that we want to bring in, where not just the primary health, prevention, promotion, and prolongation of life, the three basic, pillars of the public health will be promoted for the tuberculosis patient. This is no longer a vertical program in Tamil Nadu, but we'll be showcasing it to the entire country if we are successful in implementation of this one-stop TB solution. So because as far as tuberculosis is concerned, now we are faced with two major problems, which I would say is something of case detection as well as the mortality prevention. So here and again, when it comes to case detection, the role of primary health centers, as Dr. Nirmal Jo said, it's not just the block level, the sub-block level, the smallest unit, how it is going to be integrated in detection. So this is something we also have evidence, which Dr. Rao very correctly pointed out, that the prevalence survey said we have around 39% of the people in community who are asymptomatic. So if you're going to look for patients who are going to cough for more than 2 weeks, who are having fever, who is going to, there'll be blood and sputum. If we are going to wait for somebody to come with such symptoms, we will be missing cases and our case detection rates will not be as we have increased our examination rates. So this is where every primary health center has to be aware that there is a hidden case in the community. At least for one case, 2 cases that we detect, there is one case that is still in the community that has gone undetected. So we've also heard from the previous 2 speakers, so what are the vulnerable population that are there among the community? We also have a line list of something that is already there. So this is where the hidden cases could be, because they are all having, for example, the cancer cases, the immunity is very low. We also have patients who are under dialysis. So all these line lists are there. So where to look for patients? So answering Sir's question, the block level senior treatment supervisor and the senior treatment lab supervisor, so they should be able to share these data among the at the block level, so that the focused case finding happens at the block level in these community to start with. All those line listed vulnerable groups that were presented by the previous speakers, so that has to be focused upon so that we will detect cases from that pool. So having said that, we have to have probably the new interventions, the new technologies that are also there, the handheld X-ray, the artificial intelligence solutions that are available in the handheld X-ray, so that we don't wait for a radiologist to give us the diagnosis or rather screening. So by investing more, so my request would be to invest into these technologies that are available now for TB elimination, achieving the targets.
Another one question about any TB notification out of 100 cases, 85 is adult, 15 pediatric age group. Likewise, 75% is pulmonary and 22 to 25% is extrapulmonary cases. Okay. We have only the examination facility, that screening test facility is sputum microscopy. Even with some upgraded PSC, we have X-ray unit. How you integrate your field, your NHM sponsor staff like STS, STLS, as well as the district coordinator, block level coordinator for PPP program, private notification, so many staffs. Whether any DHO or CHO, any integration between the TB staff as well as your field staff is there in the field? I want to know. Any one of health officer or district health officer, please tell us. Health officer. Mike. What is your notification rate? Whether 100%?
Sir, notification as such, the number of persons identified as TB, for example, last August we had 55 cases for the corporation, out of which only 4 or 5 directly came from PHC, sir. We, after this one-stop center, we started integrating the block level TB staff. We have very minimum number, 1 STS, 1 HV and 1 LT. Those are the available staff. Now we have started using our own UHC health inspectors into the picture, sir. What we have tried is, we have a separate mobile X-ray unit and the key population which has been a focus point like more diabetic cases. So we mobilize those patients and try to put those patients into the screening. Starting from 1 or 0 in the few months, now we have moved on to 4 or 5 cases directly reporting from the PHC, sir. This is an improvement in the last 5 to 6 months what we had in our urban context, sir. Otherwise, we do refer the patients to the headquarters hospital where they confirm and they take it into it, sir.
Why we are not doing at your level? Why you are referring the case to Taluk Hospital, the district headquarters hospital or TB unit?
For confirmation part, we don't have any facilities. We have only the sputum microscope.
Under ILS you can use. Now recently ILS system you have started.
We have started using it, sir, but it is only weekly 3 days, the compliance. We have started improving it, but previously we sent most of the patients, and we do have headquarters hospital within the E-Road, DTC within the E-Road, so they easily moved and accessed to the DTC, and that's what the results, sir.
Response from any DHO about TB integration at your level? Salem DHO. நீங்களே இன்டகிரேட் பண்ணலனா அப்புறம் how can we integrate? அதனால தான் உங்களுக்கு
Good evening all. Actually we are coordinating with DDTB and his unit. As sir said, we are using IELS. Actually on the TB cases on the all diabetic patients and long-term illness patients எல்லாருமே இப்போ mobilize பண்ணி PHC கூட்டு வந்து as Dr. Prakash said வந்து இப்போ TB cases கண்டுபிடிச்சிட்டு இருக்கோம். But once confirmationக்கு STS வந்து அவங்கள வந்து higher center தான் கூட்டிட்டு போறாங்க. This is the reality is going on.
Usually 100 cases you are diagnosed now. Out of 100, 65 confirmed by sputum examination. Remaining 35 by X-ray or TrueNat or CBNat or some other histopathological examination. Okay, 65% of cases diagnosed by sputum microscopy only. Once you diagnose as a sputum microscopy, then the drug sensitivity test only, it is taken to the nearby TB, the TrueNat availability or CBNat availability. Okay, 65% cases diagnosed at your level. One-stop TB center is enough to diagnose TB cases.
Yes, sir.
Okay?
Yes, sir.
Right.
Yeah.
One question to madam.
Maybe I'll add a point
sir,
into that.
Sir, I like to differ with this point, sir. Sir said it is 65% it is through microscopy, but in field we do not find that much proportion,
we
sir.
We analyze the data last 3 years. We analyze the data last 3 years. Out of 94,000, how many detected by sputum examination, how many detected by X-ray, how many directed by TrueNat or CBNat, and how many directed by histopathology examination or CSF analysis. We have the data. That's why I am telling.
Within the sputum, microscopy is only a minimum proportion, and now NAT and
Not like
CBNat
that.
is
Not like
Madam
that.
can add upon.
Madam?
Not across. It's, let me just add into this, So it was wonderful to go to the field the last 2 days in Coimbatore. The mobile van which he spoke of, with X-ray, was sitting in the medical college. Why? Because the demand for X-ray is so high that the medical college X-ray unit, it is overflowing, and the patient will have to go somewhere far and come back again. So the mobile van is placed in the medical college to top up on the X-ray. So yes, enhancing our X-ray is important, but mobile van was supposed to be in the community. That is why it is mobile. So that's one thing. But in terms of sputum microscopy as the primary tool for diagnosis, it's around 70%, and we have to move that slowly. So very recently in Tamil Nadu now we have TrueNat now at all block levels, right? So the sample that is collected, it can easily be transported. Currently, sample transportation mechanism, one is with what Madam said, the ILS, but very limited, only 2 days a week and only going for this sample. But otherwise, it is the female health volunteer or fixed days, somebody will come in. So I think there is a need for one, decentralizing the diagnosis, because if you rely on sputum microscopy, like Dr. Asha said, half of the cases are asymptomatic and you wait for them. Sputum microscopy, you miss another 25% because the sensitivity of the tool is minimal. So what is happening is, all the 10 people who had to get that infection have already got it, right? So it's late diagnosis, so transmission continues. Your number of cases in the district continues to be the same year on year. Prevention is currently restricted only to the households. So that's one thing which I would want to suggest, that you need to now expand TB preventive treatment to the population which is vulnerable but outside the household. As of now, only contacts and PLHIV is the only population which may probably get it outside the household. So that is where I think a lot of new cases, prevention can happen, and which will have an impact on mortality directly. Right? So that's one population, be it diabetics, CKD, low BMI, all the population which are just showed there. Right? So have the state level committee and decide on which population you want to do. There is surplus drugs, full flush drugs available. So take that call and then you can move forward, on that part. Yeah. Thank you.
Sir mentioned that the latent TB as well as asymptomatic TB. Question to STO. What are the screening methods to detect asymptomatic as well as latent TB cases?
So, for a latent TB infection, now that we have something like, we must have heard of Manto test. So, we have another a test that has come up called CYTB, which is been, the supplies have reached the state. So, we would be utilizing CYTB for all the population that is vulnerable, clinically vulnerable. So when I say clinically vulnerable, so the patients that are with the low BMI as the contacts of TB patients, not just the household contacts, and the immunity. So people with low immunity, the patients on chronic kidney disease who are on immunosuppressives for cancers and anti-cancer therapy. So these are the pool of patients that we also have, which are, liable, clinically vulnerable to contract TB. So these, we will start with that, and as suggested, we'll have a state level committee, and we'll deliberate on after that we'll draw the SOPs into integrating that. So as far as latent TB infection is concerned, there is something, the other pool, as I said earlier, the asymptomatic pool is also there, because they do have, as per the prevalence survey, changes in the X-ray, but there is no cough. It is dry. So that pool has to be gone, you can detect only through an X-ray, and further maybe induced sputum, and there are other methods to bring out the sputum. Otherwise, we have to go with the X-ray screening of such people. For latent TB, we have something right now in our midst, which is a CYTB, a very new tool, but a time-tested and a proven tool.
Okay, thank you, madam. The next question to Mr. Rajeswaran sir. What role can primary health care providers play in educating communities about TB prevention and treatment?
So I would like to answer this question. I have a slide from our own experience actually. Slides. Okay. No issue.
whatever the things available in the market, that is all fortified with all those micronutrients. So then the food supplements
seeing the vegetable, if it is fresh, we are thinking it is directly from the farm. But it is not like that. It is in order to add the color, they are doing this selective breeding. Then we have a genetic modifications. So this is actually we have a genetic modifications which we are doing. We are mainly of a hybrid variety of food. So how we can prevent this malnutrition? By promoting a balanced and diverse diet, improving access to the nutritious diet, and addressing the socio-economic status and providing education on right nutrition and hygienic practice. And public health interventions, policies are having a crucial role in the prevention of the thing. So what India is taking a measure to reduce this malnutrition, mainly ANC coverage, that is antenatal coverage, iron and folic acid supplements, institutional delivery, early and exclusive breastfeeding, timely and age-appropriate complementary feeding, and complete immunizations. Then the UNICEF initiative to reduce this malnutrition, when you are saying, means growth monitoring, oral dehydrations for diarrheal disease, breastfeeding, immunizations, food fortifications, then female literacy, then fertility regulations. So if you say in the government of Tamil Nadu, the schemes which has been launched by our Honorable Chief Minister in 2022, that he has introduced this breakfast system for the school children, mainly to combat this micronutrient deficiency. So each day, if you see, their meals will be included all kind of pulses, cereals, and every other nutrients also. So it has been appreciated by many people. Even the other state has been adapted to this system. Mainly the Telangana state also adapted to this breakfast system, and they have introduced in 2023 this breakfast system giving for here we are giving the children for a primary school children, but in Telangana it is up to 10th standard they are giving this. And the latest one in the Tamil Nadu thing is, it's not only for the government students, even for the government aided schools they are going to implement this program. And the schemes by the government of India, when you are saying, means PM Poshan Shakti Nirman scheme. So in this, under this scheme, by 2024 March, they have made a score, index score of zero hunger. They have kept 22 to 84 as a things value index score. So out of this, among the union territory, the Puducherry has the highest score of 84, and among the state, Kerala is the forerunner of this score of 84. And other than this, we have even a national food security missions. So under this scheme, they are doing this fortification. They are giving a training to the agriculturals, like because we saw in the cost, the land agricultural production is less. So within short duration, high yielding of food. So those kind of training and all they are giving to the agricultural people. Thereby they are improving the production of food products also. Then the other one is rice fortification in India. So this is mainly mixing a rice with vitamin and minerals. So this has been given from since 2019 to 20, and up to March 24, the statistics shows that around 406 lakhs metric tons of fortified rice has been distributed through public distributed system. So this Rashtriya Poshan Ma has been celebrated in our country in the month of September, and through this they are tracking the people through mobile app also. So to conclude that to eat is a necessity, but to eat intelligently is an art. So our God, when created the world, He has given everything in a good way, and He has given the authority to the human being to rule the earth. But as a human beings, we have adulterated and corrupted in everything, even the food which we are eating it. So it is our responsibility to combat or to overcome this nutritional disorders. Thank you for the opportunity.
Thank you, Dr. Mary Rita. That's an excellent comprehensive thing from malnutrition to overnutrition and the various programs. Comprehensively, you covered everything. And important thing is, okay, so you covered everything very comprehensively. It was very good. And as a nursing principle, we also have to say certain other things. For example, if you use substance use for obesity, the same is there for malnutrition also. It's not only for the person, for the family. So, and the knowledge of the food, that also needs to be given.
That actually when the students are posted in the community, along with the primary health center people, they are doing all this project, and even we are conducting obesity clinics in the college, like every time, whatever the day, special days are coming, we are conducting this
Exactly,
thing also,
advocacy, that is the way to go about. It was very comprehensive, very nice, madam.
Yes.
Any questions from the audience, please? Okay, towards the end of the day, I think. Very good, madam.
Thank you, sir.
1 minute.
Thanks for deepening our understanding, ma'am. We request Mrs. Sumati, JD SBHI, to felicitate Dr. Mary Rita. Thank you, ma'am.
We cordially invite Professor Dr. Suja Suresh, Head of the Community Health Nursing Department, SRM College of Nursing, Trichy, to present a topic, maternal nutrition and its impact on fetal development. Professor Suja Suresh aided in establishing SRM Trichy College of Nursing in 2018 and 2023 and launched DGNM program and submitted a PG program proposal to the Tamil Nadu government. As head of the Community Health Nursing Department, she led multiple awareness programs and camps. Please join me in welcoming her onto the stage.
A warm good evening to all. First of all, I thank the organizing committee members and Director Public Health and Registrar of Nursing Council, Dr. Annie Grace Ma'am, for this opportunity. I am going to present about the maternal nutrition and its impact on fetal development. Already so many speakers spoke about malnutrition and other things. So let me go with the... Everyone know it is a unique experience by every woman regarding the pregnancy, and nutrition plays a major role in the health of the mother and the fetus. So why nutrition is very important during pregnancy? Due to the rapid development of the fetus and the physiological changes which take place in the mother. As we know, it has 3 stages during the pregnancy. One is pre-embryonic. There is a rapid cell division in this stage. Next is embryonic stage, rapid organogenesis. Then third one is fetal stage from 9th week to the till birth. Here there is a great demand for the nutrients because of the increase in the length and width of the fetus. The next one is we have to consider about the maternal weight gain. Maternal weight gain is based on the BMI. One is if the pre-pregnancy stage BMI is less than 18.5. We expect 12.5 to 18 kg, and if it is 18.5 to 24.9, then it is 11 to 16 kg, and more than 25 to 29, it is 7 to 11.5 kg, more than 30 is 5 to 9 kg, approximately 10 to 16 kg weight gain is expected. So to achieve this, we have some of the aims of the maternal nutrition. One is support fetal growth, reduce the complication, and maintain the mother's health, then support lactation. And there are so many studies conducted on maternal nutrition. They said whatever mother puts in her body, that will influence the future generation. Let's see about the recommendation given by the ICMR during the antenatal diet. Energy, some books says 300 calories, some says 350 calories. So we expect at least 300 calories mother has to consume, and it will definitely fuel the mother and the growth of the fetus. Then protein 60 to 70 grams, that will improve the weight of the mother and the child. Then increase the blood volume. Iron, of course, that will definitely support the increasing of the blood volume and the prevent iron deficiency anemia. And folic acid support the nervous system, especially that will reduce the neural tubal defects. Then calcium, of course, for the bone health. Vitamin A for immune system. And vitamin C again that support the immune system and beta iron absorption. Then vitamin D again fetus bone health and the prevent the vitamin D deficiency among mothers also. Then omega-3 fatty acids for the cognitive development. And mother has to consume minimum 2 to 2.5 liter water a day. And some of the foods to be included and avoided. Usually we say they have to take more calories from the protein origin, then avoid the more fats and sugars and the beverages than junk foods. Usually we say go with the healthy diet. Healthy diet means balanced diet with the locally available ingredients. Then burden already discussed. Impact. Usually that will impact on the low birth weight, preeclampsia, anemia, birth defects, and gestational diabetes and postpartum depression. Overnutrition. Usually overnutrition also we have to talk here. If that will cause the maternal infections, pregnancy-induced hypertension, then gestational diabetes, and decrease the success level of trial of labor, then prolonged gestation, increased risk of cesarean section. Undernutrition, stillbirth, then again increased risk of DM, the later life, then increased risk of structural anomalies, IUGR babies, and neonatal deaths, and preterm birth.
Next slide.
Protein. Impact on low protein is directly linked with the fetal death and the placental insufficiency, oligohydramnias, and IUGR, then cognitive behavioral defects. Iron, of course, that will again link with the premature birth, then postpartum hemorrhage, postpartum depression, low birth weight baby. And there are so many studies conducted. One of the study done in Sweden specified that if the mother is having anemia during first 30 weeks, then definitely we can expect the incidence of autism in the generation. folate, of course miscarriage, abortion we can expect, anencephaly, again preterm birth and neural tube defects. Iodine, iodine. Actually, iodine plays a major role because first 2 trimester child will get iodine requirement from the mother only. So here mother has to consume adequate iodine to prevent the cretinism and also cognitive issues also. Child may develop with the cognitive developmental defects. Then vitamin C, again it is important for the brain development, and of course it is very, very important for the immune system and collagen development. Vitamin D, again bone health, and they said sometimes this will cause the ADHD among the developing child in the future. Zinc, again they said zinc is very, very important, and acrodermatitis is expected. Here child will have the poor absorption of zinc genetically. And some of the barriers to adopt recommended diets in India, one is availability, lack of availability and accessibility. Though we have sometimes availability, accessibility is a major issue. Then economic constraint. Here we know low economic status and higher economic status mothers conception. Then exposure to health and nutrition services. Rural area people having less exposure to get the health services than compared to the urban area mothers. And maternal education plays a significant role in selecting the quality foods. Then food taboos and restrictions during pregnancy, here family plays a major role. And since we are living in the rural areas, usually they say don't eat this, don't take that, so that definitely influence the health of the mother and the child. Then gender norms, again usually female used to have the food end of the, everyone will have the food first, remaining only will be ate by the mothers. So that is also influencing here. Other demographic factors also we have to consider. Then there are so many programs for the better nutrition. Already this was discussed by the ma'am. And Muthulakshmi Reddy scheme is very good scheme which is implemented here. And here we are giving financial assistance to the mother. And National Iron Plus initiative to control the anemia. Then again we have to talk about the sustainable development goals. It comes under the goal to zero hunger. Then supplementary nutrition program through ICDS center we cover antenatal mothers. And role of nurse here, as a nurse what is your role? Here we have role in preconception itself. We have to go with the proper screening and counseling and nutritional assessment and education and distribution of iron and folic acid supplementation and calcium supplementation. Promote good dietary habits. Then we encourage for the small family norm and the frequent diet during antenatal period also, and home economics and spacing. And specific protection, again we encourage for the food fortification. Mother should consume more protein and calories and fruits and vegetables and behavior change communication. Then early diagnosis, here through periodic surveillance and screening, we go for door-to-door survey. Through that we can identify the deficiencies early and we can refer them and treat them early. And monitoring the weight gain during pregnancy and treating the maternal infection early and deworming, and then go for the supplementation of iron. Then early identification of risk mothers and treatment, nutrition counseling.
Can you summarize, madam?
Yeah. I would like to summarize that here as a nurse, your role is very, very significant in reducing the impact due to nutrition deficiency. Here as a nurse, we can go with the proper screening and good education and the counseling, because counseling and education brings a better behavior change. Thank you.
Dr. Suja Suresh, that was an excellent presentation, and you had summarized everything about in pregnancy. Pregnancy is a very critical term where we need a lot of nutrients, micronutrients, what you had pointed out.
Yes.
But there are certain things about autism which you said. Autism is multifactorial.
Yes, sir.
Not
One of the
exclusively, there is a gut hypothesis there. In fact, they give a lot of supplements which is used to treat autism, which is very good that you summarized all those things. Important thing is to identify that. We need to have some symptoms or signs that need to be there from the nursing perspective. Please
Yes,
summarize that, it will be very good. Thank you. Audience has any questions?
Thank you, sir.
Thank you, Dr.
Thank you.
Sujas.
Thank you for your insightful presentation, ma'am. Now I would like to invite Dr. Krishna Bala, Joint Director NHM, to honor our speaker.
Thank you, ma'am. DPHICON2024 renders an amiable welcome to Dr. Rajati Abdullah, HOD, Mental Health Nursing Department, Kaveri Nursing College, Trichy, to shed light on anemia in women and children, strategies for control. She holds MSc in Mental Health Nursing, PhD in Nursing Research. She is a Senate member of Dr. MGR Medical University, Chennai. She has organized various counseling awareness programs and screened camps to promote health education. She played key role in establishing the Youth Red Cross at Dhanalakshmi Srinivasan College of Nursing. She has conducted several departmental projects and contributed to the curriculum and research committees, ensuring academic excellence and innovation. She is an ad hoc inspector for University, State Nursing Council and Indian Nursing Council, and examiner for nursing examinations. Welcome, ma'am.
அனைவருக்கும் எனது இனிய மாலை வணக்கம். Good evening to all the delegates and especially the director sir and the team, DPHICON team, who has conducted such an excellent, wonderful conference 3 days in Tanjavur. So I really appreciate the team and congratulate the team and especially inviting us as a nursing teachers. We also would like to thank sir for asking us to participate in that. Apart from that, my special thanks go to Dr. Rani Grace Kalemadi, Tamil Nadu Nursing Registrar, Tamil Nadu Nursing Council Registrar, for having given this such a wonderful opportunity. So from morning, எல்லாருமே டாக்டர்ஸ் இங்கிலீஷ்லேயே பேசிட்டு இருந்தாங்க. So now I would like to, being a nurse, I am very proud to be a nurse. So I would like to say few tips only for the healthcare workers, especially nurses, ANM and VHN and field workers. இவங்களுக்கு மட்டும்தான் எனக்கு ஒரு 5 minutes தான். I don't want to take much time because we know theory. எல்லாருக்கும் theory தெரியும். What is anemia? What are the medications you are going to give? Dosage எல்லாமே நமக்கு தெரியும். But what is our role? So, you know, nurses are taking a very crucial role. We say nurses are the backbone of healthcare system, right? So being a backbone, what we supposed to do? That is very important. Only 10 points I am going to say to you all, especially field workers and nurses. My dear fraternity, nursing fraternity, if you think you can stop maternal death, everything is in your hands. We are the front row people. We have to know many things about anemia. So let me show few slides quickly, then we will come to the last role of nurses, right? First slide. Yes, this is a definition by WHO. Insufficient red blood cells or oxygen carrying capacity of to meet the physiological needs. Normal values, HP, you all know, right? So 12 gram per dilution, pregnant woman 11 gram per dilution, children under 5, 11 gram per dilution. Next slide. So this is prevalence in India, Tamil Nadu. 57% of women are anemic and especially in Tamil Nadu, 55.2% of pregnant women are anemic. So this is our current trend. Next slide. So characteristic common symptoms: fatigue, pallor, weakness, dyspnea, dizziness and palpitation. Because unless you know the symptoms, you cannot treat, you cannot identify and bring the patient to the doctor. So it is very important, being a nurse, being a healthcare worker, we should know this. Then physical signs: pale skin, rapid heartbeat, shortness of breath and cold extremities. Apart from that, difficulty in concentrating, irritability, decreased work performance. All these are you have to identify as a nurse. Next slide. So these are all the types of anemia. One is iron deficiency, vitamin B12 deficiency anemia, aplastic anemia and hemolytic anemia. Next slide. These are some of the other symptoms, like you can identify from the patient when they have a low level of HP. Next slide. Then medical management: iron supplements, ferrous sulfate, blood transfusion if the HP level is below 8 or below 5 for the pregnant ladies, and vitamin B12 injections and erythropoiesis stimulating agents for patients, those who are having chronic renal disease. Next. General preventive management, usually iron supplementation, dietary changes, then fortification as well as screening. Next slide. Next slide. So these are some of the South Indian foods which you can give a health education to the public when you go to the field, especially BHN and ANM. So you know what food to be prescribed. Patient kitta enna sollanum, public kitta enna food which contains more iron, nutritional foods. So enga kedaikira food enna romba costlyana food sollama, depending upon the economic level you have to tell them what are the food which contain rich iron and how to take all those things. Next slide. This is not necessary, I just made it for hospital nurses. Slide, skip the slide. Next slide. Next slide. Next slide. Next slide. Yes. Yes. Home care. So this is also one of the important role, being a home visit. When you do a home visit, you are going to be with the family, and you have to educate them what are the food which contains rich in iron, and what are the medication, how to take medication. Suppose if they want to take iron, when to take iron, how to take iron, and what time they are supposed to take, along with what they should not take. For example, iron should be taken in a empty stomach if they don't have a gastritis, or they should not be, iron should not be combined with milk, tea, coffee, those kind of foods. And iron can be taken with vitamin C rich food. This kind of health education to be given to the public. That is very important role of a nurse. Next one. So this is a simple classification of mild, moderate and severe anemia. So depending upon the level of hemoglobin, what are the treatment as well as how to do when to do a follow-up and when to refer the patient to a higher level. This is a simple slide which describes different types of anemia: mild, moderate and severe. Simple classification. This is about management of anemia on the basis of hemoglobin level among pregnant and lactating women. So why it is important for pregnant and lactating women? They need more iron because they have more needs when they have become pregnant. So for that kind of situation, based on depending upon the hemoglobin level, what to be done? When the hemoglobin level is, HP level is 9 to 11, what are the things you have to do? That's all part of medical. Okay. Then what you have to do as a nurse, public health nurse? I have seen many community health nurse, when any death, maternal death, how they suffer. Lots of inquiry, they have to answer for the press, media and family members. Really, my dear ANMs and village health nurses and ASHA, Anganwadi workers, it is very, very crucial role of all of us. If you do a simple detection, investigation or screening to identify anemia, you can save one family, one mother If you save one mother, the whole family is being saved. So simple screening or do a follow-up. Primary prevention is mainly to just identify and find out whether they are taking the iron tablets or folic acid tablets on time properly, and do a follow-up visit. And if they are not improving with the HP after a month, bring them to a medical officer and do a follow-up investigation. Then if they need higher level of care, refer them to the higher level of facility hospital. So this, if you do simple thing, that will definitely save the patient life. Apart from that, the common thing what will happen if there is low HP, there are 4 complications for the mother. One is abortion. Number 2, what will happen? Anyone? Low birth weight, then premature delivery, then what else? Maternal death. So if you identify the anemia on proper time, 20% of the maternal death can be stopped. So doing a simple HP investigation will help and will save the mother. Number 1. Number 2, you have to identify level of HP. Based on that, you have to take the mother to the particular MCH and do a follow-up visit and check whether they are taking the tablet on a proper time. So all these are important role of a village health nurse, Anganwadi workers or the field visit. And also the malaria as well as some parasites can also lower the hemoglobin level. So for that you have to do what? Deworming. Do a deworming by annually. So simple steps can definitely save the mother's life. Then next slide. There are some government schemes, initiatives, Anemia Amak Bharat and School Health Program, State Nutrition Mission and Muthulakshmi Reddy to assist financially for the under poverty mother. Next slide. Same thing about they mainly focus on from 6 months to 49 age. They cover all the school age, adolescents as well as mother those who are in the age of mother those who are from the 19 to 49. So these people are covered by this system. They take care of their HP level and they provide iron and folic acid supplement and fortifications. All those things are covered by this scheme. Next slide. School health program. The teachers, their role is very important. They should identify the students, those who are weak, pallor, not having concentration. The nurse, school health nurse, she should identify and take the child to the UHC, Urban Health Center or Primary Health Center for further follow-up. Next slide. Next slide. Next slide. So this is a financial assistance. You all know government, they are doing financially helping the mother, antenatal mother to do the financial help. Next is conclusion. So public health is a very challenging one. It needs multifaceted approach and we need ongoing research. So my dear nursing fraternity people, those who are here, so kindly do the 5 things. One is primary prevention by giving proper iron and folic acid tablets to all the mother, antenatal mother for 100 days. You know the follow protocol for 100 days, 100 milligram like that. Number 2, counseling. Number 3, tell them the side effects of iron and folic acid tablet, and if they don't take the tablet, what will happen? Okay, cardiac risks are there if they don't treat the anemia properly. So anemia is a simple disease, preventable disease, which save the mothers and fetal life. So being a frontline workers and the backbone of the healthcare system, I really ask all the people, those who are involved in the healthcare system, to do a little identification and screening test will really do a lot of change in the public health. Thank you so much. With one request to our director, sir, kindly organize a conference like this for our nursing fraternity. We are really in the front line. We are taking care of, we are going door to door to the people, and we have to get more knowledge than other people. So I really expect our director will organize such a wonderful conference for nurses as well as Anganwadi workers, all the frontline people, soon in Tiruchirappalli. Thank you so much, sir.
Thank you, Dr. Rajati. That was very comprehensive. See, from the time we have seen 1980s, anemia first cause of maternal death. 1990s, 2000, even now also anemia is a leading cause of death.
Yes, sir.
You comprehensively summarized everything.
Yes, sir.
I request you to please include RBSK because that is a program that is addressing that.
Yes,
If
sir.
you include that, I think it will be complete. Just a suggestion. Excellent presentation. Thank you.
Thank you, sir. Thank you, sir. Thank you so much.
Thank you, ma'am. Thanks for expanding our understanding. We request Dr. Nirmalsan, JD MCH, to felicitate Dr. Rajati Abdullah and moderator Dr. Satish Raghavan, JD Tansax. Thank you, sir.
We would like to invite Ms. Gomati, Village Health Nurse, representing Tamil Nadu Government VHN Association and VHN, SHN and CHN Federation to present on VHN's perspective of public health.
பன்னாட்டு பொது சுகாதாரத்துறை 3வது மாநாட்டிற்கு தலைமை வகிக்கும் எங்களுடைய வெளிப்படையான இயக்குனர் உள்ளிட்ட விழாக்குழுவினர் அனைவருக்கும் தமிழ்நாடு அரசு கிராம சுகாதார செவிலியர் நலச்சங்கம், தமிழ்நாடு அரசு கிராம பகுதி சமுதாய சுகாதார செவிலியர் கூட்டமைப்பின் சார்பாக எங்களுடைய முதற்கண் வணக்கத்தினை தெரிவித்துக் கொள்கிறேன். நாங்கள் நிறையா பேருக்கு VHN அப்படி சொன்னால் ஆஷா மாதிரி பயன்படுத்த முடியும் அப்படின்னு நினச்சிட்டு இருக்கிறாங்க. இப்போ இருக்கிறவங்க சீனியர்களுக்கு தெரியும், ஜூனியர்கள் எல்லா கேடர்லேயுமே எங்கள் VHN உட்பட யாருக்குமே தெரியல. அதனால் அடிப்படையில் ஒரு கிராம சுகாதார செவிலியர்கள் எப்படி வேலைக்கு வந்தோம், நாங்கள் இந்த பொது சுகாதாரத்துறையினுடைய முதுகெலும்பாக இருக்கோம் அப்படின்னு சொல்கிறதுக்கு என்ன காரணம் அப்படின்றத சொல்லணும், அப்படி விளக்கணும் அப்படின்றதுக்காக தான் நாங்கள் இன்றைக்கி பேசுகிறோம். தட்டினால் கொடுப்பது விவிலியம், தட்டி கொடுப்பது செவிலியம். வீடு வீடாக போய் தட்டி மக்களுக்கான நலவாழ்வு சேவைகளை உரியவருக்கு உரிய நேரத்தில் உரிய இடத்தில் கொண்டு போய் சேர்க்குற வேலை தான் கிராம சுகாதார செவிலியர்கள் வேலை. கிராம சுகாதார செவிலியர்கள் என்பவர்கள் கிராம சுகாதார செவிலியர்கள் பொது சுகாதாரத்துறையின் விருட்சம் அப்படின்னு சொல்கிறோம் இல்லையா, ஏன் ஆணிவேர்கள், ஏன் கிராம சுகாதார செவிலியர் பொது சுகாதாரத்துறையின் ஆணிவேர் முதுகெலும்பு சொல்கிறோம் இல்லையா, முதுகெலும்பு நீங்கள் தான் தூண் அப்படின்னு சொல்கிறோம். ஆனால் ஆமாம், அது மிக இல்லை. நோய் நாடி நோய் முதல் நாடி அது தணிக்கும் வாய் நாடி வாய்ப்பச் செயல் அப்படின்னு சொல்லக்கூடிய பொய்யா மொழியாரின் கூற்றுக்கேற்ப மக்களின் உணர்வுகளை, பழக்க வழக்கங்களை, அவர்களுடைய நாடி துடிப்பை கண்டறிஞ்சு அவங்களுக்கான சேவையை நன்குணர்ந்து அவங்களுடைய சேவையை பணியாற்றுவதில் கிராம சுகாதார செவிலியர்கள் வல்லவர்கள் அப்படின்றத இன்றைக்கி காலையிலிருந்து பேசின கட்டுரையாளர்கள், பேச்சாளர்கள், விஞ்ஞானிகள் அத்தனை பேருமே சொல்லியிருக்கிறீங்க. அது எங்களுக்கு ரொம்ப பெருமையாக இருக்குது. அதை நாங்கள் யார், நாங்கள் எங்கேருந்து வந்தோம், நாங்கள் எப்படி வந்தோம், ஏன் நாங்கள் அவ்வளோ சிறப்பாக செய்கிறோம் வேலை, ஏன் மக்களோட மக்களாக இருக்கிறோம் அப்படின்றதும் தெரியணும் இல்லையா. அதனால தான் சொல்கிறோம், நாங்கள் விளிம்பு நிலையில், பொருளாதாரத்தில் பின்தங்கிய நிலையில், ஆதரவற்ற இல்லங்களில், சேவை இல்லம், இணையராக கைவிடப்பட்டவர்கள், இணையரை இழந்தவர்கள், சமூகத்துறையால் நடத்தப்படும் சேவை இல்லங்களில் அரசு உதவி பெறும் ஆதரவற்றோர் இல்லங்களில் படித்து பயின்று என்ன செய்கிறோம்? நாங்கள் மக்கள் சேவை ஆற்ற வந்திருக்கோம். ஆனால் எப்படி சேவை வைக்கணும்? சாதாரணமாக வரல, சமூக நீதி அடிப்படையில் பணியமர்த்தப்பட்ட காரணத்தினால்தான் அடித்தட்டு மக்களுக்கு எங்களால் உணர்வு பூர்வமாக விசிட் பண்ணாமல் அவங்களோட இணைஞ்சு மக்களோட மக்களை வேலை செய்ய முடியுது அப்படின்றத இங்கே நாங்கள் தெரிஞ்சுக்கிறோம். அடுத்தது கிராம சுகா சொல்லுவாங்க எல்லாருமே, விஹெச்என்ட்ட சொன்னால் எந்த சூழல்லையும் வேலை செஞ்சுருவாங்கப்பா, விஹெச்என்ட்ட கொடுங்கன்னுவாங்க. எந்த சூழல்லையும் பணியாற்றக்கூடிய வல்லமை பெற்றவர்கள் கிராம சுகாதார செவிலியர்கள். அடிப்படை கட்டமைப்பு வசதி இருந்தாலும் இல்லாட்டாலும், உபகரணங்கள் போக்குவரத்து வசதிகள் இருந்தாலும் இல்லாவிட்டாலும், சமவெளி பகுதி, மலைப்பகுதி, மலைப்பிரதேசங்கள், வாகனங்கள் போக முடியாத பகுதிகள் எல்லாத்துலேயுமே ஆறு, நீரோடை எல்லாத்தையும் நடந்து கடந்து போய் மக்களுக்கு சேவை செய்யக்கூடியவங்க. மக்களோடு வேரோடும் வேரடி மண்ணோடும் சொல்கிறோம், வேரோடும் வேரடி மண்ணோடும் மக்களோடு மக்களாக பணியாற்றி டார்கெட், ஏற்கனவே எங்களுக்கு டார்கெட் கொடுத்து நாங்கள் வேலை செஞ்சோம். இப்போ அந்த குறியீடு அடிப்படையிலான அணுகுமுறையாக இருந்ததை மாற்றி நாங்கள் சமுதாய தேவைகளின் மதிப்பீட்டு அணுகுமுறையாக மாற்றி காதலுக்கு வழிவகுத்து பாதை சாத்திடுவோம் என்ற பாட்டன் பாரதிதாசனுடைய பாடலுக்கேற்ப தாமாக முன்வந்து மக்கள் குடும்ப நல முறையை ஏற்க செஞ்சுருக்கோம். மக்கள் தொகையையும் தாய் செய்கிறப்பையும் கட்டுப்படுத்தி பொருளாதாரம் மற்றும் மனிதவள மேம்பாட்டிற்கு சிறப்பாக பணியாற்றியவர்கள் கிராம சுகாதார செவிலியர்னா அது மிகையல்ல, அது உண்மைதான் அப்படின்றது உங்களுக்கு தெரியும். சமுதாய பங்கேற்பிற்கு மக்களை ஊக்குவித்தவர்கள் கிராம சுகாதார செவிலியர்கள். இன்றைக்கி எல்லாம் சொல்கிறோம் கம்யூனிட்டி நர்சிங், யார் வேணாலும் எப்போ வேணாலும் வாங்க. யார்கிட்ட நேற்று வந்து ஜாயின் பண்ண விஹெச்என்ட்ட போய் கம்யூனிட்டி நர்சிங் மக்கள்கிட்ட பேசணும்னு நினைங்கன்னா பேச முடியாது. அந்த அளவுக்கு விஹெச்என்னால் கம்யூனிட்டி நர்சிங் செய்ய முடியும். வீடு வீடாக போகிறது, பேசுகிறது, குழுவாக அமர வச்சு பேசுகிறது, வினாடி வினாமூலம் பேச வைக்கிறது, அவங்களுக்கு தலைப்பு கொடுத்து பேசுவது, நாங்கள் செஞ்சுக்கிட்டு இருக்க வேலை. பணியாற்றும் கிராம மக்களே அவங்களுடைய குடும்ப விழாக்களில் பங்கேற்கிறது, தொண்டு நிறுவனங்கள் தன்னார்வர்கள் நடத்தும் நலவாழ்வு நிகழ்வில் பங்கேற்கிறது, பணிபுரியும் பகுதியில் அந்த வட்டார வழக்குகளில் பேசி அவங்களுக்கு புரிய வச்சு இன்றைக்கி நேற்று பேசும்போது சொன்னார் அமைச்சர், ஒரு ஆரம்ப சுகாதார நிலையத்தில் 5 பிரசவம் நடந்துருச்சு அப்படின்னு நம்ம எல்லாரும் வேகமாக கை தட்டினோம். 100 சுகப்பிரசவங்கள் நடந்த ஆரம்ப சுகாதார நிலையம் இன்னைக்கு 5 பிரசவத்துக்கு கரவொலி எழுப்ப வேண்டிய நிலைமையில் நம்ம இருக்கிறோம் அப்படின்றது இங்கே நான் பதிவு பண்ணணும்னு நினைக்கிறேன். சுகப்பிரசவங்களை பார்த்து பெண் கருக்கொலை, சிசு கொலை தடுக்கவும், பாலின பாகுபாட்டு தீய கூறுகளை எல்லாவற்றையும் நலக்கல்வி மூலம் விழிப்புணர்வு அளிக்கும், ஆணும் பெண்ணும் சமம், பாலின சமத்துவத்தை மக்களுக்கு ஊக்கப்படுத்தி மேம்படுத்தும் பணிகளோடு தமிழ்நாடு அரசும் ஒன்றிய அரசும் கொண்டு வரும் நலவாழ்வு கூறுகளை விரைவாகவும் தாமதமின்றியும் மக்களுக்கு கொண்டு போய் சேர்க்குறவங்க நம்ம துறையில் இருக்க நிறையா பேர் இருக்கோம். முக்கியமானவங்க நிறையா பேர் இருக்கோம். அதில் முதன்மையானவர்கள் கிராம சுகாதார செவிலியர்கள் தான் அப்படின்னு நாங்கள் ரொம்ப பெருமையோடு சொல்கிறோம். கிராம சுகாதார செவிலியர்னா கிராமத்தில் தவிர்க்கவே முடியாது. கிராம சுகாதார செவிலியர் இல்லாமல் எதுவுமே பண்ண முடியாது. வில்லேஜுக்குள்ளே நீங்கள் ஒரு முகாம் நடத்தணும்னு போய் நீங்கள் ஊராட்சியில் போய் கேட்டு பாருங்களேன், எங்கள் நர்ஸு சொல்லலையே, எங்கள் சிஸ்டர் சொல்லலையே, அவங்க சொல்லணுமே அப்படின்னு கேட்பாங்க. அதே மாதிரி எந்த குழு இருந்தாலும் சரி, அத்தனை குழுக்கள்லையும் எங்களை கேட்கவே வேண்டாம், அவங்களே எங்கள் பேரை சேர்த்துப்பாங்க. கவர்மெண்ட் ஜீவோ போடுறதுல கூட விஹெச்என் சேர்த்துருவாங்க. அதே மாதிரி தான் ஊரக வளர்ச்சித்துறையிலையும் பாருங்கள், கிராம குடிநீர் மற்றும் துப்புரவு குழு, மக்கள் நலவாழ்வு குழு, பள்ளி மேலாண்மை குழு, கிராம மேலாண்மை குழு. அதோடு மட்டும் இல்லை, இதனால் இவன் முடிக்கும் என்று ஆராய்ந்து அதனை அவன் கண்விடல் என்னும் வள்ளுவனின் வாக்குக்கேற்ப திட்டப்பணிகளை செயல்படுத்த துவங்குவதற்கு முன்பாகவே பொது சுகாதாரத்துறை உயர்மட்ட அலுவலர்கள், நீங்கள் எல்லாரும் முன்னால் உட்காந்துருக்க எங்களுடைய இயக்குனர், கூடுதல் இயக்குனர், இணை இயக்குனர்கள், டிஹெச்ஓக்கள் எல்லாருமே என்ன செய்வீங்க, இந்த ஸ்கீம் தானே அதெல்லாம் பார்த்துக்கலாம், நம்ம விஹெச்என் இருக்காங்க, நம்ம விஹெச்என் வச்சு செய்ய முடியும், அவங்க எல்லாத்தையும் செஞ்சு நம்மளுக்கு நல்ல பேர் வாங்கி கொடுத்துருவாங்க, நம்ம தான் முன்னோடி, நம்ம தான் தமிழ்நாடு தான் முன்னோடி அப்படின்னு கூடிய நிலைமையை உங்களுக்கு ஒரு நம்பிக்கையை ஏற்படுத்தினவங்க கிராம சுகாதார செவிலியர்கள் தான். அப்படின்னு ஏதாவது மாறுபட்ட கருத்து இருக்கா யாருக்காவது? யாருக்காவது இல்லைங்கள? அப்போது அது மட்டும் இல்லை, எவ்வளவு காலி பணியிடங்கள் இருந்தாலும் யாரெல்லாம் விடுப்பு போட்டாலும் அத்தனை இடங்களிலேயும் கோடிட்ட இடத்தை நிரப்புவது போல எல்லாரும் அந்த இடத்துக்கு சரியாக போய் உட்காந்து எல்லா வேலையும் சிறப்பாக செய்யக்கூடியவர்கள் கிராம சுகாதார செவிலியர் அப்படி என்றதை நான் பெருமிதத்தோடு இங்கே தெரிவிச்சுக்கிறேன். தெரிவிச்சுக்கிறதோடு மட்டுமில்லை, எங்களுக்கு இந்த அளவுக்கு நாங்கள் இன்றைக்கி பேசுனதில், அத்தனை பேர் பேசுனதுலேயும் கிராம சுகாதார செவிலியர்கள் அப்படின்னு சொல்லும்போது எங்களுக்கு ரொம்ப பெருமையாக தான் இருந்துச்சு. அதே நேரத்தில் இந்த விழாவில் பன்னாட்டு சர்வதேச மாநாட்டில் எங்களுக்கு பேசுகிறதுக்கு வாய்ப்பளித்த இயக்குனர் அவர்களுக்கும் இந்த விழா குழுவினருக்கும் மனதார நன்றியை தெரிவித்து விடைபெறுகிறோம். நன்றி, வணக்கம்.
பொது சுகாதாரத்தின் விழுதுகள் நீங்கள். பொது சுகாதார திட்டங்களை மக்கள் இல்லங்களுக்கு கொண்டு செல்லும் உங்களுக்கு எங்களுடைய பாராட்டுக்கள். மிஸ் கோமதி அவர்களுக்கு நினைவு பரிசினை வழங்க டிஹெச்ஓ சேலம் டாக்டர் சவுண்டம்மாள் மேடம் அவர்களை அன்புடன் அழைக்கின்றோம். நன்றி.
Now we will continue with the DHO's presentation. I would like to invite District Health Officer Thiruvannamalai, Dr. Selvakumar, to share his experience.
Good evening, sir. Good evening to all. Sir, my presentation is regarding the outbreak investigation at Jamunamuttur Hills. Last 3 months back, we had an outbreak regarding the we had an outbreak in the school. That was the next. It's regarding Namimbattu block PHC details. Next. It's a definition of outbreak. That is occurrence of the more cases disease more than expected one. Next. Specific demands when investigation outbreak. Unexpected event, need to act quickly, need to rapid control, work carried out in the field. Next. These are the steps we have steps of the outbreak investigations. Next. Initial response one. This was the place where the outbreak was happened. Arsu Palangudiyar Nala Undu Uraivida Palli. This was the first in on-spot investigation. This was the place. In the second outbreak. 2 years back we had outbreak in the skin infection. That was the scabies. Second outbreak in the same school. Then inspection done by the team. Then we had a outbreak due to the chicken that was cooked in the mess in the school. That was that was given in the even the night without cooking the, reheating the chicken. This is the index case. It's reported in the Jamnamathur PSC. We have a Jamnamathur PSC and Namiyamuttu PSC. Both the PSC we had reported. The first case was, the outbreak was 19/6/24, and the first case reported was 20th. Then in the Namiyamuttu PSC we have conducted the medical camp. Then descriptive data collection and analysis. It's the total strength of that school was 281. Out of it, Tirunamala HOD is 181. Other HOD nearby Vilupuram and Vellur and Ranipet was 100 students. Incidents. Out of it, 104 were symptomatic. Asymptomatic 69 and not identified 8. Not identified means school they were registered as 300 children, but on inspection only 281 were there. Then descriptive data collection and analysis. Age-wise distribution, first thing was 6 to 10 years, 5 children was there, 11 to 14 years, 87 children, 14 years, more than 14 years, 12 students. Treatment, in the OP we are given 24 students, and IP 42, and field surveillance 38. The occurrence of the outbreak is found to be caused by the intake of chicken and contamination of water and unhygienic practice of the children. Hypothesis that was occurrence of outbreak is found to be caused by the intake of chicken, contamination of water, same thing. Then water sample was collected. Water sample and food sample, unfortunately food sample couldn't be, we couldn't collect it because it was not there. Stool sample was collected on the 24/6. This was a water sample collected. Then control method, what was we have a frequent field inspection and review, and inspection at the ward and chlorination checking. School screening. Then we have formed out of 180 children, we have formed a team. Each 10 children we have given a responsibility for the each VHN and ANs. These are some field activities. This was the report of the outbreak. That outbreak was reported on 19/6 and last case was reported on the 24/6. And the location of the tribal resident school, 281 students. Out of it, 104 were affected. And the sample was collected was the borewell water. That was positive with the E. coli and Shigella. Even it started on the 19th and it was last case was on the 25th. Totally 202 people were, manpower was involved in that outbreak control business. Then challenges faced was that remote location, assessing the affected area has been very challenging. Limited infrastructure, school and surrounding were lacking adequate facilities, infrastructure, community engagement, gaining trust and cooperation from the local community. Educational outbreak, conducting effective health education and hygiene promotion was the challenge. Data collection reporting, gathering accurate data on the outbreak, including the case numbers, that was in the even in the hilly area it was difficult. Cultural center, then respecting and navigating cultural beliefs, overcoming that was the challenge. Then long-term support, ensuring sustained support recovery and preventive measures beyond the immediate crisis. This was some paper news was given there. Then here in the outbreak level, what we found was stool sample was not there. We couldn't collect the food sample. And local on the school was the second time outbreak was there. And the school level 280 children were staying, but on the school படிக்கிற ஒரே ஹால்ல 20 to 20 அந்த ஸ்கூல் அந்த இடத்துலயே வந்து அவங்க அங்கேயே ஸ்கூல்ல இருப்பாங்க. அதே இடத்துல சேர் பெஞ்சஸ் வந்து ரிமூவ் பண்ணிட்டு நைட் அங்கேயே படுத்துக்குவாங்க. ஓவர் ஃபுடிங் வாஸ் தேர். ஸோ இப்போ வந்து ஆஃப்டர் த இன்டர்ஃபரன்ஸ் ஆஃப் இந்த அவுட் பிரேக் கலெக்டர் வந்து அந்த இடத்த சேஞ்ச் பண்ணி அதுக்கப்புறமா இப்போ நவ் இட் இஸ் ஷிஃப்ட் டு அதர் பிளேஸ். ஓகே, தேங்க்யூ சார்.
Thank you, sir. We welcome DHO Sivagangai, Dr. Vijay Chandran, sir, to share his experiences. கலை நிகழ்ச்சிகள் 7 மணிக்கு ஆரம்பமாக இருப்பதால் தங்களுடைய பாடல்களை அனுப்பி வைக்குமாறு அன்புடன் கேட்டுக்கொள்கிறோம்.
Good evening, one and all. I thank respected DPHR for giving this opportunity to present over the experience about adolescent anemia program in Sivagangai. I'm going to present about the prevalence of anemia among the school children over the period of 1 year were diagnosed as anemia and follow-up against. Next. So, adolescence is a unique stage of human development and an important for foundation stone for the good health. So, everybody knows about prevalence of anemia among both school-going children and pregnant mother. So, it's everybody's role to combat the anemia among all the pregnant and the adolescent children. The study is about the prevalence of anemia among the school-going adolescent children. With respect to the adolescent health programs, it's been health camps conducted in Sivagangai district. The period of study is from June 23 to March 24. It's a record-based analysis of the data available in the DHO of Sivagangai. Total of 46,698 students who are studying from 6th to 12th standard were taken into of the government and government-aided schools were taken into account. As we all know, the prevalence of anemia is about 44% in the total study population of the total 46,698 in Sivagangai. So gender-wise prevalence of adolescent anemia, of those diagnosed 20,662 anemia, females are more, female adolescent children having more anemia, that is about 49.5%, with respect, whereas the male component is around 37.5%. The categorization of adolescent anemia where mild contributes for around 60%, 62%, and while the 37% is moderate and 0.73% is considered very severe. The gender-based categorization, as always knows, always the female component is more affected. Both the mild, moderate and severe anemia are similar between both sexes, except for the moderate anemia in female adolescents shows higher prevalence. With respect to the urban and rural differentiation, the crude analysis shows the rural adolescents having more anemia than the urban adolescents, and where the population-based analysis shows higher prevalence in the urban population also. So, resident-wise, rural population having moderate anemia is 17.3%, where the urban population having mild anemia is 40.3%. The prevalence of mild anemia is more in urban adolescent population, but moderate anemia is more in the rural population. Whereas in the rural classification, the female component is affected more, having 50% of the total affected population, where in urban, male component is having more anemic when compared to the female population. These are the block-wise reduction of the anemia among the school-going children, whereas that two blocks were Manamadure and Kannangudi block having more number of anemia affected children. In respect to urban, the Sanjay urban PHC belong to the Karaikudi Corporation and the Devakotai urban PHC. So urban population also plays a major role for students having anemia. Of the 20,662 students who are found anemia, mild anemia accounts for only 62%, 37 exhibit moderate and 0.73% classical severe anemia. Higher moderate anemia is more in females, but blocks like Kannangudi and which are more Kannangudi and Manamadure place having a rural population, and Sanjay belongs to the Karaikudi urban having a highest anemia prevalence. So recommendation, as all know, that there should be a collaborative effort between all the stakeholders of health with respect to health, school education and ICDS also. This one is when in Sivagangai district we conducted an intervention study for anemia control with the help of the district Siddha medical team. a total of 125 students who were school-going children for exam-appearing students were identified, and the sustainability of hemoglobin estimation was done, and the intervention was done for 3 months from December 1st of 2023. So this was the schedule. Pre-hemoglobin was done at November. Intervention started at December 1st by giving the supplementary nutrition by the Siddha medicines. Those kids were not given any iron folic acid from our side, only the Indian system of medicine they were taking. The first month intervention hemoglobin estimation was done, second month, third month was done, then intervention stopped, and then again followed by 3 months their final intervention was done. So these are the 3 Siddha Indian system of medicine which were given to the medicine. Eladi tablets, Karuvepilai podi for regular food habits, and Madalai Manapagu 10 ml which was taken with milk and water. So this was an exclusive preparation for the school children. With the help of this district collector and Siddha medical team, we prepared and distributed to the kids in the regular interval. So surprisingly, the mean hemoglobin which was found in the pre-hemoglobin stage was improving on the 4th intervention by significantly there is an increase in the value. So on analysis post-hoc for a pre-hemoglobin, there is a significant value of improving hemoglobin among the students who are identified. The main difference between the pre-hemoglobin and hemoglobin is significant, statistically significant. The main difference between the group, except for hemoglobin 1 and 2 and hemoglobin 1 and 3, all those values are clinically significant. So it is the time of our department to intervene all the inter-system of medicine and our allopathic medicine to improve at any ways the among hemoglobin status of the children, thereby preventing their thereby improving their nutritional status and preventing the further maternal deaths. Thank you DPH for giving this opportunity.
Thank you, sir. So finally, we have come to the end of today's session. I kindly request everyone to maintain silence for another 5 minutes because this is the last topic for the day. We are pleased to invite City Health Officer Madurai, Dr. Vinod Kumar, to share his experience.
Good evening to one and all present here. So I am going to present about practicing One Health and urban local body as City Health Officer. Next slide, please. Okay, One Health. What is One Health? See, it is an integrated and unifying approach to achieve a balance and optimization in human health, animal health and environmental health. Why we are taking these 3 issues means, these 3 are very closely interlinked, and we also studied a concept called as epidemiological triad. So, these 3 are very closely related to determine the human health. So, integrating these 3 factors, it's a core concept of One Health. So, when did it get conceptualized? After the incidence of COVID-19 outbreak, this concept is widely spoken in the international forum. And how does it going to work? So the concept behind One Health is the 3 sectors: public health, human health, veterinary health department and environmental sectors should work hand in hand to ensure the balance between the health of all the life in the society. So what is the objective of human health? The objective of the human health is to ensure food and water safety, to ensure the nutrition of the community, to control the zoonotic diseases and the pollution related issues. So in this context, I would like to explain about the organogram at my urban local body, though it may not be the same in all the urban local bodies. The 2 million plus cities will have a similar structure of organogram. So for example, in urban local body, the Department of Health is headed by City Health Officer, and it has two different arms. The one is the urban primary health centers, which we have medical officers, MCHO, and other stakeholders. The another major arm has different stakeholders. For example, I have a veterinary officer in my department. I have a vital statistician who look after the vital events, registration of vital events, and I have an entomologist who look after the control of vectors and thereby preventing diseases. And I have a sanitary officer who look after the environmental issues. So the role of health officer in an ULB. With regard to human health, what does the health officer does? The basic of public health is to know about our denominator. So the enumeration of the community through the family register and by registering the vital events by the with the Birth and Death Act. So I get analysis of morbidity and mortality pattern of my community. With the available data, I will plan about the impending outbreaks or the health related events and the ways to prevent incidence of diseases. Some of the interventions I can do with the organogram available with me is screening and treatment of diseases, vector control, ensuring the nutrition of the community, and HR complicating pregnancy, early identification and referral and intervention, and information education community to the community so that equipping the community to prevent diseases. And in terms of secondary prevention, I give NCD drugs, early screening and provision of NCD drugs, and all the UPHC services. With regard to animal health, with the veterinary department, my veterinarian will collect the surveillance data of all the animal diseases, and with enormous manpower, we are giving health intervention to prevent any outbreak of the veterinary diseases. And as an urban local body authority, I have the enumeration of the animal population, especially the stray cattle and stray dogs, and thereby I am taking health intervention to prevent diseases. And it is a very serious problem at the community, the human-animal conflict, especially with the stray dogs, and it is the urban local body, the city health officer who is intervening the problem. With regard to environmental health, actually, with regard to environmental health, I monitor, the city health officer monitor the implementation of solid waste management and septic waste management in the urban local body with the sanitary officer and sanitary inspectors working in the urban local body. And the most important thing is abatement of nuisance. The Tamil Nadu Public Health Act empowers the health officer to abate the nuisance, and it also empowers the health officer, the Tamil Nadu Urban Local Bodies Act empowers the health officer to give the trade license. That is, the health officer is the competent authority to decide whether a trade can occur at a community or not. In a residential area, the health officer have the powers to stop any trade activity which tends to affect the health of the community. So, the nature of the duties of health officer, it covers human health, animal health and environmental health by virtue of its post. So, to conclude, this One Health concept has been in the international forum since a decade, but I would like to say that since 1921, the Department of Public Health and Preventive Medicine is practicing One Health in the urban local body with the Tamil Nadu Public Health Service officers. So this century-old concept is now spoken in the international level in the form of One Health. So in this scenario, I kindly request my director, if there is any new initiatives in the urban, in the One Health, so it can be implemented in the urban local body, which has a effective, robust intersectoral coordination between all the three sectors, because all the three sectors are report to the city health officer from the Tamil Nadu Public Health Service. And beyond, to conclude, sir, I kindly request that we as a Tamil Nadu Public Health Service officers, we should look beyond the UPHCs and we should have a comprehensive One Health approach, sir. Thank you, sir. Thanks for this opportunity.
Thank you, sir. I take a moment to thank everyone for your kind cooperation throughout the sessions and for successfully completing the first day of DPHICON2024 conference. And I'm also looking forward for your cooperation tomorrow also. Thank you.
DPHICON 2024க்கான ஹோட்டல் அறைகள் நாளை மதியம் வரை மட்டுமே பதிவு செய்யப்பட்டுள்ளதால் அறைகளில் தங்கியிருப்பவர்கள் நாளை காலை வரும்போதே அறைகளை காலி செய்து வருமாறு அன்புடன் கேட்டுக்கொள்ளப்படுகிறார்கள். நாளை காலை அறிவியல் அமர்வுகள் சரியாக 9 மணிக்கு ஆரம்பமாகும். அனைவரும் காலை 9 மணிக்கு அவைக்கு வர கேட்டுக்கொள்ளப்படுகிறார்கள். ஃபோட்டோ டவுன்லோட் செய்யவும், கனெக்ஷன் கேமில் பங்கு பெறவும், தகுந்த QR கோடுகளை ஸ்கேன் செய்யவும். தங்களது DPHICON பையில் டாக்டர் சாரதா பரமேஸ்வரன் அவர்களது பணப்பை காணப்பட்டால் விழா அமைப்பாளர்களை அணுகி மீண்டும் திரும்ப அளிக்க கேட்டுக்கொள்ளப்படுகிறார்கள். நன்றி. கலை நிகழ்ச்சிகள் தொடங்க இருக்கின்றன. DMCHO அம்பிகா மேம் மேடைக்கு அருகில் வரவும். கலை நிகழ்ச்சிகள் தொடங்குகின்றன. முதலாவதாக மயிலாடுதுறையைச் சார்ந்த சௌந்தர்யா அவர்களின் பரதநாட்டியம். கலை நிகழ்ச்சிகளில் முதலாவதாக மயிலாடுதுறை சௌந்தர்யா அவர்களின் பரதநாட்டியம்.
நீரானவா நிலமானவா விண்ணானவா காற்றானவா இறைவா ஒளியானவா நீர்தானே உயிர்க்கெல்லாம் முதலானவன் நீர்தானே உயிர்க்கெல்லாம் முதலானவன் நான் தேடும் உலகெல்லாம் உறவானவன் ஜெகம் கூடி ஜதி பாடும் இசையானவன் ஜெகம் கூடி ஜதி பாடும் இசையானவன் என்னை நாடும் தொடர்கின்ற நிழலானவன் என்னை நாடும் தொடர்கின்ற நிழலானவன் நீர்தானே எல்லாம் முதலானவன் இறைவா நதியில் நீராகி நிலவெல்லாம் மொழியாகி பனியில் துளியாகும் இறையானவா நதியில் நீராகி நிலவெல்லாம் மொழியாகி பனியில் துளியாகும் இறையானவா புவியில் திறனாகி இதெல்லாம் கருவாகி காற்றில் அசைந்தாடும் நிறைவானவா புவியில் திறனாகி உயிரெல்லாம் கருவாகி காற்றில் அசைந்தாடும் நிறைவானவா ஸ்வரம் தேடியே உனை பாடினே நீதம் கூடியே மகிழ்ந்தாடினே சலங்கை ஒலியாக சதிராடும் மயிலாக ஜதியில் ஒயிலாக நடமாடினே சலங்கை ஒலியாக சதிராடும் மயிலாக ஜதியில் ஒயிலாக நடமாடினே சபையில் இனிதாக இடம் தேடும் முகமாக இதயம் கலந்தோரை புகழ்ந்தாடினே சபையில் இனிதாக இடம் தேடும் முகமாக இதயம் கலந்தோரை புகழ்ந்தாடினே ததபப்ப சசரி நினி ததபப்பரிதவா சசரி நினி நிரி சசரி காமரி கசா நீர்தானே உயிர்க்கெல்லாம் முதலானவன் நான் தேடும் உலகெல்லாம் உறவானவன் ஜெகம் கூடி ஜதி பாடும் இசையானவன் ஜெகம் கூடி ஜதி பாடும் இசையானவன் என்னை நாடும் தொடர்கின்ற நிழலானவன் என்னை நாடும் தொடர்கின்ற நிழலானவன் நீர்தானே உயிர்க்கெல்லாம் முதலானவன் இறைவா
அருமையான தொடக்கம். நன்றி சௌந்தர்யா. இரண்டாவதாக திருவரங்குளம் ஏஎன்எம் ட்ரைனிங் பள்ளி மாணவர்களின் நிகழ்ச்சி. திருவரங்குளம் ஏஎன்எம் ட்ரைனிங் பள்ளி மாணவிகளின் நடனம்.
Da மொழியாள் நிலாவென சிரிக்கும் மலர் கொடியாள் நிலாவென சிரிக்கும் மலர் கொடியாள் பைங்கனி இதழில் பழரட்டும் கருவாள் பருகிட தலை குனிவாள் எந்தமிழ்தேன் மொழியாள் நிலாவென சிரிக்கும் மலர் கொடியாள் நிலாவென சிரிக்கும் மலர் கொடியாள் பைங்கனி இதழில் பழரட்டும்